OHS Executive Director, Deirdre Gifford. Deirdre.
Thank you, Commissioner, very much. And good morning, everyone. I am Deirdre Gifford, the Executive Director of the Office of Health Strategy. I want to welcome everyone to this part 2 of the Healthcare Cost Driver Forum. Today's session, as you heard the Commissioner say, is focused on solutions. I'm joined by my colleague, Kelly Cinco-Stuber from OHS and from the terrific OHS team in the peanut gallery. And I'm grateful to them and to my predecessor, Vicki Veltri at OHS, for all the work, not only in preparing for today, but in all of the work that OHS is doing around solutions to the high cost of healthcare. So I've just a couple of slides to ground us a little bit in the conversation today. I'll talk while we get rid of that message. This is a depiction of the work of the Office of Healthcare Strategy. And the reason we wanted to include this slide this morning was because whenever we talk about affordability and cost, we want to make sure that everybody knows we're also thinking about quality, equity, and keeping the patient at the center of our conversations. So although we're talking about cost drivers today, we're always thinking about those in the context of the recipients of the healthcare that we all provide. Next slide, please. This is just a reminder about the affordability issue that's at the core of our conversations today. Healthcare remains unaffordable to many with and without health insurance. And this slide just depicts the increase in income at the bottom in Connecticut and the increase in total premiums and out-of-pocket costs in the top 2 lines. So you can see that income is not keeping pace with the increases that we're seeing in out-of-pocket costs and premiums, which is making it harder and harder for individuals to access the care that they need. Next slide. Yesterday, I had the opportunity to be with Governor Lamont when he announced a $20 million proposal to relieve medical debt here in Connecticut. And it's unfortunate that we need to be thinking about the relief of medical debt. But the fact of the matter is that many people, a growing number of people here in our state are unable to afford the cost of care. This is a recent local survey showing that 51% of people with commercial coverage went without care at some point in the prior 12 months because of cost. Nationally, Gallup released a poll a couple of weeks ago, and that number was around 40% of people in the country reporting that they are avoiding care because of cost. And affordability is even more problematic for people of color and people with healthcare issues or disabilities. Next slide. So today we're here to talk about solutions, and in order to think about what are some of our most effective solutions going to be, we at OHS have been looking at the drivers of healthcare cost increases. I'm not sure that you can see the small print on this slide, but basically it shows that what we've seen in our data here locally, and this is consistent with what we see around the country, 2 primary drivers of the growth in healthcare costs are hospital spending and the cost of drugs, both inpatient and outpatient. And hospital spending here is divided into both inpatient and outpatient spending, and both have been contributing to the rapid increase in healthcare costs. So that's a little bit of background to keep us grounded. I want to say thank you to the Office of the Health Advocate and to colleagues at CID for helping to organize us. And in particular, I want to say thank you to all of you who have agreed to come and help us talk about solutions. The governor has been saying, and I think this is something for us to keep in mind, that in order to tackle this program, everyone needs to be part of the, tackle this problem. Everyone needs to be part of the solution. That includes health insurers, but not just health insurers. That includes hospitals and providers, but not just them. That includes employers, both small and large. That includes state agencies, our colleagues in the legislature, and the consumers of healthcare. Basically, and anyone who's a part of the healthcare system, which is pretty much all of us, need to be part of the solution. So I'm very much looking forward to the conversations today. We're hopeful that we'll end the day with a concrete set of ideas that we can take forward and turn into policy and eventually bring down the rising cost of healthcare. Thank you.
Thank you, Director Gifford. My name is Ted Doolittle, and I am the state healthcare advocate. And for those of you who haven't heard of the healthcare advocate, we have a team of nurses, paralegals, and others who help people who are struggling with health coverage issues. It can be Medicare or Husky or commercial insurance. If you've got a claim denial or something of that nature, another difficulty, we have folks who are standing by to help you. So please remember the Office of the Healthcare Advocate. It's my pleasure today to be co-hosting this with Commissioner Mays of the Insurance Department and Director Gifford of OHS. And I want to thank the staff, particularly Justin Kaiser, Jim Carson, and Adam Prizio, who are here today for helping set this up. Thank you very much. I do just have just a few slides to recap what we learned in the first session. This is a solution session. We kind of set the landscape last time. And if we could have the next slide, please. So we're just going to do a recap. First, we learned that the U.S. and none of these data that I'm presenting, I believe, are controversial at all. So the U.S. spends more on healthcare than other wealthy nations. Go ahead with this next slide. How much more? Like twice as much more. These are 2020 prices. You see the per capita cost in the United States is verging on $12,000 in 2020, and the OECD, the wealthy nation, the wealthy and high quality healthcare nation average is about half of that. Next slide. We know that U.S. healthcare is excellent in some areas, but overall it's not better quality than other nations. That's not to say we don't have a good healthcare system. It's to say that many other wealthy nations also have high quality health systems. Next slide. This is a famous slide. You'll see it later, actually, in another presentation. Along the right axis is high cost. Along the up and down axis is healthcare system quality, which includes a variety of measures, including equity. This is from the Commonwealth Fund. And you see that the U.S. stands alone in the high price arena. And unfortunately, it was ranked lower, particularly because of some of our health equity issues. So we're not getting better healthcare and paying twice as much for it. That might be acceptable, but the situation we're in now is not. Next slide, please. The U.S. does not use more healthcare. This is something that is really hard for people to grapple with. Next slide. This shows hospital stays, and you see that the U.S. is ahead of a couple of countries, or down near the bottom of the pack. Next slide. This is doctor visits. Again, a couple of countries below us, but kind of down near the bottom of the pack. We're not going to the doctor more. We're not going to the hospital more. And I could go on with a lot of other slides in other care areas. I'm not going to, but this is the picture. We don't use more healthcare. Next slide. Why is it more expensive? U.S. healthcare is expensive because the underlying prices are higher. Next slide. This is the price of an appendectomy in the U.S. in 2014, about $15,000. We see some other high quality healthcare nations, wealthy nations, United Kingdom at about half the cost, Australia down near something like 1/3 of the cost, maybe even less. Next slide. This, I'll explain it. The red dots on this is a list of inpatient and outpatient procedures. I showed this slide last time. The United States' price for every procedure is 100%. And that's why there's a line of red dots down on the right. Those are the U.S. prices at 100% for all of these 14 procedures. The other dots are other, again, high quality, wealthy nations, their cost for the similar procedure. Not only the appendectomy that was on the previous slide, but 13 other procedures as well. I've marked 50% with the blue line, and you see that most of the dots are even to the left of that blue line. So that means most of the dots are paying procedure prices that are half. So this is the situation that we're dealing with. This is controversial. Next slide, please. If we want more affordable healthcare, we must find policy solutions that address underlying medical prices. That's why, and most, the overwhelming majority of the presentations that you hear today will address prices. There's a lot that can be done. Where the reforms don't address prices, perhaps they're a good reform. For instance, prior authorization reform is good. It might not have an impact on prices. Today, we're trying to focus on cost, which, as we learned last time, cost is a function mostly of the underlying price. So that concludes my remarks. I just wanted to kind of tee up what we learned last time so that we can dig into the solutions. So I will go ahead and introduce the next panel. It's terrific to have Sophia Tripoli of Families USA here. She'll be our first speaker. Then we're going to move on to Kelly Ryan from the pharma industry. Sam Hallemeyer is here with the Pharmaceutical Benefit Managers, and Sam can tell you what that stands for, PBM. We have several hospital and other providers. Kurt Barwis, Bristol Hospital CEO, Greg Shangold from the Connecticut State Medical Society, and James Carden from Hartford Healthcare. And thank you for participating, Hartford Healthcare. We appreciate seeing you here. The carriers are going to be spoken for by Susan Halpin. And with that, if Sophia is online, she's participating virtually with Families USA, a terrific advocacy and consumer group that my office works with closely, based out of DC. Sophia, if you're there, go ahead.
Good morning, everybody. Thank you so much for having me. My name is Sophia Tripoli, and I'm the director of our Center for Affordable Whole Person Care at Families USA. And Ted, just a quick question. I'm happy to share my screen for a few slides, or?
Yeah, that's great, Sophia. Go ahead.
Okay. Sorry, folks. 1 second while I just get those up. Okay, hopefully folks can see that. Great. Families USA is a leading national voice for healthcare consumers. We work really hard to make sure that everybody has high quality, affordable healthcare and improved health for all. And we advance our mission through public policy analysis, advocacy, and working with partners to make sure we have a patient and community-centered approach. We've been around for about 40 years. We operate on the national, state, and community level, and we work across 4 key areas: health equity, healthcare value, healthcare coverage, and people's experience. I'm going to move through these quickly because
Sophia,
yes.
move on. We do see the sort of view that has the next slides.
Oh, okay.
I don't know if you're able to just move to the slideshow.
Let's try this. That's the same view. Maybe what I'll do is minimize this. How does that work? Ted, does that work okay?
That's better. Thanks, Sophia.
Sure. So I will move through this pretty quickly because as we just heard from Ted and Director Gifford, we really are facing an affordability crisis in this country around healthcare. 100 million Americans facing medical debt, nearly half not seeing a doctor when they need to because of the costs, nearly a third saying that the cost of care interfering with their basic needs like food and housing, putting heat on, and 3/4 of the public saying that the cost of healthcare, they give it a grade D or an F. So we really are facing a crisis for people. It's occurring at the federal level as well. Here you see that the Congressional Budget Office projects that our healthcare spending will surpass all other non-interest spending by 2040. We now spend nearly 20% of our GDP on healthcare. And what's playing out at the federal level is also playing out for states. Here, the Centers for Medicare and Medicaid projecting, saying that Medicaid spending is outpacing growth in state tax revenue, and that Medicaid spending for the first time will exceed $1 trillion nationally in 2028. And for people, for families, the problem has been building and mounting for decades, where you see premium increases continuing to outpace the growth in workers' earnings and overall inflation. And what this means for people and consumers and families is that healthcare continues to crowd out their family budgets. And the more that they're spending on healthcare, the less they have available to spend on paying utilities, buying food, buying a car, putting a down payment on a house, sending their kids to college. We are creating a real financial crisis for our nation's families due to uncontrolled healthcare costs. And as we just heard, for all the spending, our quality is lagging. We have much worse health outcomes on some key indicators, including life expectancy, maternal mortality, infant mortality, and the data are super, super clear on health equity, that good health and healthcare are not equally available to all in our nation, particularly for racial and ethnic minorities, where we see much higher rates of chronic diseases for non-Hispanic Blacks than for their white counterparts, high rates of infant mortality, high rates of maternal mortality. And the good news is that there is, in fact, some energy solidifying around affordability issues at the national level and across states. And part of this energy, this outrage around unaffordable care, is what got us a national ban on surprise medical bills. It's what got prescription drug pricing reform done at the end of last year. And now folks are starting to become more aware of how irrational hospital prices become and the role of pricing in driving up health system costs and unaffordable care for our nation's families. And as Ted mentioned, the reason we have much higher costs of care in this country compared to other places is because of our prices. Prices are high, they're rising, they're variable, and they're really driven by a growing trend over the last couple of decades of industry consolidation, particularly among the hospital sector, but not only the hospital sector, where we've seen hospital prices since 2015 increasing by more than 30%, accounting for a third of healthcare spending, growing 4 times faster than workers' paychecks. And prices in the commercial market from the hospital sector are on average 2.5 times what Medicare pays for the same inpatient and outpatient services. That's that chart that Dr. Gifford went over about hospital inpatient, outpatient prices. And this really has been a fundamental shift in the role of hospitals in our economy over the last 60 years. And they've shifted from these charitable institutions funded by donations, staffed by volunteers, to these mega corporate entities. And the business interests, the business model of the hospital sector has really become malaligned with the interests of making sure that people are healthy and that we have financial security when we need healthcare services. And that really is generating high volumes of tests and procedures through fee-for-service payment and generating the highest possible fees by buying up global competition in order to price gouge.
So
now, as I mentioned, yes.
3-minute warning, 3 minutes. Thank you.
Great. I won't go over this. I'm going to jump right to solutions and just spend my last couple minutes talking about solutions. On the next slide, hopefully. There we go. There are several buckets of solutions. Connecticut already has an all-player claims database, which is excellent, but there are other things the state can do to take on transparency, including codifying some of the federal price transparency regulations into state statute with some teeth. This really helps to unveil how irrational prices have become and then be able to tune into market dynamics to make more informed decisions about where the costs are growing. So price transparency. The next bucket around consolidation, 2 really important parts here. One is around banning anti-competitive contract terms. These are terms in consolidated markets where large providers often have the upper hand in contract negotiations to build networks, set prices, direct referrals. And the result of many of these contracts include terms that limit higher quality, lower cost care, such as anti-tiering, anti-steering clauses, and all or nothing clauses. So a ban on anti-competitive contracting practices helps to incentivize higher quality, lower cost care, and also improve competition in markets that might be dominated by certain firms. The other point to mention here on consolidation is expanding some power to the state's attorney general or a health cost commission, that they can have overarching authority on cost, and they can place conditions and block potential harmful consolidation of healthcare providers in their states. So this basically means that in order to consolidate or for a merger or transaction to be finalized, the attorney general gets a heads up, and there's an administrative process to go through to be able to review it and decide that it's actually appropriate, not going to have negative consequences in the markets. I won't spend time talking about healthcare cost benchmarks because I know Connecticut already has one, but we'll talk very briefly about another way to sort of get at increased spending around affordability standards. Here, this is an option where the insurance commissioner could have the authority to enforce some affordability standards through the insurance rate review process. Neighboring Rhode Island has a similar process set up where the insurance commissioner can constrain commercial healthcare prices, reimbursement growth of hospital prices to the rate of inflation plus 1%. The last bucket around really getting after high prices at the provider level, the first is taking on facility fees. These are a major cost driver in the healthcare system that result from consolidation. And these fees can be tacked on after a big system can buy up a physician practice, rebrand them as outpatient department, and they can tack on a facility fee, even if a service can be performed in a physician's office. So prohibiting facility fees or putting some limits on facility fees can help to lower costs and actually de-incentivize consolidation of independent providers in the healthcare market. The next one is around setting out-of-network payment limits. Here, the idea is that you can set a limit on a network rate as a way to incentivize a lower in-network rate. So there's a common dynamic playing out where markets across the country, where a large health system with a lot of power can demand higher reimbursement rates. And when the payer says, I might not want to pay that, or wants to, maybe doesn't immediately agree, the system can threaten to terminate the contract and go out of network, which drives up overall costs. So placing a limit on an out-of-network rate creates a financial incentive to stay in network for larger systems and to potentially negotiate a more rational in-network rate. The last area to highlight is around all-payer models and global budgets. Maryland is a prime example. Folks probably very familiar. This is really the idea that in most states, hospitals negotiate a payment rate with each payer, but under this type of model, a cost commission can establish uniform rates for all hospital services for multiple players. One of the benefits of this type of model, in addition to constraining the growth of hospital costs, is that it can also align quality and equity goals across payers. Maryland has had a lot of iterations of this model from 2014. There's a lot of data on that, but the model, and now a new model of total cost of care being implemented. But ultimately, the model has been mostly successful in constraining healthcare costs and lowering costs for all patients, particularly those with high cost, high needs. That I think wraps, and I'm probably close to time. Thank you very much, and look forward to answering any questions.
Wonderful, Sophia. Yeah, we'd appreciate it if you'd hang around for questions. I will note that all the presentations will be available on the Connecticut Insurance Department website soon. And I also want to note, in the presence of the room, we are graced by the presence of Representative Berry and Senator Huang. Thank you so much for your interest and for being here. With that, we'll keep moving right along and go to the Pharmaceutical Care Management Association, represented by Sam Hallemeyer. Sam, welcome, and go ahead.
Thank you, Ted. Good morning, everyone. My name is Sam Hallemeyer with PCMA, which is, again, Pharmaceutical Care Management Association. We are the National Trade Association for America's Pharmacy Benefit Managers, PBMs. PBMs administer prescription drug plans for more than 275 million Americans. Sorry, I should have waited for the slide deck to come up.
Yeah, thanks for your flexibility. I think I did take you out of order, Sam. I want you to keep going,
okay.
But I apologize to Kelly for doing that. But we'll get to you next, Kelly.
One moment, everyone. We're just having some slight technical difficulties.
All right, thank you. Next slide, please. So building toward a more accessible and affordable healthcare future. So pharmacy benefit companies secure lower prescription drug costs, enable better health outcomes for patients, and offer employers and health insurance plan sponsors the choices and guidance they need. I want to be forward on the onset that PBMs do not set the price of prescription drugs. In fact, pharmacy benefit companies exist to lower the cost of prescription drugs. Plans hire us to lower the prescription drug costs for their plans and look to solutions to lower their healthcare costs. So next slide, please. So I'm going to focus my solutions on three three key areas. The first one is going to be by promoting competition. The next is going to be working and supporting clinicians with tools and data to serve their patients optimally. And then finally, enhance patient outcomes and improve the patient experience. Next slide, please. So the first solution deals with promoting competition. And the best way we think to do this is by promoting generic and biosimilar competition. So as evidenced by the impact of generic drugs, the most effective way to reduce prescription drug costs is to increase competition in the marketplace. Similarly, when biosimilars will enter the market, that also will increase competition as well. The solution that I recommend is protecting PBM tools to promote competition. Those two things are going to be prior authorization and step therapy. So prior authorization is required for drugs with a high risk of abuse, will have significant side effects, a high cost, or various other factors. And then step therapy ensures that prescribers consider the lowest, medically appropriate therapeutic alternatives, typically generics, before starting a patient on a course of a higher cost drug, such as a brand name drug. Prior authorization can generate savings of up to 50% for targeted drugs. And then step therapy has demonstrated savings of more than 10%. If Connecticut implements and prohibits prior authorization of step therapy, we project that fully insured employers and commercial health plan health costs would increase by $627 million over the next 10 years. That's a big number. Every plan does have a process to bypass this prior authorization and step therapy process. A medical provider can work with the insurance company to provide medical documentation on why a patient shouldn't be on that drug. And this is a process to safeguard against the use of prior auth and step therapy being too restrictive. So again, there are ways to bypass prior authorization and step therapy by physicians. Next slide, please. The next way to promote competition is to promote pharmacy networks. Where a patient acquires a drug can impact costs significantly. We're concerned that policies that restrict plans being able to build pharmacy networks will drive up the cost, while well-managed pharmacy networks offer savings to both plan sponsors and patients. So the solutions I recommend are taking a look at a group called Pharmacy Services Administrative Organizations. PSAOs is their acronym. Most independent pharmacies work with large PSAOs to negotiate favorable contracts with pharmacy benefit companies. By leveraging the power of the large PSAOs to negotiate with PBMs on their behalf, independent pharmacies can secure favorable contract terms, and on average, higher reimbursements than drug retail chain stores. The independent pharmacy in Connecticut is actually growing. The independent pharmacy numbers are growing in Connecticut. From 2011 to 2021, the numbers grew from 138 independent pharmacies to 156, which we found to be 13% increase. Next, we need health plan sponsors to provide the ability to design these networks and continue to grow to save on costs. Without pharmacy benefit companies, pharmacy network interference to make affordable choices for their participants. Health plan sponsors strive to create accessible, affordable benefits that meet the needs of the populations they cover. And we're concerned that any mandates that could increase the cost and decrease quality among pharmacy networks. Another thing that pharmacy benefit companies like to use is protect and promote the use of mail order. So mail order is a service PBMs use that allow patients to have their prescription shipped to their front door, to their preferred location, and typically result in lower out-of-pocket costs. Next slide, please. Next, pharmacy benefit companies want to work with clinicians and providers on tools and data to serve patients optimally. Things such as real-time benefit tools, electronic prior authorization, and electronic prescribing reduce administrative burdens and speed access, enabling clinicians to allocate more time to direct patient care. This goes back to the first solution I was talking about with prior authorization and step therapy. These tools will help out speed up those administrative burdens that we've heard from providers, even at the legislature here in Connecticut. So PBMs strongly support the use of real-time benefit tools to increase transparency. A real-time benefit tool, for example, is when a patient is in with their doctor, they can look at their laptop and look at the prices and drugs available for that patient. And that patient can work with their provider to decide what is the appropriate drug and cost that they can use. And if there are any step therapy or prior authorization processes, the provider can start it right there in the doctor's office with the patient before the patient even goes to the pharmacy to get denied. Real-time benefit tools lead to lower costs, out-of-pocket costs, with the largest savings typically around 40%, because the doctor is going to recommend that the patient start at a generic based on the list price. And then going on to the next solution is requiring the use of electronic prior authorization will streamline the process for patients and healthcare providers. In other words, this is moving away from faxes. Electronic prior authorization, we think, will speed up the process here and to move away from fax machines. And then providing incentives for real-time benefit tools, alternative payment models to include prescribers eligible to share any potential plan savings that they got by selecting lower cost alternatives from the list price. Yes. Okay, thank you. Next slide, please. Continue to work with physicians. Another solution we recommend is allowing pharmacists to practice at the top of their license. Pharmacists are skilled professionals and healthcare providers, and policymakers and regulators should enact legislation enabling pharmacists, where appropriate, to perform diagnostic testing, prescribe indicated medication, and administer vaccines to lower our costs and expand access to care. Another solution is reliable sources, including government entities, academia, and clinician groups, to increase healthcare literacy and promote uptake of biosimilars, which again will increase competition and generate savings. Next slide, please. Finally, enhance patient outcomes and improve the patient experience. PBMs serve people along with the full spectrum of life circumstances and are best able to meet a patient's needs when pharmacy benefit tools and offerings are fully available. And solutions I recommend are supporting the use and promoting the use of specialty pharmacies. Many PBMs own or partner with specialty pharmacies to dispense drugs with high prices and complex handling requirements. And we typically see savings between 11% and 45% on specialty drugs when they go through a PBM specialty pharmacy. And again, I already talked about the promotion of home delivery, but home delivery removes certain barriers connected to social determinants of health, such as lack of transportation, which will enable access for patients. And again, promote the use of real-time benefit tools within the provider's office and a patient so they can see the cost of their medications. Next slide, please. Next, I have solutions that not necessarily might be able to be done at the state level, but recommendations at the federal level. The first one is stop patent abuse by drug manufacturers. To increase competition and lower patient and plan sponsor costs, it is imperative that policymakers end anti-competitive tactics used by drug companies and then ensure drugs can compete fairly. So big drug companies block competitors from coming to the market through a variety of anti-competitive tactics used to determine the market in their favor. An example of this is a drug manufacturer and a drug called Humira. This has generated $114 billion in revenue for that drug manufacturer. This drug came out in 2016, and the list price has gone up 60% since that drug was introduced. It is now over $80,000 a year for this drug. U.S. Senator Richard Blumenthal here in Connecticut actually introduced the Affordable Prescriptions for Patients Act, which prevents drug manufacturers' anti-competitive use of patents to block generics and biosimilars from entering the market. The Insurance and Real Estate Committee also raised a concept looking to ban pay for delay as well. Next slide, please. So in summary, the three solutions I recommend deal with increasing competition, encouraging the use of technology, and then improving the patient experience without raising costs. And then next slide, and I think that wraps my presentation.
Sam Hallmeyer from PCMA, thanks so much.
Thank you.
I'm going to introduce Kelly Ryan from Pharma, and I will say a lot of good partnerships have emerged out of this process for my organization, and certainly one of the pleasures has been getting to know Kelly Ryan. Please go ahead, Kelly.
Thanks so much, Ted. Well, the slides start to come up, but I'm really happy to be here again to continue this conversation. As Ted said, my name is Kelly Ryan. I'm Deputy Vice President for State Policy with Pharma. We represent the innovative, research-driven drug manufacturers. And if we flip to the next slide, I just wanted to pick up a little bit on a thread that we started at the last conversation. And that's spending on medicines is a relatively small and stable portion of the healthcare dollar. It has been for a number of years. It is projected to continue to be so for a number of years. And that's even in the face of some pretty incredible innovation. That said, even a stable piece of a pie in an ever increasing pie, overall healthcare spending is something we need to pay attention to. But as we go through solutions and have this conversation today and in the future, I really encourage us to break down some silos and look holistically about what is going to control spending overall and most importantly, keep people healthy. So if we go to the next slide, we know that the majority of health spending is driven by a small segment of the population, namely those with chronic and complex conditions. The CDC says that 90% of costs, and we can flip, 90% of costs are driven.
Next slide, please.
There we go. 90% of costs are driven by individuals with chronic disease and mental health conditions. And the number of people with 3 or more chronic conditions is projected to double by 2030, right? That's a huge cost driver. And this is not new to anybody that's worked in health policy, right? This is like one of the tenets that a very small number of people drive a ton of spending. And so if we're really talking about solutions to deal with spending, this is a population we need to pay attention to. This chart up here shows the impact on employers. We're talking about premiums and the challenge of employer sponsored insurance. So I thought that was a good visual, but you can cut this data any way you want. It's a small number of people driving a ton of spending. If we flip to the next slide, please. One of the most surefire ways to manage costs for people with chronic and complex conditions is medication. Right, the better use of medicines could eliminate $213 billion of annual healthcare costs in the United States. That's 8% of the national of spending, right? So we're spending 14% of the healthcare dollar on drugs. Using drugs better could save 8% and keeps people healthier. It keeps people out of the hospital. That's the goal we all should have. This chart shows, $1 extra spending in the context of a number of chronic conditions saves a considerable amount of money. Another example, just recently, the American Journal of Managed Care released some research relating to hepatitis C medicines that came out about 2013, right? This was an expensive drug class. Medicaid had some real challenges with it at the beginning. Even with the cost of the medication, the cures have saved Medicaid $15 billion since they were introduced. So that's net. And have cured nearly 280,000 enrollees of hepatitis C. So again, just saying like spending bad is not necessarily the right approach. The question is, what spending are we engaging in and how does it impact overall healthcare costs and the health of Connecticut residents and Americans? We can switch to the next slide. We've seen a real change in plan design over the last number of years that makes achieving these goals challenging for patients. And frankly, we think this is a little short-sighted. In the prescription drug space, I know that patients with deductibles and co-insurance are considerably more likely to abandon their medications. There's a bigger impact on communities of color, exacerbating health disparities. I think can we go back one slide, please? There we go. And I just really want to zero in on this leftmost box as we're thinking about solutions, because it really jumps out at me, right? Nearly 40% of commercially insured patients incurred half of their annual healthcare spending in one day, right? So this big shift to high deductible health plans to deductibles, people are delaying care because the deductible is hanging over their head. And when something happens, they have a pretty catastrophic cost at the beginning, right? So this undermines our goals of adherence and keeping people healthy. And again, just to keep sort of the context of how this impacts employers, sick employees have more sick days, they're less productive, right? So the idea of, squeezing sort of whether it's the out-of-pocket to premium bubble is this sort of zero-sum game. I just want to submit that the goal of keeping folks healthier saves the system more broadly than just the conversation we're having today. If we flip to the next slide now, we talked about this a little bit last time, and I'll just touch on it really quickly. We know that supply chain dynamics have an impact on spending in the drug space. More than half of spending goes to players along the supply chain, other than manufacturers, not getting to patients in the form of discounts, rebates, fees, all sorts of sort of steps along the way. And this number has grown. This is the most recent data we have. But like I said, more than half of every dollar spent on medicines goes to folks other than those who develop and manufacture the medicines. And if we switch to the next slide, this growing gap between list and net price that is driven by this issue in the supply chain creates mechanisms that, excuse me, they create issues for patients because very often when they pick up their medicine at the pharmacy counter, they're paying coinsurance or the deductible based on the full list price. Now, this is not in every situation, and there is, the report out of the Connecticut Insurance Department that says there is some sharing of rebates at the point of service, but the report is very general. It is clearly not every carrier, it is clearly not every drug class, but it is happening. We certainly would encourage a stronger push towards this sharing of point of sale rebates. We're looking at solving this issue. On one hand, it's helping patients at the pharmacy counter by making sure that they're reaping the benefits of all of those savings and discounts in the system. And the other approach is sort of a more systemic effort to start to drive some of this disparity in these hundreds of billions of dollars that's kind of sloshing around in the system, out of the system, and the incentives that they drive, right? If supply chain actors are making their money on something that is tied to the list price of the drug, then there's an incentive to have higher list price drugs on the marketplace. And this gap has changed quickly. So we would urge, for example, PBMs, like Sam just talked about, offer service, right? They do good. Yeah, 3 thank you. They provide a service, they negotiate formularies, they process claims, they're doing all this stuff. That's important in the system. That work should be compensated on sort of a flat administrative fee basis, as opposed to something tied to the list price that incentivizes higher cost drugs to gather more chunks of that rebate throughout the system. And this is a relatively new idea, but since we're talking solutions, we did want to throw that out there. If we flip to the next slide, just to circle back to the concept of point of sale rebates and really making sure that cost sharing is based on the net price of the drug that the payers are, the cost that the payers are paying. Payers are doing this, right? They're capable of doing it. They're offering it to their clients. And the information coming from payers is that it's providing a benefit. I really want to zero in on improved patient adherence of up to 16%, to circle back where we started, right? We want people to pick up their medicines. We want them to be adherent. We want them to stay out of the hospital and start to drive costs down across the board. And if we flip to the next slide, just to wrap up, there are a number of levers we can push. I talked about plan design a little bit. So share the savings is the concept of point of sale rebates. Connecticut already bans accumulator adjustment programs, making sure that patient's assistance goes to the patients. It counts towards their deductible. That's an important step we've already taken. And then there are all these other shades of adjusting plan design, whether it's getting rid of deductibles in general, right? If I could wave a magic wand and like completely redesign plan approaches, right? We'd have flat copays and we wouldn't have deductibles and people would go get the medicine and everything would be very predictable. Fully recognizing that that's a big ask, right? So we can start to push these levers a little bit, recognizing that we can only really address the fully insured market here in Connecticut. And I understand that's a small piece, right? It's about 46% in Connecticut, the last numbers I looked at, but it starts to move the needle. So one example would be to look on the exchange in the non-group market. Connecticut has standardized plans. They've been ahead of the pack on that. The federally facilitated exchange now requires standardized plans. We expect to see that actually tighten up even more going into the 2024 plan year. And one of the really important aspects of those federal standardized plans is it's co-payment only, right? There's still a deductible, but they've eliminated co-insurance. The bronze plan, at least in Connecticut, still has a 20% co-insurance for drugs across the board. So Connecticut, while it was a leader, is actually starting to fall behind on plan design in this respect. We can look at covering preventative medicines pre-deductible, making sure that people are getting the chronic disease management that they need. And, ideally we would have flat co-payments across the board. I'll wrap up, but I would just say there are shades of gray in these policy options that we can use to start to move the needle without blowing the system up, without creating a huge premium spike, because that's obviously a concern as well. I'll stop there and happy to take questions afterwards.
Thanks, Kelly. So we've given great editorial control to all the participants here, except for the next one, which is Kurt Barwis, CEO of Bristol Hospital. We specifically asked Kurt to address the Maryland total cost of care model because of Kurt's long experience in that market. So welcome, Kurt Barwis of Bristol Hospital. Thank you.
Good morning. It's great to be here, and thank you so much for asking me to do this. I was kind of dating myself. I went back, it was 25 years ago that I actually worked in Maryland, and I spent almost 9 years there. The system in Maryland actually started 36 years ago. It's one of the states that's been on a model for a long, long time. And as I went through the updated model, which is the global budget model, and I think you heard a little bit about it just a few minutes ago, it brought back a lot of really good memories to me. First of all, rates were set in advance, and it's true then and it's true now. If you spent too much or your costs went up, independent commission called the HSCRC. If you advance, you're on my, thank you for keeping up with my slides. HSCRC, which, it's an independent commission. I would say it's a quasi-governmental commission comprised of payers, providers, government individuals that really looks at the totality of what a hospital or health system is doing. So managing costs, managing prices. I am an accountant. And so one of the things I loved about that system was there actually was a relationship between what you were charging and the cost of the service, which has been obliterated throughout this country because of the way we negotiate rates and do rates. But the current system almost operates what I commonly refer to as what I existed in. And that is that there's a global budget. Hospitals work through that global budget. The commission actually looks at how you're doing throughout the year. Rates are adjusted to make sure that you hit your budget. It's set in advance. The beauty of the system and what I would say works and is really an important criteria is that if you're being somehow affected by a disproportionate share of a particular population, 1 year to the next, you're only 1 year away from getting that addressed. And if you look across the country, and I worked in the mid-Atlantic states, and I was a reimbursement specialist at one time, and I remember seeing New Jersey come off of their rate regulation system, and it was because they didn't address the uncompensated care. They didn't address uncompensated care. One of the things about the Maryland system, which is beautiful, is that uncompensated care, you're only a year away from getting your costs back, from getting that back. So budgets are adjusted based to account for inflation, changes in area demographics, market shifts, and other factors. It's an all-payer system, right? So, and I can give you personal examples in Southern Maryland, very unique population. And one of the things that we did, because businesses were paying the same rates as Medicare and Medicaid, everybody paid the same rate. The businesses got together with the hospital, and we created a health share card for individuals who didn't qualify for any insurance. And that was really about reducing the stigma of a person going into a doctor's office and not having a way to pay for their care. We did fundraisers, we shared, resources, but everybody had a card. Incredible experience, right? And so when you think about, giving hospitals or healthcare organizations money and saying, well, now that they could profit from that, what are they going to do with it, right? How does that work? They can invest in things, infrastructure. We were in Southern Maryland. We had a heavy Amish and Mennonite community. We had water troughs and hitching posts at all of our urgent care centers and hospitals. We use that money to change the outcome for the community. And it exists throughout Maryland. So a great system. And from my experience, we spent a lot of time doing community outreach to those farmers, the Amish people community, and we brought services, we talked about their issues, and we brought healthcare professionals to help them overcome those issues. So from a social determinant of health standpoint, I felt like while you may not see it in the state data exactly, there are clearly opportunities to go after that in a way that's really unique and special. So again, the spending cap under the current system is subtracted. If you go over it, it's subtracted from the next year. we commonly refer to it as the spend down, the dreaded spend down. And if you went over your cap in expenses, you had to make it up the next year. It includes, the current model includes inpatient, outpatient services, and it's mandatory. It's mandatory for all 47 hospitals across the states. There's no exception. You can't get out of it. They started with a demonstration project that included 10 rural hospitals, and then they expanded it out. And it's mandatory for Medicare, Medicaid, and all commercial payers, right? Good, you're just keeping up with me. That's really good. It really provided predictable funding. And I can tell you from personal experience, from year to year, running a small independent system in the state, 1 year is good, the next year we struggle. And to have predictability enables you to invest in things like access to care. So recruiting physicians needed, physicians in the community, and also go after specific issues that you have within your community. And they vary from one community to the next. It really depends on the state's methodology for adjusting rates, but it's really the HSCRC that does all the advocacy and controls it. Again, 36 years, there's trust. There's absolute trust in that organization. It's not like people are saying that dreaded HSCRC, everybody's on the same page. And it's and I covered that transparent. And so how does this kind of reflect on us? Think about it. Medicare increased their rates, right? And now we have budget neutrality. So when you think about the Maryland model and trying to bring it to another state like Connecticut, the big hurdle to overcome is, first of all, could we actually get Medicare to increase the rates? I'm not sure you could, but it's interesting because when you think about it, right, who gets increased rates for Medicare all the time? Medicare Advantage plans do. They have never once cost less than traditional Medicare. The model in Maryland, what they had to do to keep the demonstration and keep that exemption was to prove, and it wasn't that they cost less, but that the rate of increase of the cost of care in the state was less than that of the rate of increase in the rest of the country. And I think that's still true today. But again, budget neutrality really does,
Kurt, 3 more minutes.
thank you, create a real hurdle for us if we were to go with a model like this. And it would also require an increase in state Medicaid rates. So those are 2 big blockers. The next slide has to do with the social determinants. You've seen this slide. I think 2 individuals presented it in the first meeting that we had. But this has to do with diabetic care in the state of Connecticut, and the estimated cost is $3.7 billion a year. If we were to move into a different kind of model for reimbursement, could we actually go after this? Could we make a difference? And think about that, right? The more you improve the health of the state, the more you improve the economic outcome of the state, right? It absolutely is completely connected together. And you only have to do is look at hospitals in areas where they have good health status, and you could see their fortunes are different, right? So next slide, please. So the healthcare cabinet of the state, when Nancy Wyman headed it up, spent a lot of time looking at different models. And we actually had consultants that helped us do that. And it was an incredible deep dive into alternative models. And you'll see most of these that I'm putting up here. Oregon Section 115 waiver. Section 1115 waiver is actually refers to a section of the Social Security Act. And it's no different, this happens to be a way you would get to do a demonstration project for the entire state. No different than Maryland, except they applied under a CMMI designation, which is a Medicare innovation project, but they're all innovation projects. And if you look at the right side of this, you're going to see that in each particular case, they've dealt with different issues that they're having in their states. It is absolutely something that we talked about at the healthcare cabinet as an opportunity for us as a state to actually increase federal support to go after things like the social determinants of health, to actually go after and make a difference in our state. So I just, leave you with a couple points. One, I'm passionate about the need for this state to come up with a different model. It's going to take time. It would take time. It's really important, I think, that as a state, we actually fund in this legislative session the costs associated with getting consultants and experts in here like we did years and years ago. It just wasn't the right time for us to do it, to actually go after some of these models and go after an 1115 waiver that could bring additional resources that maybe we're leaving on the table right now that could help us improve the healthcare of this state, right? It's probably not going to be the Maryland model. It's probably going to cause, some political tugging and pulling, which was part of the block that we had the last time we went after this. But I think this state deserves better in terms of how we go after this and how we address these social determinants. If you just look at the one metric that was up on that screen, $3.7 billion can do a lot of good in this state. So I'm going to conclude my comment. Thank you.
Thank you very much, Kurt Barwis of Bristol Hospital. I want to welcome to the table Representative Tammy Nuccio. There's no member of the General Assembly more passionate about affordable health care. So thank you for coming to listen to these presenters. Next presenter is Greg Shangold, who is an emergency doctor and representing here the Connecticut State Medical Society. Greg, go ahead.
Thank you, Ted, and thank you, everyone, all the distinguished representatives, senators, and government people. I think I have the slides here we figured out, so I'm going to share my screen. And just trying to. Right. All right. There's a lot of slides here. I'm going to try to gloss over them, but I guess Ted will have them all posted there. So I'll try to hit the major parts here. This is just about me. So I'm representing this Connecticut State Medical Society. I'm past president for the 4,000 Connecticut physicians and physicians in training that we have here. I've been in the state over 20 years now, and I'm the managing partner for our group, and we see about 160,000 ED visits a year. We have the only Connecticut independent group, and we have 68 physicians and APPs. So these are the ones I'm going to focus on, basically, that medical liability reform, which we haven't heard much about today, but is a big driver. I think we just got touched on the Medicaid rate adjustments that I think is really needed, and the value of keeping independent practices preserved here in Connecticut. There we go. So for medical liability reform, there's the defensive cost of medicine. There's various studies on this. It's anywhere from 46 billion to 300 billion. And that definitely factors into the premium costs. But there's other values here, as we've talked about with competition, that we need to make Connecticut a desirable place to practice. And I'll show you some evidence that Connecticut is not. And lastly, it will increase the willingness to take care of complex patients because sometimes those are the ones that don't always lead to the best outcome, despite following all standards. Specifically here in Connecticut, this is national, 85,000 cases are filed each year. But most claims are dropped 65%. Only 6% go to trial. Of those that go to trial, 89% are found to be for the defendant. But when you look at this in this 10-year period from 2010 to 2019, we've taken $42 billion out of the healthcare spending dollar and put it towards malpractice claims. So when you look at surveys, why is there a defensive practice of medicine? These are sort of the reasons there that you just avoid doing things because you don't want to be named in a lawsuit. It's the standard of care, peer pressure, all of these things sort of drive why it's done. And someone that's practicing medicine, I can tell you every shift, almost every patient, I'm doing tests that I know I probably can avoid, but I do them because of these sort of feelings. If you look specifically, this is all the states here of the average settlement from 2017 to 2021. So it's hard to see, but blowing it up there, Connecticut is up there at the top at the 4th highest as far as average settlements. And this is a report I assume that many people in this room have, because this came to done by the Department of Insurance. So I'm sure Paul's familiar with this report. So taking those numbers out of here, the average indemnity in Connecticut was 890,000, but 47%, right? There was no payment. And the total payments in Connecticut was 1.2 billion. And premiums have continued to increase. And it's mostly because the high, not the number of claims, but the high value claims have gone up. And just knowing people know this is important. If you go back to the beginning of COVID, right, within less than a month, they issue orders about having additional protection for malpractice in Executive Order 7U and 7V, because they knew how important this was about access to care. So any solution with malpractice should go to decreasing cost, improve patient access, and making it a better experience. CAPS has definitely been shown in many states to do that. We can go through all the data on CAPS, but it's in there, but CAPS definitely have worked in other states. And then here are just some other solutions that have other states have done. So we haven't addressed it in this state for many years, but there's definitely a cost savings as if you want to go into the underlying cost that leads to price from that. Adjusting the Medicaid rates. I think trying to break this down simply, do changing Medicaid rates improve access to care? All of these cited articles here show that that's true. I mean, it's innately sort of understood as true, but there's articles that show if you improve Medicaid rates, you improve access to care. This was just one that data I saw from this Alexander and Schnell paper. A $45 increase in Medicaid rates would eliminate disparities amongst 2/3 of adults and all children. You know, so as we talk about disparity in medicine and healthcare, that's there. But we've talked about this as well, about managing chronic disease is important as well. So if you can manage people early on in the disease, a lot of times you avoid costs later. And this is just some data from the Kaiser Family Foundation about where Connecticut ranks overall. We're number 30th. Delaware is the best. And then if you look specifically from primary care and OBGYN, we're not that bad, but specialty services, we're number 42. And since I have to go through, try to get through, Medicaid definitely hasn't kept up with inflation. Medicare hasn't, and particularly towards physicians. If you look at this from 2022, we got a little bump with some COVID, but we actually in 2023, physicians had a 2% cut. So as inflation's going up at 6, 7, 8, 9%, physicians were cut 2%. So when you look about this, the problem is this cost shift, right? We're competing with other states to retain and attract physicians. Cost of running, the regulations have gone up significantly. There's studies that show it's a 39% increase. Medicare and Medicaid have not kept up with those costs. The revenue must come from the commercial market. And then even with those higher rates, physicians often don't collect that revenue because of high deductible health plans. So I think some of the solutions right here is increase Connecticut Medicaid rate to Medicare, and then to develop a system so that we're not doing that year after year after year. And then the last piece is about keeping independent practice, the regulatory burden. Physicians in private practice are going down. So we're down to 21% of practices. This basically shows that. And the regulatory burden is definitely part of that problem. Prior auth is one of the big reasons. We've talked about getting rid of faxes. But if you look at overall, just the cost of running a practice is why many doctors have left that. And these prior auths do cost a significant amount of money. So again, if prices are what you're doing, you have to look at the underlying cost of why those prices are there. And, you know, I didn't even bring up, like I did in the first market, the medical education. But if we reform prior auth, we eliminate physicians from being exposed to high deductible health plans and get a reliable income, and make these initiatives to make Connecticut a desirable state, will improve the workforce and improve the competition, and therefore it can maybe drive down those prices. Sorry I had to go so fast, but I think we got
Thanks
there.
so much, Dr. Greg Shangle from the Connecticut State Medical Society. And he's got a lot of information packed on his slides. You can pick them up later on the Insurance Department website. Gives me great pleasure to welcome Dr. James Carden from Hartford Healthcare. Dr. Carden is the EVP of Chief Clinical Integration Officer and the CEO of Integrated Care Partners. Go ahead, Dr. Carden, and welcome.
Thanks, Ted. I thought it'd be useful for this to use my time to describe the way Hartford Healthcare is thinking about this problem, affordability, and how we're approaching the issue. Greg, don't worry about too many slides. I don't have any, so I think between the two of us, we kind of balance out here. But to be a little bit overly simplistic, you know, our purpose in its essence as a provider of healthcare is to care for people, and we get paid to do so. In order to meet that need, we have to buy stuff, rent stuff, and have the honor to work with an incredible group of dedicated individuals to provide that care that we have to pay for. We remind ourselves quite often that every system is perfectly designed to deliver the cares you're getting. And so as we look at that and understand what our role is and what we're doing, we recognize that if we're going to address affordability, we have to fundamentally transform the delivery system. We have to challenge our assumptions about the where, the what, and the how we are providing care. The fundamental barrier to what we're trying to achieve and that we're dealing with right now is the timely access to care. I'm not describing what that care is. It's whatever the patient needs, what our communities need for us to help with. We have to figure out how to deliver that in a timely manner. And it's just not any access. It's really access through the three interdependent domains of excellence, so quality, equity, and affordability. So I'd like to spend a little time on each of those things and give you some sense as to the progress and where we are in this journey. So affordability really begins with quality of care. We've heard that in the other presentations already. I'm going to start with risk factors. So we know across the country how to treat hypertension. It's not complicated. We've been doing it forever. Yet we also know that the vast majority of people are inadequately treated. Similarly for diabetes, a major cost driver, but oftentimes we are not meeting the expectations of getting people to goal. So we've taken that on, recognized that we needed to really look at all of the patients who see us for care. How are we managing their blood pressure? And the results were interesting. We had 110,000 people with hypertension. Biggest challenge is if you ask every clinician, they say, I'm doing a great job. Look at all the people I saw. Their blood pressures are well controlled. The trouble is, you didn't see all the people. So it is acknowledging the fact that it is not just taking care of the people who are in front of you, which is typically the way the providers work, but is acknowledging that we had a vast majority of people who didn't seek the care that we needed to be responsible for. And we've made great progress in figuring out not just the medicine, but the logistics of getting blood pressures on 110,000 people every year. Similarly with diabetes, 33,000 patients, making sure that not only they had their medicines and were compliant with the medicines, but that the outcomes were where we wanted them to be. And both of those things are critical for us if we're going to decrease the end organ damage that those conditions result in, that lead to strokes and heart attacks and kidney failure, if we're going to ever address the affordability issue of care. The second bucket is those people who already have chronic conditions. How do we manage them more effectively? How do we ensure that in between office visits, they are receiving the care they need? We've hired and enlisted a series of care managers that risk adjust every one of our patients, set up care plans, and check in with those patients on a regular basis to ensure that whatever condition they have remains stable and they don't get sick, tumbling into expensive hospitalizations, ED visits, and additional testing. That means we need to manage people who are coming out of the acute facilities. They're already identified as a very high-risk population. And between our care management and our transitions of care management, we have some clear metrics of reducing readmissions. Those that are involved in our care management program are readmitted to the hospital, half the frequency of those that are not. And for managing, if they're in our care management program and our delivery system, we've looked at our ability to bend the cost curve and have clearly seen a significant impact on the year-over-year increase in cost of care if we can maintain those patients within our care environment. Lastly, we recognize there are people who are going to end up in a hospital. What do we need to do there? We need to be more focused on efficient and getting great outcomes. How do we decrease complications? How do we reduce mortality within the hospital? How do we reduce infections and errors? All of that work reduces additional medical spend and allows us to move those patients through the hospital efficiently. But that's not going to be enough. We also need to find lower cost sites of care to deliver the same quality and performance and safety that we're currently doing in hospitals. Hospitals are expensive. They're always going to be. But there are other sites of care, ambulatory surgery centers, urgent care for those who don't require emergency room level of visits that we have built and are engaged in to allow us to move that care to lower sites of care with the exact same performance around quality. We watch our quality very carefully. We look at our mortality. We look at our hospital-acquired infections. We look at our safety events. And there is daily management of those kind of episodes with great scrutiny when we are off plan. In addition, external validation through Leapfrog tells us that we are at least headed in the right direction to be able to have consistent performance across our institutions where we are A and B rated across all of our sites, which is a fairly rare accomplishment. Thank you. Lastly, it really is, as we talked about around access, this is an enormous challenge. It's timely access to care if we're ever going to meet our affordability. You can't manage what you don't manage. Our ability to ensure that we are in contact with patients and be able to give them care, but it is not necessarily requiring office visits. What is the minimal amount of care they need to address their issue? And with that, no more, no less, we feel we have an option to really manage these conditions in a much more affordable way as we go forward. Plus, we have to acknowledge that we need to meet patients where they are. We have a neighborhood health agenda and an initiative going on to where we are going into communities with communities partners to provide access to those with no insurance or underinsured, and to ensure that we're meeting their needs, not just medically, but in acknowledging that we have a real responsibility around social determinants to understand those additional barriers to access and the barriers of care if we're ever going to get to the equity condition. Payment models matter. I don't think there's any question that the way we've been paid has determined a lot of the what, where, and hows we do. And we acknowledge that that is an unsustainable model. We have embraced our ability to get to a total care cost model where we are responsible for total cost and quality. We did that through Care Partners, a Medicare Advantage plan that we co-developed, which is still and growing, and have now developed a risk-bearing entity that will take full capitated cost up and downside risk on an all-payer database on Medicare Advantage. This allows us to start to align the payment model with the delivery system. So I'm happy to take any questions and appreciate the time and the invite to be here.
Thank you so much to Dr. James Carden from Hartford Healthcare. Our next speaker is Susan Halpin, representing the Connecticut Association of Health Plans. Susan, go ahead.
Good morning, everyone. It's a pleasure to be before you today as the Executive Director of the Connecticut Association of Health Plans, representing Aetna, Anthem, Cigna, Connecticut, and United Healthcare, and home to the insurance capital of the world. 40,000 plus jobs. I guess I came to this position naturally since both my parents were employed throughout their careers in the insurance industry. My mother in the health insurance industry and my father in the P&C industry. If you can go to the first slide, I think I want to start by commending this group today, commending Governor Lamont for his executive order, commending the Department of Insurance, Commissioner Mays and his esteemed team, commending the Office of Health Strategies, both Dr. Gifford and her team. Kelly, I know still here, has been integral in these conversations over the past several years, and also Vicki Veltri, your predecessor, and Ted, who we've always had a very good ongoing relationship with and working hard together. I'd also like to thank the carriers and all the other stakeholders in the room that have committed a tremendous amount of resources, time and energy to many of the discussions that have happened over the past couple of years through OHS, its work groups and task forces of the legislature. And I do want to say the last thanks and appreciation I want to give is to the bipartisan nature of the legislative support for these initiatives as time has gone by, and with passage of the legislation that codified the executive order. So the first thing on my slide is invest in collaboration. I think evidence of that collaboration is here today and has been in present. So in that sense, Connecticut is ahead of the game, right? We've convened the stakeholders. I don't think I've been doing this for almost 30 years. I have never seen so many people sitting at a table from all different, parts of the delivery system at such high levels before in my career. So that in itself, I think, is an enormous achievement and something that we should all take pride in. I also think we're always struggling for what's next. What can we do to reform the system? Where can we go from here? Sometimes I think we need to take a step back and recognize the current initiatives that we're all engaged in and invest further in those current initiatives, because it takes a while once we pass something for it to show the promise of what was intended. And I think, we're at that phase now. We understand what the cost drivers are. You've seen evidence of that over the past several sessions and again today. But we all acknowledge, I think, that there is no silver bullet here. If there was a silver bullet, we would have found it. Somebody else would have found it in the state. There is no silver bullet. This is hard work. Everybody has to come to the table, putting aside, their biases, and we have to move forward. I'm really encouraged by what I've heard around the table today. I think there's more common ground than not. We're obviously going to disagree on some of the mechanisms to put those things in place, but whether it's, value-based payment, whether it is the need to make sure that our payers are aligned across the system with public payers and private payers, whether it is about social determinants of health, equity in healthcare, access, quality, affordability. I think we're all talking about the same mission and that we've all embraced a shared mission. And I also think, whether it's defensive medicine or malpractice reform, we too share in those concerns. We know they drive the underlying cost of healthcare. So, we recognize the value over the volume, the quality over the quantity, right care, right time, right place. All of these things, I think we're all pretty much on the same page with. Next slide. I think you'll hear later today from some folks that will go into a lot more detail about what the carriers have done to educate and to engage consumers and employers. There's a lot of talk around this table and in the employer community and others around quality, transparency, wellness, digital tools, telehealth. These are all accomplishments over the past several years that I think we all have to take a step back and acknowledge and figure out if they're helping us or hurting us. I'd dare to say they're helping us significantly. And I think we all need to be encouraged by that. I don't want to spend a lot of time on, the bottom part of this slide, because I think we all have seen what the cost drivers are. And the next phase is how do we tackle them? I would add to the list that's already been discussed today, mandates, fees, and assessments. They may not be at the top, but they certainly are contributors to the bottom line of healthcare costs and therefore healthcare premiums. Because, I think folks have recognized that premiums, insurance premiums are merely a reflection of healthcare costs. And that's a total cost that does include mandates, fees, assessments, as well as the major cost drivers that have been identified today. I think also what I get asked all the time, so what do we do? What do we do next, right? My answer always is please first do no harm. So that would be the next slide, please. We have to understand in Connecticut, and this is a hard concept, I think, for folks that don't live and breathe this every day. We have to understand in Connecticut that we have authority as a regulatory body, as a legislature, over only 14% of Connecticut's 3.5 million people. 14%. That is a very small number of folks. And those are the folks that are in the fully insured market. And I'm sure the department would reiterate this. The fully insured market continues to shrink. So it's 75% or more is self-insured. And that is not under the governance of Connecticut. 25% or less is the fully insured market, which is. And those are the most price sensitive people in the market. Yep, price sensitive people in the market. We have to be careful about what we do in terms of if that is going to increase the costs for that most sensitive, part of the market. So we have to target the major cost drivers. You can skip that slide, the next slide. We have to hold everyone accountable. I would argue that the carriers have been at the forefront of that accountability standard. I think there's a lot that the carriers have undergone, whether it's rate review and approval, which is in current law, medical loss ratio standards and premium rebates are under current law. We have benchmark reporting, CID report cards, all payer claims database. Many of these things have been announced already or not acknowledged already. So we need to hold all parts of the system accountable. We need to establish an accountability and an answerability. We talked about the benchmarking being one of those current initiatives. We need to invest further in that. We need to bring the hospitals, my friends at the hospital systems, into that benchmarking arena. We also, this is a hard one to understand too. We also have to acknowledge the role of contract negotiations in cost mitigation. Consumers are rightly upset when they hear about contract negotiations between payers and providers. It's a hard thing to understand that, your hospital or your network is in a tough negotiation with a carrier. But that is where the cost mitigation by the carriers pays and reduces premiums. So I think as things go into the public arena, there has to be acknowledgement of that cost mitigation aspect of those. Other things that have already been talked about today, the anti-steering and anti-tiering legislation from NASHP, we support that. We also believe that we need to look at the reimbursement system from a little bit different lens than what we've talked about already today. We have to make sure that the reimbursement and the billing structure follows the actual site of care, so that everything isn't billed under one umbrella code, that it actually reflects if something was done, in those community providers. So we'd like to talk about that. And then modernizing the certificate of need policy. Kim Martone, nobody knows more about it than her. And I wouldn't profess to suggest what exactly needs to be done there, but we need to consistently monitor it. what's working today, this delivery system is moving faster than any of us, can appreciate on a daily basis. We need to make sure we should roll back those CON policies that aren't working. Perhaps look at new policies where it needs to be applied, whether it's on, let's say, the private equity firms that are coming into healthcare that we've seen, having tremendous negative impact in the rest of the country. Perhaps not as much here in Connecticut, but that needs to be looked at. And maybe it's coming and we need to look at that. Sam did a great job on the pharmaceutical aspects. So I'm going to leave that for a second, but I do want to focus a little bit on the cost shift in all of those working groups, in all of those task forces, from the steering committee at OHS to the recent task force that I participated in on emergency medical systems with the ambulances and our 911 folks. Consistently, there's been a conversation about whether Medicaid prices are what they should be. And consistently a conversation that they are, whether it's a system, a hospital, or, an EMS provider, they're constantly monitoring what their commercial census is, because they need those commercial reimbursements to offset the payments that they're not receiving from Medicaid and to a lesser extent Medicare. So I know there's studies out there that question whether the cost shift is there,
Final
but we
thoughts,
need
Susan.
to assess it, and we need to determine whether that needs to be addressed. Just 3 things I'm going to say in closing. We have a fabulous exchange. We need to invest in it. We need to modernize it. We need to explore redetermination and auto enrollment. That's the biggest thing in healthcare. It's the thing we should all be talking about right now. I know it's happening in the rest of the building here, but you've got potentially 400,000 folks about to have to be redetermined for eligibility in Medicaid. And if only half of those are redetermined ineligible, to Kurt's point about uncompensated care, you could potentially have 200,000 members coming to all of your facilities without any insurance or reimbursement. So we need to be looking at that. And workforce. I'm not going to say anything more about that. Everybody needs to look at that. Everybody needs to invest in that. So thank you for the time.
Thank you, Susan Halpin from the Connecticut Association of Health Plans. We're going to go to a discussion period now. And I first wanted to solicit Commissioner Mays. If you've got any questions for panelists, please go ahead.
Thank you, Ted. And I do have a couple of questions. Well, actually, I've got 4 questions from what I see here, and they're focused on drug prices. I'm going to start with Sam. And we heard Kelly call for significant changes in rebating, focus on the point of sale. We know there are various studies. There was a USC study, for instance, that said that every dollar increase and the rebate to a PBM would result in, or usually results in, a $1.17 increase in list price. Bearing that in mind, how do you respond to Kelly? Do you think rebates should go almost or completely to the consumer at the point of sale? And at the very least, should there be a minimum level of pass-through so that the PBM is not retaining those rebates? And my second question, I'm going to throw out all these questions at once. My second question to you, Sam, is on spread pricing, which is when there are lower prices for generics that the PBMs pay than basically what you charge. So there's a difference, there's a spread between what you're paying to pharmacies and what you're charging the insureds, whether those are employers, employer groups, or others. Does that still exist? And if so, why? And let me just throw out the question to Kelly right after this so I can get off the screen. And Kelly, my question to you, it's got a couple of parts, but it's really the same question. We saw a GAO study a year or 2 ago that compared drug prices in the US. They did a basket of drug prices. They compared it to similar countries. And they specifically said, for instance, Australia, Canada, France, similarly situated countries, and consumers in the US pay 2 to 4 times as much for the same drugs as consumers in those countries. And in addition to that, we've certainly seen over the past few years increases in the cost of basic generic drugs like insulin, for instance. Those increases significantly in excess of inflation. There are no research costs. These drugs have been around forever. Shouldn't be any significant increases in manufacturing costs. So my question to you is why? How do you explain that to consumers? Thank you, Ted.
Great, Sam. A couple of questions there for you. Go ahead.
Thank you, Commissioner, for the questions. So to address your first question with point of sale rebates, that is a concept that has been brought up not only in the state of Connecticut previously, I believe back in 2020, that did not make it across the finish line. It also was introduced by the Trump administration under the rebate rule, which was also repealed back in 2021. But the concept of point of sale rebates, it actually does nothing to address the high cost of drug prices. Rebates, the system of rebates is used to lower premiums for everyone within the payer system. And those are spread. So when rebates are paid back to a plan, they use those to lower premiums for everyone within the plan. If point of sale rebates were to be implemented, not every drug has a rebate. I don't know the percentage off the top of my head of which drugs are rebated, but point of sale rebates might only impact 10% of patients. And then 90% of those patients, where normally those rebates would be used to lower the cost of their premium, now those 90% of patients don't have those lower premiums and have higher premiums. So that is my response to the point of sale rebates. And we don't think that that is a good solution for the state of Connecticut. Next is on spread pricing. That's a plan choice and a risk mitigation contract. An example I like to use, especially in Connecticut, is like home heating oil. You can either pay your month-to-month utility bill, or you can lock in a rate that's used over the course of the year. Sometimes you might come ahead and sometimes you might not, but that is a risk mitigation choice. A plan has a little bit more predictability when it comes to a spread pricing contract. So again, we think that that should be a plan choice and not be eliminated in the state of Connecticut.
Before we go to Kelly, if I could just have a quick follow-up here, Sam. Formulary, there are some academics who have suggested that rebating does have an effect on the formularies that you create. The high rebates means that drug manufacturers, especially the high-priced drugs, have a better chance of getting into the formulary that you use. Could you address that as well?
Sure. So PBMs use formularies to pit drug manufacturers against each other to get to the lowest net cost. That is the goal with these formularies, is to get to the lowest net cost for plans and payers. So that's the use of formularies, Commissioner. Does that answer your question?
So you're saying there would be no effect from the rebate that's received by a PBM on what is included in their formulary. Is that what I'm hearing?
Well, no, the use of the formularies is to keep, to get to the lowest net cost for plans, to pass those rebates back to those plans to then lower premiums for everybody.
Thank you.
I'm happy to jump in. Thank you for your questions, Commissioner Mays. Regarding US prices versus international prices, just a couple of points. You're absolutely right. The American consumer bears the burden of research and development much more than the rest of the country. We certainly would love to see more equity in that respect. The countries referenced in the GAO report all have price controls, and an impact of those price controls is access to new medicines, right? So in recent medicines, 87 to 90% of new medicines are available in the United States, and they're available within 0 to 3 months. For example, in the UK, that number is 59% of such medicines are available, and there's a delay of 18 months. Canada, 46, with an average delay of 15 months. And so it's a value judgment that Americans have access to newer, innovative medicines faster. They have access to medicines that simply are not available in other countries. And yeah, we would like to see that balance out, but not on the back of access to innovative therapies. And with respect to your question with generic price increases, just to level set, I represent the Innovative Brand Manufacturing Association, so I can't really speak to generic price increases. And as a trade association, I don't really get into the weeds on individual company decisions. But with your insulin example, I would point out that in general, looking at the class as a whole, net price of insulin has actually come down dramatically. And we would say that, kind of going back to the rebate conversation, this idea of really driving a huge gap between list and net price, and why we think the system is so broken. The insulin market is like the poster child for that example, right? Net prices are coming down, yet patients are paying the full list price at the pharmacy counter, or they can't access their particular insulin because of the quote unquote competition between you know, if I, as a PBM, am getting a bigger rebate, I'm going to choose insulin 1 over insulin 2, and then patients that are stable on insulin 2 can't access it on the formulary. So I think you're right to zero in on that market as an example of the issue.
Okay, before we turn to Dr. Gifford and her questions, Susan wanted to jump in with a comment. Go ahead,
Yes,
Susan.
thank you for
Susan
your
Halpin, Connecticut Association of Health Plans.
Thanks, Ted. And thanks for your indulgence. I just wanted to offer that I think some of the legislation that we've seen in the area of spread pricing or pass-through of rebates or formulary restrictions falls into that category that I mentioned of first do no harm. These are things, these are tools that employers, unions, and other organizations, including the state and its municipalities, are asking carriers to provide as a way of cost savings, as a way of driving quality, as a way of using evidence-based practice to drive what's the best medicine. Everybody agrees that evidence-based practice is the way to go, but when it results in step therapy, sometimes folks have questions. But again, I want to say that, you know, employers are asking for these measures, hospitals as employers, universities as employers, unions as employers. They're asking for these measures to be put in place so that it benefits their entire population of members and lower premiums. So I just wanted to offer that because the employers are not sitting at this table today, and they probably should be.
Very good. Thank you so much. Dr. Gifford, please.
Thank you, Ted. And let me just say to all of the speakers in our first panel, thank you so much for your contributions, your expertise. I think to echo something Sue said, this is the kind of conversation that's very necessary. They're difficult conversations, and I really appreciate those of you in particular who have been called out as drivers of cost increases for being here and being part of the conversation, because that's what it's going to take. So really appreciate all of the participation, and more importantly, look forward to, as the session progresses and as this work progresses, more conversations and collaboration. First of all, I just have a question for the PBMs. This is a follow-up. You mentioned that rebates are used for premium reduction. We would be very interested because PBMs are one area where we don't have a lot of transparency. Ms. Tripoli mentioned that transparency is an important tool in driving down costs. And I think one of the areas with the least transparency is the flow of dollars between pharma, PBMs, insurers, and payers, purchasers. So we would be very interested if you could get back to us on any data you have on how rebates are used to drive down premiums in Connecticut. The second question I have for you, Kelly, is you mentioned switching from to a transaction-based fee for PBMs versus a price-based fee, which is intriguing. My question to you is if you could just explain very briefly, and then I have a follow-up for Dr. Carden. Who is responsible for setting that method of paying the PBMs? My assumption is that the two parties involved in the transaction, that is the manufacturers and the PBMs, it is within your control to change to a transaction-based system. So what's the barrier to getting to that?
So the compensation doesn't run between the manufacturers and the PBMs. It's the health plans are the PBM's clients, right? So that's where we're focused in. And frankly, all the way down the supply chain, right? So wholesalers as well. There are obviously negotiations between manufacturers and PBMs as well. And again, like as the trade association rep, I am not privy to what my individual members do, right? So I'm speaking very generally. But the concept that we're presenting is, okay, look at the services of formulary development and claims processing and PA and like important services in the system, right? The cost of those services should be the same whether or not a drug costs $1,000 or a drug costs $10. And so we're looking to drive the incentive to choose a $10,000
Understood.
drug.
Mike, I guess my question is, is there a role for the state in that? Or isn't that something that's between the parties that is fully within your control to move
This-
forward on?
The state as an entity that regulates health insurers certainly could regulate how health insurers develop their contracts with their third party, their TPAs, that kind of thing. Like I said, it's a relatively new concept. So I can't say like, oh, state X is doing this exactly this way.
Okay,
But in the literature, this is an issue that is starting to be discussed.
Got it.
And that's how we think the state would have the ability to do it is through the regulation of insurers.
thank you.
Mhm.
Appreciate that. So my question for you, Dr. Carden, is we heard a lot about the role of healthcare consolidation, horizontal and vertical consolidation in driving up price. So I wondered if you could react to that data and then share with us any thoughts you have about potential ways to mitigate that. That has been, something that comes up in almost every conversation. We appreciate that there are benefits in terms of care coordination, communication, administrative efficiencies, et cetera, when it comes to integration, but we also see evidence that that is a cost driver. So I wonder if you could just speak to that issue in particular.
Sure.
Dr.
Pardon,
Carden,
before you do that, so we're gonna just have a few more minutes of the discussion. I also want to mention to any legislators that are online, there will be a chance, there is a legislative portion to this later this afternoon for you to ask questions at that time. But again, we have about 3 minutes for the discussion. Please go ahead, Dr. Carden.
That's okay. I'll try and keep it succinct. So from our perspective, without the full system of care, in order to have and explore how we're going to deliver care fundamentally differently, you become increasingly constrained on what you can do. If I'm a hospital, there's only so many things I can do around that. When we have a broader system of care, including not just hospital in one location, but being able to utilize all of our assets across geography, we have a much better way of rationalizing where care is most efficiently and affordably delivered. It gives us the ability for us to invest in fundamentally different capabilities. We certainly saw that with COVID. If we weren't the system we were, we would not have been able to meet the inequities in care that we knew were going to roll out of that whole both testing and vaccination program. But because we could deploy resources in a very different way, we were able to mitigate a good deal of that. Always room for improvement. As we look at our neighborhood health initiative of being able to build out a program to where we can provide access to uninsured and underinsured, it's because we have the scale that we sort of have. Ultimately, as I said, right now, we are still very much living in the system delivery mode that has been developed over the last 100 years. I don't know, it's been going on a long time. Our challenge is how do we now take all those assets and really think about it fundamentally differently and use them differently so that we can provide that timely access, not just access, timely access to where we can get in front of what we see as drivers of that cost. By the time somebody's sick, you're really late to the game. And those people are going to be expensive to take care of forever. The only chance we have is not cause any additional injuries to them and get in front of them as best as we can so we don't end up with as much chronic illness that we're having to deal with.
Okay, we could obviously have a rich discussion with this panel all morning. I want to thank each of you for the time and the expertise and your continuing availability to my office and others in the state, because we do need your expertise. We have to do this all together. With that, we're going to try to keep as close to time as possible. So if folks could plan on coming back at 10:54, we'll try to keep that out. I'm going to try to keep the tight schedule. The next panel's all virtual. So we will see them kicking off at about 10:54. Thanks, everybody. Okay, if you have continuing conversations, please take them outside. And okay, so yes, you're liberated. Anybody on the prior panel can go about your business. Okay, thanks, everybody. We're going to get started with the section 2, academics and experts. We're hearing from a very distinguished set of speakers today. I'll briefly go through them and then introduce them separately as we go through. First up will be Cynthia Cox. Conversations outside, please, folks. Cynthia Cox of the Kaiser Family Foundation. Then we're going to go to Christine Monahan of the Georgetown Center on Health Insurance Reform. Then we're going to have Lauren Adler, who is Associate Director of the USC Brookings Schaefer Initiative for Health Policy, Michael Bailett, President of Bailett Health, and Maureen Hensley Quinn of the National Academy for State Health Policy. And then we'll have another discussion period. So with that, Cynthia Cox of Kaiser Family Foundation, if you are on, the floor is yours.
Hi. Okay, I'm going to share my screen for the slides. 1 second.
And Cynthia and other speakers, I'm going to give you a 3-minute warning when you have 3 minutes left.
Okay. All right, can you see my slides?
We can.
Okay, great. So I'm Cynthia Cox of the Kaiser Family Foundation, or KFF, and I'm joined here by my colleague Jeannie Fuka-Stampenik, who will be also speaking about some of the actions that states are taking to address prices for healthcare services. So I just want to take a step back and kind of recap what I said in the last session and what others have also spoken to, which is, and also to explain why our presentation, and I think a lot of the others on this panel, are going to be focused on prices for healthcare services. And that's because, of course, as we all know, the US spends a lot more money on healthcare than any other country. And the main driver for that difference is what we spend on inpatient and outpatient care. That's about 75% of the difference in what we spend versus what our peer countries spend. And when you break that spending down into its components of prices and utilization, you can see that Americans use less healthcare in some ways. We just pay higher prices for the health services that we're getting. So that's why we're focused on healthcare services in particular, or inpatient, outpatient care, and also why we're focused on prices. This is not to say that hospitals or physicians are bad actors here. Is not to single them out in any way. It's just that if you're looking at where our healthcare dollars are going, it's hard to imagine any meaningful dent being made in healthcare costs without looking at the prices for inpatient and outpatient care. And of course, this has implications not only for the economy broadly, but also, of course, for household budgets, with millions of Americans owing medical debt. So what are states doing to address prices for health services? These are not an exhaustive list of either states or actions, but these are just some noteworthy examples that we're going to walk through today. And also just want to make clear that at KFF, we're not making any policy recommendations. We're just showing some options that are out there that other states are doing. So I'm going to start off by talking about the public option plans in Washington and Colorado and just showing some early results of how those programs are working. And then Jeannie's going to take on price regulation, which includes price setting, price caps, and price targets. She can also speak to global budgets and spending growth targets, but in the interest of time, she's really going to focus on the second section here. So taking a step back, the phrase public option gets kind of thrown around to mean a lot of different things. So, some people might use it to refer to a option to buy into Medicare or Medicaid. But what Washington and Colorado are doing is very different. They are both implementing their public option through private health insurers. So these are the same insurers that are already offering in these markets. In Washington, those insurers have the option to participate. In Colorado, they're required to participate. These are both pretty new programs. This right now we're about a month into Colorado's program. Washington's been around for a couple of years. So it's still really early to say how they're working, but and I think others on the panel will go into more details here, but in Washington, the way that it works is that the state is regulating what prices insurers can pay to providers and setting that at a certain percent of Medicare. In Colorado, it's more aimed at setting premium reduction targets over a period of a few years. And then after those years, there will be further steps potentially that might involve price regulation too. So just to recap, as I said, in Washington, it's optional. So it's a public option that's optional for private insurers to participate. So what that means is that there's some counties with no public option, there's many with only one, and some with a couple maybe, but it's not very broad participation. And in Washington, in the first year when this public option rolled out, only about a handful of people actually signed up for the plans. It rounded to 0% of enrollees. But now a couple of years in, it's up to about 12% of enrollees are signing up on the public option in Washington. In Colorado, again, this is, we're about a month in, and they have already enrolled about 13% of their exchange market into a public option plan. So just to give some kind of quick overview of how it's working so far, again, this is still very early on. And I also want to point out that we're in the midst of a pandemic. So it's really hard to say kind of what are the main drivers right now of these price or premiums. But in Washington, I want to point out that, a lot of insurers are not participating. In Seattle, there's one insurer who is Ambetter that is offering a public option plan that is lower cost than their other plans, but it's just barely lower cost. It's about 2% lower than their next lowest cost plan that's not a public option. And then there's another insurer that's only offering a public option in Seattle, but most of the insurers are not even participating. In Colorado, all of the insurers are participating because they're required to, but only one of the insurers there set premiums lower for their public option plan than they did for their other plans. The other insurers are pricing their public option plan higher than some of their other non-public option plans that they're offering on the market. And, when you look at the insurers that are pricing their public option plans lower than their non-public option plans, they're both, Ambetter and Denver Health already happen to be some of the lowest cost plans on these markets. And Denver Health, which offers the lowest cost plan in Seattle, and it offers a lower cost public option plan than any of their other plans, they are the only insurer that actually reduced premiums coming into 2023. All the other insurers raised rates. So again, both these programs are new. Enrollment is still fairly low. Insurers participation in Washington is also not very robust, and we're in the midst of a pandemic. So it's really hard to evaluate how well these programs are working so far. I think it'll just take more time to tell. So with that, I'm going to pass it over to Jeannie, who's going to talk about price regulation. Jeannie, can you?
Yep.
I'll just continue the slides for you.
Okay, perfect. Thank you. So Cynthia said, I'm going to talk about price regulation, and I will cover price setting, price caps, and price growth caps, the key design choices, trade-offs, and some additional considerations that apply. These are all part of a report that we published last spring that we can point people to if there's interest. Generally, price regulation aims to constrain prices or price growth directly, and this is because, as we've all already said and discussed, prices are what are driving healthcare spending. For each of the options that I'm going to talk about, It can apply to all prices for all services or a subset of services, and can also apply to all providers equally, or could be applied more narrowly, for example, to target just high price providers. So price setting establishes a fixed price for each service, which is usually based on a fee schedule. There is a long history of price setting in the United States. Medicare is perhaps the most well-known example. But in the 1970s and 80s, many states also implemented hospital rate setting systems, including Connecticut. Maryland is the only state that still has some version of that still in effect, but it was popular at one point. The main design decision for price setting policies is how to set the fee schedule. You can base this on Medicare, you could base it on prevailing rates in the commercial market, but deciding what to set that fee schedule based on. Additionally, policymakers can decide what services, as I said, all of these policies could apply to a set of services or more broadly to all services, as well as what providers and potentially even what payers. And then the decision about how to set the fee schedule will have implications for provider finances and incentives. So that can then translate into implications for patient access and potentially quality, especially if it's very aggressive. And so that's something to keep in mind. Setting relatively low prices in the hopes of achieving greater savings can have some undesired effects. Another thing to keep in mind is the complexity. The hospital rate setting system states had in place decades ago grew increasingly complex over time in most states, and ultimately lost the support of stakeholders. And so that is part of the reason why those fell apart and are no longer around. The last thing to mention on price setting is the interaction with alternative payment models. So those move payment away from a fee-for-service basis and are, they're becoming increasingly popular and more common. And so how to treat price setting in that context has to be considered in order to get the implementation right. The next policy option, see if you want to advance the slide, is price caps. Price caps limit the maximum price for a service or set of services without setting the exact amount. So this preserves a role for market forces to influence prices under the caps and allow prices to vary to some extent. Montana, Oregon, and Washington have all implemented some form of price caps, though Montana has actually shifted away from that beginning in January of this year. And that was in the context of their state employee health plan. The design considerations here are similar to those for price setting. How do you determine the caps? Do you base them on Medicare rates, for example? In Washington State, for their public option plan, it was 160% of Medicare rates was the cap for prices. Do you apply them both in and out of network? You could apply just out of network. That's in some ways similar to the case, what is happening for Medicare Advantage, for example, because there's essentially an out of network price cap because the price would default to traditional Medicare. And then do you include a price floor to make sure that the prices are not too low, particularly for certain services? The appeal of this approach is that it can be less disruptive than price setting, especially if the caps are set at a level that really only applies to the highest prices. And an additional consideration here is that if the cap only applies to a subset of health plans, such as the state employee health plan or a public option plan on the state's marketplace, providers could choose not to contract with that plan. You might see market exit in that case. And then the last price regulation option is price growth caps, which constrain how much prices can increase over time. For example, usually it's limited to a measure of inflation plus 1 percentage point. The primary consideration for price growth caps is selecting the index and methodology used to determine the allowable changes in prices. Usually these types of caps, as I said, are pegged to something like CPI, medical price inflation, or potentially GDP growth. And then, it could be plus or minus some factor. And you can also change that over
Jeannie
time.
and Cynthia, 3 minutes.
You can also have different price growth caps for different providers based on their existing relative prices or their risk for price growth. So in a consolidated market, you could have a tighter price growth cap. Compared to the two other options I've discussed, price growth caps can be less disruptive, which may be appealing. However, they can also lock in price variation, which is something we have quite a bit of, and there may also be an interest in reducing that. So this policy would not help achieve that goal. And just the last thing I note is that these last two options, the price growth caps and price caps, can actually be used together. And with that, I think we will conclude. Thank you.
Okay, great. Thanks so much. And we'll look forward to hoping you can hang around for some questions after the panel. Next up is Christine Monahan from the Georgetown Center on Health Insurance Reform.
Good morning. Let me also try to share my screen. Okay, can you see my slides now?
Yes, we can.
Great. Okay, so good morning, everyone. My name is Christine Monahan. I'm an assistant research professor at Georgetown University Center on Health Insurance Reforms. Thank you so much for having me here today. For those of you who are not familiar with our work, SHEER is situated within Georgetown's McCourt School of Public Policy. We are an independent, nonpartisan policy and research center founded in 2011 with a mission to improve access to affordable and adequate health insurance by providing balanced, evidence-based research, analysis, and strategic advice. We're primarily funded by foundations, and much of the information I'm going to speak with you about today comes from projects supported by Arnold Ventures, West Health, and the Commonwealth Fund. My colleagues and I are very appreciative of their support. And so, I know we're here today to speak about healthcare cost containment, and in my opinion, and echoing what you've heard from Ted, Cynthia, and others earlier today, I think if you're hoping to achieve meaningful healthcare cost containment, you need to think about how you can limit healthcare prices. This includes both provider prices and pharmaceutical prices, although I will be focusing my remarks on the hospital provider side. This is not to say that there aren't savings to be had elsewhere in the system. There are a lot of opportunities for cost savings, but the primary driver in cost growth is healthcare prices, and we're not going to get very far in making healthcare and health insurance more affordable if we don't do something about that. And the reality is that care is becoming increasingly unaffordable, including for people with, quote unquote, good insurance. And so the proposals I'm going to speak about today are steps. Some of them are baby steps, some of them are a little bigger, but they aim to start moving us in the direction of being more conscious and deliberate about the prices we are paying for care. How much of an impact they will have will depend on some variables. You may be able to ramp up or down depending on how aggressive you want to be, including which providers, services, patients, or insurance markets you target, and how intensely you try to crank down prices within those segments. No single one will address the whole problem on its own, so you might want to pair some of them up. I would also encourage you to set up a monitoring system so that you can assess the impacts of any changes you make as you go and be able to respond and make adjustments along the way. And so to that end, there are a lot of places you could start. I'm going to focus on just a few that I and my colleagues at SHEER have been spending more of our time on. So the first option I want to speak about today is a state public option, or in many cases, a quasi-public option. I'll start off with my quick take on the nomenclature, which Cynthia also mentioned, right? So traditionally, public option is this government insurance plan offered to compete against private health insurance. And under this model, the government administers the plan and bears the risk of any claims. More recently, we're seeing the phrase used to talk about programs like in Washington, Colorado, and enacted in Nevada, where the state contracts with or requires private insurers to introduce new plans into the market for which the private insurer bears the financial risk. But like traditional public options, these new plans are intended to compete in the private market, expand consumer choice, and have greater public influence over the plan premiums, benefits, and networks for the new plan options compared to traditional private plans. But they do this without the state taking on the same level of administrative responsibility or financial risk of a traditional public option plan. There are a lot of ways to structure and design a public option at the state level. I would encourage folks to check out this online resource center that we've created at SHEER. The website's on my slide. There's a lot of information on the different models, design considerations, and various resources on this topic. From a cost containment perspective, I want to emphasize a few of the most important considerations. The first being, of course, what is your actual cost containment mechanism? Here we've seen a split among the states that have moved forward, with Washington capping how much the public option plans can reimburse providers in the aggregate, and Colorado and Nevada instead setting premium reduction targets for their public option plans, as Cynthia mentioned. My take is, in Washington, I think the 160% reimbursement caps aren't really low enough to be really driving down premium levels, at least not, when applied in the aggregate. The cap is basically close to where some of the lower cost plans in the market already were, as Cynthia alluded to. And, what it seems to be doing so far is keeping the public option plan premiums from going up as much as the premiums for other plans. And so, these are often the lowest cost level plans in the state right now, but we're not seeing the 5 or 10% premium reductions or anything like that. And so as Washington continues to move forward, I think the state is looking at, what else it can be doing. And so that might be, more targeted service or geographic specific caps, lowering the reimbursement cap, or potentially adopting a premium reduction target on top of its cap to put down more downward pressure on premiums. In Colorado, the premium reductions that are in place right now, it's 5% this year, 10% next year, 15% after that. But as Cynthia mentioned, only one carrier actually hit its premium reduction target for all of its plans across the state this year. But I think a big thing to know that is there wasn't an enforcement mechanism really for the premium reduction target so far. And so for the upcoming plan year, plans that don't meet the target will actually have to go through very involved public hearing process. And during this, they'll have to name any providers that they hold responsible for keeping the plan from meeting the targets because the providers were demanding too high reimbursement rates. And then they'll all submit evidence, and ultimately the commissioner will need to decide if in fact the provider was responsible. And if so, the commissioner can set that provider's reimbursement rates and order them to participate in the public option plan network, subject to certain floors. And so we'll be watching that closely to see how it plays out. The second main design consideration to think about is provider participation. Here, I think there's generally consensus that you can't simply leave provider participation to be totally voluntary, especially when you want the new plans to be driving down costs and they have little or no enrollment to start with. So the question is, what hook you use to get them to participate. In Washington and Nevada, they require providers to participate they require providers that participate in the state employee benefit programs, Medicaid programs, to contract with the public option. In Colorado, instead, it has this kind of curing process where plans might be ordered to contract with a public option. And finally, the other big issue, and Cynthia was alluding to this as well, is how much cost containment you have will depend on, how many people are in these plans. And so that will depend on, what market are you in? Are you in the individual market or also a small group market? Or do you actually reach out to the large group market? You'll also want to think about how you get the public option available statewide, and that connects to this provider participation requirement. And then finally, how do you get people to enroll? Obviously, lower premiums and good networks will do most of the work, but I think introducing a new plan in the market can be challenging, especially when most people tend to re-enroll in the plan they were in last year. So you'll want to think about how these plans are displayed on the marketplace, how they fit into your auto enrollment policies, what sort of marketing campaign you want to do to promote them, and keeping in mind that that could create some resistance from current carriers if you're perceived as favoring the public option. So that's a delicate dance. Ultimately, I think the public option, you don't want to oversell the impact it'll make from the cost containment standpoint, especially in the first few years. But rather, think about this as a kind of step-by-step process. And this is a way to introduce more state regulation or state regulation provider rates and health plan premiums. And you can only do so much so fast. So then I want to talk about enhanced rate review. This is where regulators are considering whether the rates are affordable for consumers or whether the provider reimbursement rates that undergird the insurance rates are reasonable. A popular version of this would explicitly allow the insurance department to consider affordability of premiums, or more generally the public interest when setting rates. Rhode Island, Delaware, Vermont are examples of states that have brought in affordability lens into the rate review practices. So you may want to look to them as models. Rhode Island, for example, has given its Office of the Health Insurance Commissioner a very broad mandate to push back on hospital rates if they're driving premiums too high. And research has suggested that this has been effective at constraining spending growth through lower prices. Delaware is following in Rhode Island's footsteps. And while not explicitly framed around affordability, Colorado is effectively taking a somewhat similar approach with its Colorado option plans, as I just described. Vermont's law is a little more general, including affordability and access to healthcare among standards that the Green Mountain Care Board can consider when reviewing rates. In general, going down this route, you'll also want to think about what data and information you have available to you. Are you able to see negotiated reimbursement rates? Can you review the contracts? Can you disapprove the provider contracts if they don't meet certain standards? Although to my knowledge, these provisions have not been used in this context, both Washington and Pennsylvania have authorities that you might want to review. In particular, Pennsylvania's law allows the insurance department to reject a provider contract if that contract provides for excessive payments, fails to include reasonable incentives for cost control, or contributes to the escalation of the cost of care. Now turning to facility fees. This is a topic I've been digging into a lot recently, and I can tell you Connecticut is leading the way here, but that doesn't mean that more cannot be done. In particular, I think there are 3 potential expansions you could consider that you can see on my slide. Ultimately, the idea is to eliminate facility fees for services and procedures that are not complex and that can be safely and appropriately done in a physician's office. MedPAC has taken a look at this in the Medicare context and recommended 57 codes on top of evaluation and management codes that they suggest fit this bill. Reasonable minds might disagree over this service or that service, and so maybe you end up with a slightly broader and narrower list than where MedPAC has landed. But I think Connecticut has room to expand from where it is today. And to that end, one example at the state level you might want to look at is some legislation that's been introduced in Indiana. Their proposal would prohibit providers from charging a facility fee for any office settings, regardless of whether it's on or off campus, with some exceptions for critical access hospitals and other specific circumstances. Now, I'll be upfront and say that unlike in the Medicare program, prohibiting facility fees in the commercial sector will not necessarily result in huge macro level healthcare cost savings, at least on their own. Hospitals can make up for the lost revenue, excuse me, by increasing their charges somewhere else. But this reform, perhaps more than the others I'm talking about, can generate significant cost savings at the micro level for individual consumers who may be getting hit with these fees through their deductibles and cost sharing structures, or if their plan's not covering them. And so from a patient affordability perspective, this can be really huge. And even if its impact at the system level may be small, making this change also, it's an important step to being more rational and deliberate about how we pay for healthcare. For the services we talked about, like those on MedPAC's list, I think it makes sense to just have one bill that reflects the cost that went into care rather than multiple bills coming in, maybe at different times from different entities where the plan might not even know where and when the care took place. There's just one bill. Plans and providers can negotiate over what the appropriate amount should be. Regulators can track that and see if they agree if that price is reasonable, or maybe at some point the state decides it is not and chooses to come in and set some caps or limits on price growth. And then finally, the last proposal I want to talk about today are out-of-network price caps. With these, as you kind of just heard, a state would set a maximum rate that insurers could pay for out-of-network care. This cap could be set for specific services. A variety of this idea has already been implemented in many states to protect consumers from surprise bills. But for a broader impact on health system costs, you may want to apply it in all out-of-network circumstances. Among the options I've been discussing today, this would likely have the biggest impact. In some ways, it's simpler. Unlike a public option, you don't need to create a new structure, and the caps could apply across the commercial market and not just to public option plans. It would also have the greatest impact on the highest cost players, as it takes the distribution of prices across plans and squeezes them towards each other around wherever this cap is set. And as you just heard in the last presentation, there's also reason to think, based on the experiences in Medicare Advantage, where plans can't pay out-of-network providers more than fee-for-service rates, then an out-of-network cap can increase an insurer's leverage in negotiations and bring down in-network rates. To the extent Connecticut were to implement an out-of-network price cap, you would need to consider at what level to set this cap and the process used to set it, whether you'd want to vary the cap to adjust it for different market conditions. Generally, you're often looking at using either a percentage of Medicare rates or some benchmark within commercial rates, like the median and network rates, to set your cap. There can be pluses or minuses to either approach. I'm a lawyer, so I will defer to the economist to weigh in on that specific choice. But I'm certainly convinced there's a lot of merit to this general approach.
Professor, 2 minutes.
And great. Well, finally, I just want to, before I turn things over to next speaker, I want to briefly emphasize that legislators should think about the resources and information they and state agencies will need to implement, enforce, and monitor any of these proposals if they become law. Connecticut is already a step ahead of many states with its Office of Health Strategy, but it may need more resources and staff if more initiatives are undertaken. The insurance department likewise may need additional resources. Insurance regulators are used to looking at things like solvency and actuarial value, but healthcare prices and affordability are a different story. And so they'll likely need increased staff, IT resources to do this work, and that might take some time to get. Now is a great time to be doing this because there's so much information out there and it's being processed in ways that can make your lives easier. I'm sure all of you are familiar with some of the new analytical tools and reports that have come out just in the past year or so, including RAND 4.0, Nashby's Hospital Price Tool, and Sage Transparency. Definitely use them, take advantage of them. Additionally, here at SHARE, it's our understanding that state insurance departments have authority to enforce the new federal transparency and coverage rules for the fully insured market. And so you may be able to dictate how this information is being posted publicly, make sure it's being posted. If you want to talk about how you can do that or want to help just dig into the data that's being released, please reach out. With support from Arnold Ventures, SHARE has teamed up with the team at Wakely, and we're available to provide technical assistance to states that want to use this information. And I can put you in touch with the folks doing that. So yes, thank you all for having me today. I look forward to the discussion that will follow. And again, I and my colleagues remain available to talk further about these and other ideas offline as well.
Well, thank you, Professor Christine Monahan from the Georgetown Center on Health Insurance Reform. We appreciate that. And thank you for being able to stick around for questions at the end of this panel. Next up, we'd like to welcome Lauren Adler, who's the Associate Director of the USC Brookings Schaefer Initiative for Health Policy. Lauren, if you're on, go ahead.
Great. Yes, thanks for having me. Let me know if this is sharing okay for the slides here. Thought I saw it pop up for a second there.
Yeah, we can see the slides.
Okay, perfect. Thanks. So thanks for having me. My name is Lauren Adler. I'm a fellow and associate director at the USC Brookings Schaefer Initiative for Health Policy. I'll be talking about sort of options on the making Connecticut healthcare more affordable. Having heard Christine's presentation, there's going to be a fair amount of overlap, but I'll try to harp on some additional details as I go through here. So first, I think, as Cynthia did in her beginning of her presentation as well, I think it's good to sort of level set here on, so there's some question when we're talking about provider prices, drug prices here, and sort of focus on the provider price angle here, right? What should prices be? And right, I think in general, the goal here, in my view, would be to have prices high enough to cover an efficient provider's cost of delivering appropriate quality care and no higher. So it's not there's sort of extra rents being taken out of the system. And right, the high prices have a lot of consequences. There's clear financial burden on consumers. There's higher cost sharing and high deductible plans just in general. And also, obviously, the government, both state and federal governments are paying money to subsidize that care. It leads to underconsumption of care when there are high prices at the point of service and high premiums to get insurance plans, and also can lead to inefficient care delivery. But obviously, right there on the flip side here, there's reason to be nervous that if we have inadequate prices, that it could hinder access to care or reduce the quality of care that patients are able to get. So taking a step back here, again, I think Cynthia kind of did a fair amount on this already, but we have a fair amount of evidence that prices are quite high in the US, right? There's the international comparisons that we tend to pay substantially higher prices. We pay very high rates relative to Medicare, and those have grown substantially over time. I think the other piece of evidence, which isn't on the slide here, but just the other fact here is that we have very widely varying prices that seem unexplainable by local wage differences and that sort of thing. Those give rise to the thoughts that at least in some areas of the country that we are paying inefficiently high prices. So I'm going to walk through just sort of three sort of big picture options here. I a lot of the stuff that's been talked about already. I think Christine's focus on the site neutral payments is important as well, but I'm going to focus here on public options, this enhanced rate review option, from Rhode Island and other states, and go a little bit more detail on some of the out-of-network cap questions here, which I think will bleed into my viewpoint on that has some advantages over these other options. So the public options, we've heard a lot today about these recent efforts in Colorado, Washington, and Nevada. Right, I think that they're all going to kind of get to these big questions here, and I think if the state of Connecticut is thinking through what to do here, you're faced with a few big questions. I think one is states really haven't done this yet, but you could actually administer a public plan that looks something like traditional Medicare, where it is, the plan itself is establishing what it pays providers, that has some sort of fee-for-service schedule. It could even sort of, glom onto some alternative payment models that Medicare uses. That obviously adds a lot of complexity, particularly at the state level, to sort of figure out what every individual price should be. So I think that's sort of why states have sort of leaned towards this process of contracting with private insurers to administer these plans. Right, and then there's these questions of what markets to offer the public option in. Right, the states so far have been focused largely on the non-group market. Some have made these available in the small group market as well, but there's nothing in action. So right, you could, especially if the state were going to create their own public option, you could create an option where employers could subscribe to this public option plan as well, and sort of offer it in the large group market too. That's going to be, depending on the way this is all set up, might be easier in the fully insured side of the market than the self-insured. But if it's your own plan, then it can be, self-insured employers can make their own decisions here. Then you're going to have these questions about benefit design and network design. I think, some of these ways, right, if you're going to contract it out to an insurer, I think sort of a natural way to think of this is, to take Colorado for the example, which I think has some advantages over the way the other states have done this, in that, look, we have strong network adequacy rules in Colorado, and the plans that you are offering each insurer, have to have at least this sort of minimum level of benefit and network access that are going to be there. And really, the key question here at all of these public options, in my view, is how are you actually generating premium reductions, right? I don't think there's sort of, some people sort of talk about this in more of the insurer competition, right? We're going to add a public option to sort of inject competition on that side of the market, but especially when you're kind of running this through private plans, that's only going to do so much. The real key, right? A lot of these states, in Colorado, for instance, says, look, you are required to reduce premiums by, you can set it however you want here, right? And I think the glide path here that folks have talked about is useful, where, reduce premiums by 3% in 1 year and 5% the next year, 15% by year 5, or however you want to do it. It's one thing to tell plans to reduce premiums. The only way that's actually going to function in practice is if there is an enforcement mechanism. So, right, you could do, Washington just sort of says, here are the rates. I think it is somewhat difficult to actually just sort of pick the rate across the market like that, especially if you are also creating a price floor. And one thing that gets missed in these conversations is that, particularly we've generally been focused on the non-group market here. And for non-group plans, our sort of theory that we've been operating on is that insurers are actually sort of paying slightly lower hospital prices in the non-group market already. So that 160% of Medicare in Washington actually often isn't really a reduction, or might even be an increase on what some folks were getting paid, right? I think the Colorado example is, look, if the plan is unable to reduce premiums on their own, the government comes in, state government says, look, providers, you have to accept these lower rates as a percentage of Medicare, and you have to accept the public option and treat their patients, and offer access to their patients. And having it, right, they're sort of focused on, let's figure out which hospitals have the higher prices, and therefore which ones, you can generate the largest premium reductions by sort of, effectively forcing a price decrease there. And right, that is hospital, outpatient, and inpatient is where most of the premium dollars are going. Obviously, this could also, similar things could be extended to physician or prescription drug services as well, although prescription drugs, you run into some issues at the state state level. But right, that is the kind of crux of this, is that you need some forcing mechanism and some enforcement mechanism. You can't just sort of leave this ad hoc 3 years down the road. And I think trying to lock folks into, look, we are going to generate this through lower hospital prices is pretty key here. So one other option that's been talked about a little bit today is this sort of enhanced rate review, or however you want to call it, right? A lot of states do premium rate review for insurance options in the fully insured and group and non-group markets. Rhode Island for a while has had, for several years now, has had this program basically where they, basically if the premiums are growing faster than the state might like, the state actually has sort of a provider price regulation enforcement mechanism here that prices for the, for certain hospitals under these plans can't grow faster than a certain amount. For theirs, it's, an inflation plus type of metric there. And right, that can certainly have some effect, right? It's effectively just a way to allow state regulators to enforce provider rate growth caps through this sort of premium rate review process. I certainly think that can have the intended effect. It is a little bit complicated because you have to go to this every single year. Admittedly, Rhode Island is probably easier than other states where you have a very small state and a limited number of insurance plans that cover most of the market there. I do think a couple, I think, important concerns to note with this process. One, obviously, it only applies to fully insured plans. The state doesn't have the authority to do this through the self-insured plan side of things. I also think an important part is the way this is set up, the providers may actually just be able to make up some of these price reductions on self-insured plans. As we're talking about insurers here who are negotiating both books of business, often you're actually negotiating the network prices across your fully insured and self-insured plans together. So it does seem plausible that you could just sort of, in the negotiation, nothing has actually changed the market power that the hospital has here. So the hospital might be able to say, pay me a little bit more on self-insured self-insured products, and you can pay me a little bit less on the fully insured products, but such that nothing is really changing. And the self-funded employers in the state end up kind of on the short end of the stick in that situation. And lastly, and the slide is short, but I kind of want to focus on this one for a little bit of time here on the out-of-network caps that folks have talked about. Obviously, again, you could just cap or set in-network prices. That leads to some setting in-network prices leads to some difficulties, especially because if you were going to say, plans need to pay this much, once you set a price floor, you risk distorting the market and increasing costs, actually. The out-of-network caps certainly have this sort of lighter touch feel to them because you're just saying, okay, when you're out of network, the insurance plan can't pay more than X, and right, it's very dialable, right? You can say it could set it really high so that it's really just sort of focused on the right tail of prices. So it's set it at 200% of Medicare, and maybe that's not going to have a huge effect on the market, but those high prices, the sort of far end of high prices, are driving a fair amount of our higher premiums in this country. And right, again, and it's also pretty flexible because once it is regulation on the provider, that can, if the state wants to, can apply across the state. So that can apply to self-insured and fully insured plans. So it could be, you could limit it to the non-group market if desired, but it also could easily be applied to the large group and self-funded plans. I really just want to kind of First, I think some of the advantage here is, right, there's a lot less micromanaging involved here, right? We're just saying you can't pay more than this. The idea is you're kind of trying to create a sort of default contract here that, right, if the insurer, doesn't have enough leverage over the hospital in this situation, they're sort of trying to create a forcing mechanism where the insurer can say, look, you can't really walk away because I'm just going to take this sort of other option and I'm going to pay you out of network and at whatever this sort of cap is. And then that provides the leverage to kind of force people into an actual contract negotiation. And then they can sort of work around, do they want alternative payment models? How do you exactly want to pay for care? What sort of prior auth do you need? Like all of that can all be worked out, in the actual contract process. It sort of forces people to, the government doesn't have to come in and figure all of those sort of micro details out. The key to that is that this only works if this is combined with a requirement on providers and hospitals to offer reasonable access to out-of-network patients. Because otherwise you set an out-of-network cap and the hospital goes, okay, I'm fine, you don't want to contract with me, I'm just not going to treat any of the enrollees in your health insurance plan. And you basically haven't changed their leverage at all. Right now, if a hospital goes out of network, they in general are treating very few non-emergency patients anymore of that insurance plan. So that their leverage is their ability to sort of not treat your patients, not the ability to charge exorbitant prices out of network. So the only way this really works is if you are saying, okay, it's an out of network cap at, pick your number, 150% to Medicare, 200% to Medicare, and, out of network hospitals need to offer access to patients, to the sort of out of network patients, because that's really the kind of key here, right? And then we sort of focus on this example of Medicare Advantage, but Medicare Advantage doesn't have quite that forcing mechanism. But what they have is the Medicare Advantage plans are effectively in competition with traditional Medicare, who's paying everyone at Medicare rates by definition. And right, the Medicare Advantage plan can credibly say to the hospital, I can't pay you more, I can't pay you much more than that, or else no one will enroll in my plan and they'll all go in traditional Medicare, and then you're getting Medicare rates, right? That's really the leverage in Medicare Advantage. But at the state, you could do kind of the same thing if you're sort of requiring to actually treat patients at those rates. And on that, I'll close and just sort of end with the sort of same thing that Christine said, and feel free to reach out to myself or my colleagues at Brookings. We compile a fair amount of data on these things ourselves, and are always happy to talk with folks about making policy improvements.
Thanks so much, Lauren Adler from Brookings. Appreciate your comments and hope you can stick around for questions at the end of the panel. With that, we'll turn to Michael Baylett, President of Baylett Health. Michael, are you on?
I'm here.
Great. We can see you. Go ahead.
All right. Let me pull up my presentation. Okay. Good to go, Ted?
Good to go.
All right. So good morning, everyone. I'm going to cover some of the content that the prior presenters have presented, but really from a different angle, because I'm going to anchor it in the healthcare cost growth benchmark work that other states are doing, because I have found that for most of the states that you're hearing about today, they have a cost growth benchmark that is serving as sort of the spine or the background of their affordability work. And so I want to talk about the connection, especially because Connecticut is one of a cadre of states with a cost growth benchmark. I'll then talk about complementary state strategies, many of which you've already heard about today. But what I'm going to highlight are some tools that Connecticut can leverage if it wants to pursue one or more of these complementary strategies. So first, just a little bit on cost growth benchmark activity in other states. So cost growth benchmark is per capita rate of growth target for healthcare spending in a state. It serves an anchoring mechanism by creating a public expectation about how fast healthcare spending should grow, and also is used to promote transparency on spending growth at the state level, but also at the payer level and at the large provider organization level. Connecticut is one of a growing number of states that has adopted a cost growth benchmark. As right now, there are 8 states. You can see them here in green. California is in the process of becoming the 9th state. They are just convening a new body to help set their methodology for theirs. Once California has a cost growth benchmark, 1 in 5 Americans will live in states with cost growth benchmarks. And you have seen a number of these states cited as examples of strategies to address rising healthcare price growth. So I will say that while Connecticut is one of this cadre of states, that some of these other states have taken complementary action that complements or supplements their cost growth benchmark. And there are opportunities for Connecticut to follow the would say, the innovation of some of these other states. So just so everyone's got a common understanding, Connecticut's cost growth benchmark was developed after an advisory body to the Office of Health Strategy in 2020 recommended that the cost growth benchmark be calculated as a 20%, 80% weighting of Connecticut potential gross state product, which is long-term projected state economic growth on a per capita basis, and 80% on long-term projected growth in median household income in the state. This formula resulted in a benchmark value of 2.9%. OHS adopted the recommendation and set benchmark values for 5 years and chose to initially have a add-on value on top of the benchmark value for the first 2 years, as you can see here. And then for this year, the next 2 years, the benchmark is 2.9%. So the benchmark is not an end in and of itself. It's really a means to advance improved healthcare affordability. And in order to advance healthcare affordability, it's necessary, as I said earlier, to measure and report performance at the state, market, insurer, and provider levels. It's also necessary to understand at a more nuanced level exactly what's driving healthcare spending. So if it's prices, for example, prices for which services, for which providers, and to make that information transparent along with performance on the cost growth benchmark overall. The next steps, and this has really been the focus of this session of the forum, are to identify opportunities and strategies to slow cost growth and then to implement them. And these strategies, which I sometimes refer to as cost growth mitigation strategies, are a necessary component of a cost growth benchmark strategy, because the benchmark itself just won't do enough to advance affordability. So let me share a little bit on state strategies to advance affordability. My lens is going to be the cost growth benchmark states, this group of which Connecticut is a member. So the strategies fall under the following categories. You have heard prior speakers address these, or some of them. So market consolidation oversight hasn't received a lot of attention today, but 3 of the other cost growth benchmark states, Massachusetts, Oregon, and Washington, have taken action to create some degree of control over future market consolidation. I will note that the insurance and provider markets in the United States right now, including in Connecticut, are heavily consolidated. To differing degrees from state to state, but there's been a tremendous amount of consolidation that's happened in the market in Connecticut, particularly in the provider market. And so these 3 states have taken steps so that there is a review of potential acquisitions and mergers, and a review against specific criteria that include impact on cost and affordability. And then an ability for the state in some fashion to take action if the proposed transaction is viewed as being contrary to state objectives. Affordability is not only one. For example, Oregon includes health equity and quality among the criteria that they consider. Strategy number 2 is multi-payer adoption of advanced value-based payment. So among the cost growth benchmark states, Oregon and Rhode Island have been the leaders here. Each of those states was able to work with groups of stakeholders and reach consensus on a strategy to accelerate the adoption of advanced value-based payment. And when I say advanced value-based payment, I mean value-based payment models that have some budgeting methodology as part of them in order to constrain spending growth. In both Oregon and Rhode Island, they are considering multi-payer hospital global budgets, both of those states, right? I'm sorry, not in Oregon. In Rhode Island, they're pursuing multi-payer hospital global budgets. Oregon is considering the strategy, but has not yet made a commitment to it. But in Rhode Island, they have an active work group that consists of certainly of hospital executives, but of consumer purchasers, state, and insurer representatives that are working their way through the design of a multi-payer hospital global budget model that would include commercial insurers, Medicaid, and hopefully Medicare. A third approach is prescription drug pricing legislation. Our prior presenters haven't gone into detail on this. Maureen, who's going to follow me from NASHB, may, because NASHB's been a leader here. But when we look at rising prices in every single one of the cost growth benchmark states, drug prices are growing faster than any other pricing. And that's both reflective of year-over-year increases in drug prices, but also a result of the introduction of new drugs at very high price points. Fourth strategy you've heard about, provider price caps. I'm not going to describe that any further. Also, provider price growth caps. You've also heard about this. And then last, strengthened insurer rate review authority. A whole bunch of states have pursued this. I could list even more states than the ones here. And you've heard some of this morning as well. So this is where the cost growth benchmark states are primarily focusing right now in their effort to develop strategies that will help them achieve their benchmark. Because stating a benchmark, in Connecticut stating 2.9%, that alone will probably have some impact based on experience that we've seen from states that went before Connecticut, especially Massachusetts, but probably not far enough and probably not on a long-term sustained basis. So I want to identify some resources that can help Connecticut pursue one or more of these strategies. And as one of the prior presenters said this morning, it's not likely that pursuit of only one strategy will be sufficient. Probably pursuing a few different strategies that get at different cost drivers and especially price drivers will be important. So I'm going to highlight two different sets of resources. The first from Catalyst for Payment Reform, and the second, a series of implementation guides that my colleagues and I recently authored for the Commonwealth Fund. So Catalyst for Payment Reform just published a few weeks ago this wonderful publication that focuses on state policies to constrain commercial prices, and as you can see in the title, rebalance market power. They have focused on price because, as many have observed, it's price and not utilization that's driving spending in the commercial market and harming affordability. And they developed this with an advisory committee. They specifically excluded certain strategies. I'll note, they excluded pharmaceutical prices. You'll see the same in the Commonwealth Fund guides that we developed. I want to emphasize pharmaceutical prices need a lot of attention because in the commercial market, retail pharmacy alone can represent 25% of spending. And when we include physician-administered drugs that are not retail pharmacy, then we start inching towards 30% of total spending is pharmacy. So there's a very nice organization of strategies in this tool. Here's a figure that depicts their categorization. So Catalyst for Payment Reform identified these four categories: banning or punishing what they describe as bad market behavior. 2, preventing further erosion of competition, noting, as I did earlier, that we've already had tremendous market consolidation, and so competition is limited in many insurer and provider markets. 3, regulating costs and prices. And 4th, building infrastructure that helps a state understand healthcare spending and design and implement cost growth mitigation strategies. So this is a very nice tool that I recommend for consideration. The Commonwealth Fund implementation guides are a little bit different. These provide step-by-step guidance for how to design and
2-minute warning.
Thank you, Ted. These provide step-by-step guidance for designing and implementing 5 different cost containment strategies that are the source of lots of activity in states. Again, pharmaceutical strategies are not included here because of the voluminous work done elsewhere. But these 5 guides, if there's interest in Connecticut in pursuing any of these 5 strategies, I think can be a helpful resource. They outline steps such as defining goals, establishing oversight, determining who should participate in the process, and then they outline a series of key design decisions for states as they develop a strategy. There are examples drawn from states that are already doing this work, and the 5 guides are available to be downloaded from the Commonwealth Fund website. And last, I just want to summarize, there is certainly ever-growing focus on the failure of the commercial market to constrain healthcare spending growth for consumers, employers, and also say for taxpayers. And the level of attention seems to be growing at a fast pace right now. There's no question that rising prices, in large part resulting from diminished market competition, and frankly, the absence of other strategy options, are making direct regulatory approaches more appealing in many states than they have been in the past. I've been doing this work long enough to remember when we were primarily looking at market solutions to slow healthcare spending growth. I would say that is no longer the case in many states because of conclusion that our market strategies haven't worked and our markets are now so consolidated that it's hard to imagine how they would. Hold on there.
Michael Billett from Billett Health, thanks so much, and we hope you can stick around for some questions. The next panelist is Maureen Hensley Quinn. Maureen is with the National Academy for State Health Policy, where she's a senior program director. Maureen, if you're there, please go ahead.
I am. Thank you so much. And I, like other speakers, will pull up my slides. Great. Okay. Can you all see that deck all right?
We sure can. Go ahead.
Perfect. Well, first, I just want to thank Connecticut so much for this forum. I so appreciated the forum that helped really build the case for why healthcare costs are important. And I will also just flag, as others have throughout the morning, that Connecticut really is a state leading in this area. I know there's more work to be done, but just have to recognize the commitment by the state, and that's clearly shown today. So just a quick note about NASHP. We are a national nonprofit, nonpartisan organization that is committed to helping states with innovative health policy. We have been working with state officials specifically across a large range of issues and topics, but relative to the conversation today, we do have a center on prescription drug pricing and a center on hospital and health system costs that is designed to help pull together state officials to identify areas of interest and need, and then identify solutions. And so I'll be sharing some of those today. So this slide is just meant to show the variety of different policy approaches that are available to states to address prescription drug costs. I'm going to focus on prescription drug costs first and then move to hospital and health system. As you can see, there's a range of options available, from transparency to active state purchasing, limiting price increases, and then setting upper payment limits. I'm going to focus in today on stronger PBM contracting and international reference rates, because there is a strong interest from states in those areas. But I would just highlight that across this menu, there's opportunities for states, depending on what problem you're looking to solve. So regulating PBMs, as was heard earlier this morning, PBMs representing sort of the middleman in the drug supply chain, it is important. States have voiced this to us. that there is a need to gain transparency to understand the role that PBMs are playing, to understand if there is an increase in cost due to spread at the point in which PBMs are working between manufacturers, pharmacies, health plans, consumers. And a number of states have sought to increase transparency, to protect consumers by banning gag clauses, increasing licensure and registration at the state level to understand who is participating in their markets, to limit patient cost sharing, and then, as I said, increase transparency. I will highlight that one particular issue related to PBMs that more and more states are looking at is this issue around assigning fiduciary responsibility. Not only do states care about this, but employers within states have started talking to NASHP a lot about how to better understand and have health plans and PBMs take a fiduciary responsibility. I will point to one particular model law that NASHP has developed with state officials, and a state has passed this. We really designed it based off of a law that was passed in Maine that does put regulation of PBMs within the State Department of Insurance by making health plans that contract with PBMs a fiduciary for those contracted PBMs. It really diminishes the finger pointing between the health plan not taking ownership over their contract with a PBM. More recently, because of the Rutledge Supreme Court decision that cites that states can have some oversight over third-party administrators and contracted entities like PBMs, there is increased attention at the state level in looking at regulating PBMs. However, I will note regulation of PBMs alone does not affect price. I know that was stated this morning. States have found that to be true. Our work at NASHP, we found that to be true. And so pairing regulating PBMs and trying to get a better understanding of the drug supply chain with looking at actual price is something many states are trying to do. It's not easy, it's complicated to do. However, NASHP does have a model. We worked not only with state officials, but with legal experts to develop this model. Essentially, what it's aiming to do is import, if you will, international prices rather than the drugs. And I'll just point to a model law we have in a white paper that really works through all of the analysis and background of thinking about this. But as many of us know, even looking at our neighbors in Canada, their price difference is pretty dramatic. And this slide just highlights some examples of the difference between what the US prices versus the Canadian price and the difference between them, and what kind of opportunity may be available for savings by going the reference price route. We have also been talking with states quite a bit about referencing the negotiated prices that HHS will be achieving as a result of the Inflation Reduction Act. We know that Medicare and CMS are undertaking, looking at negotiating directly with manufacturers to get a lower rate on a limited number of drugs, specifically for Medicare. So the federal law does not extend to the commercial market, does not extend to many state purchasers. However, that's when states came to us and said, we want to do the reference-based pricing, but not internationally to what Medicare and HHS will develop. So we did create another model that's very new. I will say pairing the two together may be the most sort of comprehensive way to go. So putting in a state statute that the state could reference-based price internationally and to the Medicare negotiated rates. As this is very new and the negotiations have not started yet, so we're not clear on exactly what those will produce. So having these two different, more comprehensive approach is something that NASHP is highlighting for states. And a little bit about the process of the Medicare price negotiations. I won't go into great detail, but I will just flag again that we do have a model law specific to this. So I'll turn my attention to hospital and health system cost as well. I'm not going to go through all of this. I know today you've heard a number of different experts share many of the policy tools that are referenced here, but I will also just flag sort of the range that states have available to them. So again, transparency is critically important, addressing consolidation, addressing rising spending, and then high prices is sort of how we have bucketed the work that NASHP's been doing. Again, working directly with state officials, addressing consolidation has been an issue from the beginning of our work. As Michael Baylett highlighted, it's a very consolidated market already, and many states said, we want to be able to better navigate an already consolidated market. And so looking at barring anti-competitive health plan terms from contract language that health plans have with providers is something that an increasing number of states are looking at and that a number of different employers are very eager for. Nevada is an example that has done this, and NASHP does have a model law and policy brief that walks folks through this. I also want to highlight that there are other anti-consolidation measures states could take, but looking around at something that could help health plans rather immediately better negotiate with large systems is what is drawing much attention to this policy. This has been talked about at great lengths, so I don't want to harp on this, but I will just share that we have been lucky enough to work directly with Rhode Island to produce a toolkit that includes model law language and, importantly, where Rhode Island has gotten most of the bang for their buck has been in developing regulations. And so we do have model regulations for a state should they want to pursue the opportunity to use rate review to incorporate affordability standards that would have an opportunity to keep reimbursements from health plans to hospitals at a capped rate, and then encourage further investment in primary care. And then this has been talked about at great length too, which I'm thrilled about, but limiting out-of-network hospital payments, I will flag for you all. One of the reasons why NASHP undertook this was because states were approaching us with absolutely the desire that was already voiced that capping out-of-network rates could really incentivize better in-network rates to be negotiated. However, I'll also flag to add some additional context to this discussion. We've also seen around the country that there were very large health systems very publicly battling with major payers in their area, threatening to go out of network. States really felt like, what can we do about this? I will just speak on behalf of, I'm living in Maine, and that the major hospital system that is providing care to 80% of the Portland area, fighting very publicly with the major health plan that covers most people here and that most employers have engaged with, really was very problematic. And there was no stopgap that the state had available to try to keep both of those parties at the negotiating table. They ultimately did work things out, but having this law in the books to have a consumer protection, if that doesn't happen, is something that states wanted. We really modeled the law to help states create this, because there are details that states will have to consider in turning the theory of out-of-network caps into a reality. We modeled this off of Oregon's law that has been in place. It has been in place just for state employee health plans, but they have been successful at using 200% of the Medicare rate for in-network rates and using 185% of the Medicare rate for out-of-network rates. And it has encouraged many folks to go in-network. And so with that, I'll wrap up and would be happy to point you to the direction of our websites that have all of these resources and more, including our hospital cost tool, which I did not talk about because I know that was discussed at the first forum, but NASHB is available thanks to Arnold Ventures to provide technical support as needed. And I just really appreciate being part of this panel and Connecticut's openness to talking about all of these varied options to a very complicated issue. Thank you.
Thank you. That was Maureen Hensley Quinn from the National Academy for State Health Policy. Thanks so much. Now we're going to open it up to the moderators in the panel for questioning. I was going to inquire for Commissioner Mays first. If you're there and would like to jump in, please go ahead.
Thank you, Ted. And I've got a bunch of questions, but I'm just going to ask one for now. If we've got time later, I can come back to the others. Maureen, you're on my screen, so I'm going to direct it to you. And this is a real world issue that I face as insurance commissioner. We've got, finally, we have the cost growth benchmark in place. Okay. We have let's just say hypothetically, we have a hospital system that is in negotiations with an insurer right now, and the insurer is saying, you know, the commissioner told us we got to live by these benchmarks, and the hospital system says fine, then we're just not going to sign with you without any kind of limitation, without, you know, for instance, the Medicare rate that you mentioned. How do we address the provider side of this? Because it seems to me that creates a greater imbalance in market power than anything else, and it would be great to be able to address that.
It's a great question, and I'd look to other panelists to weigh in on this too. I will say, so making sure that there's access is at the core of what all of this is trying to do. Making sure there's affordable access is at the core of what we're all trying to do. So part of what I would do in that case is look to data, and there's a lot of it out there at this point. But as NASHB has been lucky enough to be included in some conversations between hospitals and health systems where there is huge pushback on either a state or a large employer trying to negotiate lower rates. And so rather than just saying, no, we're not going to talk, we've encouraged using our hospital cost tool data and then walking through all of that to say what we don't want to do is set a reimbursement rate at something lower than what your costs are. But we also have to understand what's driving your cost. And so having a more holistic conversation about what's driving the health system wanting to walk away. And there is a variety of different things that are coming up right now. Inflation is real, that we recognize that. Staffing constraints are real. However, those usually aren't the pieces that are forcing a health system to not be able to afford to work with others to lower rates. And so there have been other things that have come up, but it's been data that has helped surface some of that. And so I would just encourage leveraging data, supporting health systems and health plans to talk through that. But I do think having the cost growth benchmark as you do to be set, here's what we're expecting, is incredibly helpful. And then also, I would say that in setting the rates for hospital rates, if there could also be a conversation about where maybe some rates actually may need to be increased if the data supports such a thing happening so that the health system can support access overall. But it's a very complicated issue and one that I think data is essential to help support.
Thank you.
Thanks, Maureen. Are there any other panelists that want to weigh in on that question from Commissioner Mays? If so, go ahead.
Yeah, Ted, I'll add. So this is where the proverbial rubber hits the road with a benchmark strategy. And we know from states that have cost growth benchmarks that have had some effectiveness, it's because the insurers and the contracting providers are able to negotiate using the cost growth benchmark as a reference point. So these are difficult conversations. I will note that transparency around provider performance relative to the benchmark is an important part of this strategy. And that's something that will be forthcoming in Connecticut this year. And that might aid the effort. But I think the commissioner is right in noting that that ultimately this relies upon the voluntary commitment of provider organizations to advancing affordability and accessibility, which, as Maureen notes, are linked. And today there is not good access for many people who face high deductibles and coinsurance and are deferring accessing care because of the costs associated with it.
We're going to go to, unless another panel member wants to jump in on that, we're going to go to Dr. Gifford, and then we can come back to you, Commissioner Mays.
Thanks, Ted. I didn't want to cut off any other panel members who wanted to respond to Commissioner Mays's very important question about the challenges of insurer provider negotiation. Anybody else before I ask mine? Okay. I have two questions. One, Christine, was just to ask you to clarify something that you said in your very helpful summary. And let me add that to all the panelists, really helpful information to those of us who are grappling with policy issues around this question. It's complex, and you all did a terrific job of giving us some concrete suggestions for solutions. Christine, you mentioned, and I didn't catch which state that was actually doing contract review between insurers and their contracted providers, and had the ability to review and potentially reject contracts that didn't meet certain standards. Can you just elaborate on that again for us?
Sure. There are two states that we know of that have this authority. So kind of one is Washington. They have authority to review provider contracts. The carriers must file all provider contracts and their compensation agreements with the commissioner before use. And my understanding is in Washington, that has primarily been used in kind of network adequacy reviews before, and not from a kind of reimbursement perspective. And they can't disapprove a rate just for to kind of like regulate provider reimbursement amounts. But they do have the authority to kind of look at and review these contracts. But in Pennsylvania, they have an authority that I think exists but has not been used yet. But what their law says, let me pull it up so I have it handy. So they provider contracts need to be filed with the insurance department no later than 30 days prior to their effective date. And in Pennsylvania, they can be disapproved if it's determined that the contract provides for excessive payments, if it fails to include reasonable incentives for cost control, or if it contributes to the escalation of the cost of providing healthcare services. I don't know that this insurance department has used this authority and disapproved any contracts yet, but it does exist in their law. And so it's something that you can look at as a possible model. If you want the citation, it's 40 Pennsylvania statutes annotated. It's section 3801.309.
Thank you very much.
I think Rhode Island also does something of that nature that maybe Michael Bailett can speak to.
And Ted, I don't think Rhode Island routinely reviews them, but I know that it can and does perform periodic market conduct exams that look at provider payer contracts to assess adherence to the affordability standards that Rhode Island's Health Insurance Commissioner has created.
Thanks, Michael. And my next question is to any of the panelists, and it has to do with the role of alternative payment models and payment and delivery system reform in this conversation. As a couple of you pointed out, that had been, sort of the main thrust of a lot of work around cost and quality improvement over the last couple of decades, and hasn't borne the fruit that many of us hoped that it would. Michael, you mentioned multi-payer alternative payment models as one potential solution here, and many of you did not. So I just wondered if people wanted to comment about that shift and whether the multi-payer nature of potential future payment reforms is the thing that's been missing, or if the issue of price has just overwhelmed our ability to control costs using payment and delivery system reform. That's for anybody who'd like to comment.
I don't know. I guess I can. Oh, sorry.
No, please.
I can hop in briefly, Lauren Adler here. So I think it is right. I think we have ample evidence now that the sort of accountable care organization, these sort of pay per performance, moving to kind of away from volume-based payment, have had some success. I think sort of modest, right? As you point out, right? I think we've seen cost reductions to some degree, but relatively small. I do believe that part of the issue has been the sort of lack of all payers getting into that, and the private payers in particular glomming on, to the sort of federal alternative payment models here. I do think some of the incentives that the Centers for Medicare and Medicaid Studies are issuing for their, sort of for the big picture Medicare models will push to some degree in that direction, but certainly states can do that as well. I still don't think you're expecting kind of overwhelming savings. I think at the point that, Cynthia brought this up at the beginning, right? Where we're an outlier is on prices, not on utilization. That being said, right, I think part of the hope for some of these alternative payment models is also an improvement in quality, or even getting modest price reductions while you're improving quality is still valuable. It doesn't fit the sort of affordability, line of this particular day, but I think it's useful to keep in mind that, that improving quality is still valuable, even if you're only, reducing costs by 2% or something along those lines.
And this is Maureen. I was going to weigh in just to share. And of course, this is not across the board, but in previous payment and delivery system reform efforts that states have undertaken, I think their goals were not cost containment focused. I think the goals were to create a more coordinated delivery of care. I think some of the reforms achieved that. I think there was a focus on quality and value, which there should be. But now as states are looking more, and I can echo what my fellow panelists said about global budgets, there is an increased interest across states to learn from what Maryland is doing to see if there could be a focus on care coordination, on incentivizing primary care, on putting a budget around hospital costs, if that could ultimately achieve multiple different goals. And I do think that there's increased interest in that. But I'll just say from NASHP's perspective, and looking at many states' efforts around payment and delivery system reform, cost containment hasn't always been at the core of those. And so I wouldn't say that they weren't successful. I would just say now that price has become the issue that it clearly is, trying to engage other payers to the table, I think is very exciting and has some potential. And there are states that are looking to do that.
Great. Thanks so much, Maureen. Anybody else on the panel want to comment on that? Then if not, we're going to go to Commissioner Mays, who I know has additional questions. Go ahead, Commissioner.
Thank you, Ted. I'm just going to ask one more question here, and this is going to be for Jeannie or Cynthia from Kaiser, because you brought this up first. And at our first hearing, one of the presentations we had showed us the disparities in pricing among hospitals, hospital systems, different providers, whether that was whatever the percentage over break even, and whether that was based on marketing costs or just market power, we don't know. But given those disparities, I know you'd mentioned that the price growth caps can lock those disparities in, which could permanently disadvantage some of the provider institutions. What have you seen that has worked well in addressing these, so we get to someplace where it's fair to everyone and we're not simply repeating the mistakes of the past? Thank you.
So I can take that, Cynthia. I cannot think of an example of what has worked well to speak directly to your question. There have been proposals with respect to price caps where you can start higher and then titrate down so that you don't have to keep the cap at the same level every year. So maybe initially you do have that variation, but you can make it lower so that there's some amount of variation that you're willing to tolerate. And we would expect there to be some variation. There can be differences in patient populations, quality, other things. So it's not that zero variation is the goal, but when you have a really long tail and some people are 500 times more or 500% of Medicare rates and everybody else is at 200% of Medicare rates, that's probably not where you want to be. So it's really reducing it, not getting rid of it altogether.
Thank you.
I would just jump in to add, and this is Christine Monahan, and I think Michael or others might be able to speak to this more. My understanding in Rhode Island, with their kind of limits on hospital rate increases is that they did in 2020, they modified their standard. So hospitals that had below median prices had a chance to, like a one-time chance to increase their rates, as long as they met certain quality requirements. And so again, I think this is speaking towards you can kind of make adjustments if you're seeing things, so long as you're monitoring the impact as you go.
Yeah, I can confirm that. That's correct. Rhode Island, for one time, allowed those hospitals that had outlier rates at the low end to get a bump to come up so that they were closer to the rest of the hospitals.
Anybody
and,
else?
and I'll note this is really speculative, but because I don't think Rhode Island or Delaware has done this, but you could also vary the price growth cap for hospitals based on their relative standing and have a higher one for hospitals that are comparatively under-resourced.
Actually, I'll add on that too, just looking at what Colorado is doing with their reimbursement floors, they have kind of a different, their formula takes into account, payer mix and, costs and margins and all that in figuring out what the reimbursement floor should be for each hospital. And so again, that is a way to account for, differing needs.
Okay, any further discussion on that? Terrific. Then I want to do two things. First, I do have a question that I want anybody on the panel to jump in on. We earlier heard from pharma, and there was mention of moving PBM to administrative fee only. And I wanted to know if any of you or your organizations had thought of that. The second thing I'd like to do is to just ask Maureen Hensley Quinn to just explain a little bit about NASHB's hospital cost break-even tool, just so everybody has a clear idea of what that is. It's just a wonderful tool, and I wanted some explication on that. So Maureen, if you could just tell us a little bit about that, and then open it up to the panel to give any thoughts you might have on PBM, moving them to admin-only fees. Maureen, can you help us out there?
I'm happy to. So NASHB's hospital cost tool does use Medicare cost reports as the basis of data to look at almost 5,000 hospitals, not quite 5,000 hospitals across the country. And it is individual hospitals. We do have a view so that when there's a clear connection with a health system, that can be shared as well. But I'll just share the hospital cost tool does provide multiple different metrics. The one that seems to be most helpful and certainly cuts through a lot of the chatter is the break-even metric. Essentially, the break-even metric it's an accounting term that my colleague Marilyn Bartlett knows very well. So it looks at a hospital's costs and includes in that metric profits and or losses from public payers. And I will flag that it is not across the board that all hospitals lose on public payers. Depending on the state, some actually are able to make some level of a profit, but it does consider both of those, a profit or a loss on a public payer, both Medicare and Medicaid, and then establishes what a commercial payer would have to pay as a multiple of Medicare to break even, to cover their costs and not make a profit. And that break-even metric is meant to be a conversation starter. It is not meant to imply that that's what hospitals should be reimbursed at. We know that hospitals need some level of profit, but it does help compare to the RAND metric that highlights what commercial and employer plans are paying. So what we're finding just generally, I believe the national median of break even is between 100% of Medicare and 150% of Medicare. So by and large, many hospitals are able to cover their costs, but at about 150% of Medicare. And then we compare that point or that metric to what commercial payers are paying, which is usually higher than that. And it really is variant depending on the hospital. There are other metrics that are helpful to provide an overall picture of hospital costs. I would direct you also to the cost to charge ratio. That does show a hospital's cost versus their charges, and you can see it expressed over the last 10 years to see what the trend has been. And I will just flag that we have been able to recently add 2 more years of data. So the data shown in the tool online right now, 2011 through 2021. We do expect to update it for 2022, but there are not enough Medicare cost reports in order to do that yet. Any further questions on that? I'm happy to talk about the PBM question as well.
So just to make sure I understand. So if I'm interested in a particular hospital in Connecticut, say Griffin Hospital, I can go online and using your tool, I can see what percentage of the Medicare price they would need to charge commercial insurers in order to break even. Is that it?
That is it. Yes.
Okay, very helpful. Yeah, go ahead on the PBMs then, please. And I would also like to note that Senator Cabrera has joined us, and we appreciate you taking the time to join us. Thanks. Go ahead, Maureen.
Great, thank you. I will share that the main PBM law that I referenced in my remarks, it has multiple provisions in it. One of the provisions is explicitly, as I noted, expressly making the health plan a fiduciary of the PBM that they contract with, which does connect the state's regulation to that PBM. But another provision directly within the law cites that rather than spread pricing, a PBM will be paid an administrative fee for the services they provide. And that would be a contract between the health plan and the PBM in order to do that. I will say that Maine's law was passed in 2019 and I believe went into effect in 2020. We have reached out to folks in Maine who have been very willing to share what they've been learning from this relatively new law, but it did go into effect during the pandemic, which does make it harder to be able to track how it has overall impacted premiums, which they do believe eliminating spread pricing, using an administrative payment for PBMs and then connecting this fiduciary responsibility will ultimately help reduce the costs connected with the PBM to, and the law expressly connects to bring it back to reduce overall premium payments. But it hasn't been as clear cut because of all of the different things changing with health plans and the need to connect those dots. But I would direct you to Maine for doing that explicitly. And I'm sure there are some other states that have done the same, but that's the state that stands out in my mind.
Great, thanks so much. And my impression is there are some companies that are moving in that direction, PBM companies, or some companies that have been established recently that are admin only. So very interesting. Anybody else want to weigh in on that? And then we'll wrap up here.
I'll just quickly add, I think one important point, as Maureen definitely highlighted earlier, is right, these PBM reforms in general, there's not too much of sort of a cost angle. There may be like a pharmacy, how much money pharmacies are making angle here. But, especially when you're talking about the private market where these are insurance companies that can set cost sharing however they want. They can do a co-insurance, they can do a copay, sort of changing the spread pricing. Their actual side of things probably won't have too much of a difference. I think it's questionable whether the sort of law like Maine's of sort of moving to administrative fee, how much difference you can really expect that to actually have in these situations. Not that it may be sort of more natural to do that way, but especially now, almost all the PBMs are owned by insurance companies. So it's a little bit, some of this is sort of integrated into how the insurers are already setting premiums for the employers.
Anybody want to add to Lauren's comments? Please go ahead. If not, Commissioner Mays, do you have any a quick concluding remark or another question?
No more questions, no further questions. Thank you, Ted.
Okay, wonderful. So we're going to wrap this up, and I want to thank all the panelists for a wonderful discussion. We're going to take a midday break, and then we're going to come back at 1 p.m. for section 3, which is moving to value in Connecticut, creating a transformed health care ecosystem through industry collaboration. And that's going to be moderated by Representative Kerry Wood and Senator Jorge Cabrera, co-chairs of the Insurance and Real Estate Committee. So see you back here at 1 o'clock. Thanks, everyone.
Good afternoon, everyone. Welcome back. I'm reconvening this forum, this informational session, and my name is George Cabrera. I'm the new state senator, new co-chair on the health insurance committee. Just want to welcome all our experts today. Got a chance to talk to some of you and looking forward to learning more about and get your perspectives. So welcome. I'll pass it over to my co-chair.
Thank you, Senator Cabrera. My name is Carrie Wood. I am the state representative from the 29th district serving Rocky Hill and Weathersfield, and I'm also the co-chair of the Insurance and Real Estate Committee. Very proud of the work on this committee, especially last year passing the benchmark bill where we are collecting more data than we have in the past. That data will help us drive quality healthcare decisions as we move forward. The speakers here today are going to talk about some national perspectives as well as what's happening here in the state. And I want to thank you all for participating. Jeffrey Hogan, I'll pass it over to you.
Excuse me,
Just
can
hit
you
the button.
please, mic button.
I'm sorry. Yeah. Amateur mistake. I apologize. Yeah. Very much focused on value-based healthcare solutions, not just in the commercial marketplace, but in Medicare Advantage as well. So today, and I'd also like to introduce Dr. Steven Schutzer, who's the founder of the Moving to Value Alliance. I'm going to give some remarks and then I'll ask Dr. Schutzer to finish up as well. So my focus today will be just that, on value-based healthcare, the changes that we've seen, particularly post-COVID in healthcare specifically, in the sudden employer demand for performance and predictability. Those sound like buzzwords, and I'm going to try and be more poignant about what performance and predictability looks like on the demand side from a healthcare point of view. So for perspective, healthcare consumes nearly 20% of our gross domestic product. I don't know that people realize that 20% of our gross domestic product. And particularly coming out of COVID, we see that people in general, be it employers or consumers, really aren't pleased with healthcare. Costs too much. The outcomes are poor generally, and we haven't measured them in the past. For most employers, healthcare is the second largest expenditure that they make after wages. And we see suddenly how healthcare is consuming the upper end of wages, the opportunity for wages. Here we are in Connecticut and other surrounding states where employers often, if you go back to your municipalities and ask them what they're paying for their family health plans, family health plan premiums are exceeding $40,000 a year. Think about that number. And that should level set us for the rest of our presentation. Next slide, please. Here we are in Connecticut, and I thought it was really important, particularly from a public policy point of view, for us to, again, level set on the fact that Connecticut is uniquely positioned to be a leader in this whole area of healthcare transformation and innovation, basically meeting the new needs of employers and a new healthcare consumer in the marketplace. So obviously we have a huge BUCA presence, the Blues and United and Cigna, Aetna, even Humana, and some other carriers here as well. We have an educated workforce. And I think most importantly here, this post-COVID demand, we suddenly have birthed a healthcare consumer, which really was an oxymoronic notion prior to COVID. The purchaser of healthcare was the consumer. That's no longer the case. Many of the biggest players are here in Connecticut. We have really great academic systems. We have sophisticated health systems and technology right down the street. Both health systems are integrating digital health innovations into their care paths to give better access to care and better predictability as well. And this whole notion of innovation in healthcare is happening all over the country. Rather than buy and build, the integration of health tech innovation is the way of the world right now. Next slide, please. So what are the pressures and incentives that are really making employers do things differently or want things differently? And this isn't just in Connecticut, it's everywhere. Post-COVID, we had the Great Resignation, the fact that it's really hard to attract and keep employees, and they need better plans. They need plans that actually cover things without high deductibles and exposure and fragmentation. We have fragmented supply chains in manufacturing and otherwise, and capital no longer costs zero for employers. The Consolidated Appropriations Act is really important. I'll talk about that in a little while. Most people don't understand this. This is a new federal requirement that employers managing a health plan or financing a health plan must bear a new fiduciary standard for procuring health services for their beneficiaries. We see in Connecticut and elsewhere huge variability in cost and quality. Let me give you an example. I worked on the state of New Jersey employee health plan with 822,000 active and retired employees. And we did a Prometheus analytics on the state of New Jersey's data. That means, what are they paying for the highest volume of services? Knees and hips and babies and shoulders, the things that reoccur in every single health plan. And it was really quite remarkable, the variation that we found in cost and quality. So for example, a very common knee arthroplasty, which should cost $22,500, often costs $100,000. And employers don't realize that they often, and this includes in Connecticut, pay more for the complication and the infection associated with the arthroplasty than they do for the underlying arthroplasty itself. So when I talk about value-based healthcare, it's not this esoteric notion. It's about bringing predictability to healthcare, making that knee cost $22,500 with quality associated with it. Next slide, please. So what is the value of value? Post-COVID, employers and employees have new expectations. They want to be treated virtually. They want to be treated at home. They want to be treated respectfully on their terms, not just when the offices are open or when it's convenient. They want predictable costs and access to care. New consumers in this marketplace are demanding to be treated differently. And employers must bring these innovations into their plans to attract and keep those employees as well. Next slide, please. So just before COVID, I had the opportunity as the liaison to the Connecticut Business Group on Health to the National Alliance of Healthcare Purchasers to work with Vicki Veltri, then at the Office of Health Strategy, to extrude Connecticut data from the All Payers Claims Database to put it into the RAND Hospital Transparency Report. If you've never looked at the RAND Hospital Transparency Report, I suggest that you do so. Version 4.0 is out now. And basically it surveys the commercial payments that hospital systems, health systems around the country pay or charge for basically every service. So it demonstrates the variation in cost and quality between health systems and also within those health systems by service line, cost and quality. it's really remarkable to see the amount of variation in cost and quality. And I'll tell you that RAND has been used by employers in this state, by some of the carriers that are at the table with me today, to design value-based strategies to reduce their cost and quality and to create predictability around these things as well. This slide shows you what the state of Colorado did basically with this information to produce a report on the value of Colorado hospitals and basically to inspire health policy focused on cost and quality. Employers and the state of Connecticut are using data and analytics to inform decisions around procuring services and point solutions that are relevant to their beneficiaries. The new benchmark initiative, which Representative Wood mentioned earlier, is a good example of this type of initiative, a really great start looking in this direction. Next slide, please. This is an important slide. Self-funded employers, which are about 67% of employers, including down to the small group in the middle market, have a new fiduciary responsibility to monitor healthcare prices and also quality. The bottom line is self-funded plans, if they don't know prices, really can't act in the best interests of their employees. And they now have a legal liability that their beneficiaries can actually sue companies. There is a CAA lawsuit ongoing in Connecticut right now associated with this issue. Knees, babies, shoulders, the high volume of services and high cost services can be purchased in an open marketplace at predictable costs and quality as well, just as a reminder. Next slide. So in preparation for this presentation, I wanted to give some really great examples of organizations in the marketplace that are using data and analytics, specifically around cost and quality, to change up their health plans. We just had the opportunity to interview someone from 32BJ, one of the leaders of this particular union health fund with more than 200,000 members, including Connecticut members, who literally did what I was just saying. They contracted and directed their employees and dependents to specific facilities with specific costs and quality, and excluded specific health systems that were higher cost and lower quality. What happened? They were able to bonus up $3,000 per employee. They gave a 2-month premium holiday to their employees, and they held their premium increase to 3% for 2024 and 2025, using centers of excellence and a few other things. They started with data around price and quality, and they did this for their 200,000 members. In the state of Connecticut, I'll use an example. Stu Leonard's, the beloved Stu Leonard's, did this when COVID started. They had a traditional network plan in the past. They moved to a plan with attributed, at-risk, capitated, advanced primary care, steering into predictable cost and high-quality providers. First-year savings, 37%. They got rid of their co-shares. They had high quality, made higher contributions into their 401k as well. So just 2 examples of organizations that are really moving in this direction. Next slide, please. So the convening comment here is that using data analytics and at-risk providers to meet demand, we can do better. We can lower costs. We can produce better outcomes. We can make people happy about healthcare again. Next slide. In summary, rising healthcare costs put pressures on employers and workers' wages, especially during the COVID pandemic. The wide variation in hospital prices presents a savings opportunity for employers, and employers demanding transparency on the prices they and their employees are paying is a movement. It's happening. It's good health policy. Employers need to use this transparency to inform their benefit strategies. And lastly, it's not up there, but state health policy and infrastructure can help employees in their effort, and employers as well. Next slide. The largest risk is truly in doing nothing. And certainly the state of Connecticut has been doing things. I think we can do more. I'm going to hand this over to my colleague, Dr. Stephen Schutzer, the founder of the Moving to Value Alliance.
That one. Can you hear me okay? Good. Thank you very much, Jeff, and Senator Guerreros, Representative Wood, Representative Barry. Thank you so much for the honor of being here today. My name is Steve Schutzer. I'm an orthopedic surgeon, co-founder of the Moving to Value Alliance. And up until a month ago, I was a chief physician executive for orthopedics at Trinity New England, overseeing their service lines, including the Connecticut Joint Replacement Institute and Arthroplasty COE. So I've been asked to give my perspectives on healthcare cost and quality, a concept whose definition undoubtedly will vary amongst stakeholders. I could speak to this for hours, but suffice it to say for now that for my orthopedic colleagues who are somewhat simple-minded, we adopted the framework espoused by the Professor Kaplan and Professor Porter at the Harvard Business School, defining the healthcare value equation. So what is cost? Cost is a denominator of the healthcare value equation, but costs are not charges. Costs are actually the actual true cost of delivering a healthcare service. And how is it measured? It's by applying a very rigorous cost accounting methodology known as TDABC, time-driven activity-based costing, where you map out the patient's journey and determine the unit cost and unit time to deliver each section of that patient's journey. That's true cost. We underwent that analysis 3 times as CJRI. And what is quality? Quality is a numerator of the equation. And talk about conflict. Quality in particular has myriad of definitions and metrics, but I would argue that for the end user's perspective, the patient, quality should be measured at their level. That is, patient-derived outcomes, or the outcomes that matter to the patient for their specific medical condition. These measures we call in clinical practice PROs or PROMs, and they're captured at various levels of the patient's episode of care. They're monitored by the care team because that's really the quintessential feedback that caregivers need to understand for the patient's progress. Typically, third-party vendor resources are contracted to provide those services to these providers. So is there an association between cost and quality? Of course there is. Jeff just mentioned that. Now, Jeff touched on the RANDS data. There's plenty of data to support an intimate association between cost and quality to support that causal relationships. But it boils down to this, very, very simple. When healthcare organizations invest the time and the capital to collect, adjudicate, analyze, and utilize cost and quality data, the value of their products unambiguously will improve. Plan sponsors will see reduction in total cost of care, but most importantly, our patients will be the primary benefactors of these efforts. And thank you very much for your attention. Thank you, Jeff.
We'll go to Christine Capiello from Anthem and followed by Dr. Phil Roll, and then we'll open it up to questions.
Great, thank you. Thank you. Thank you very much for asking us to be here. I'm Christine Capiello from Anthem Blue Cross Blue Shield. We are the largest health insurer in Connecticut. We service individual, small group, fully insured, self-insured. We're on the exchange. We do Medicare. We don't do Medicaid, but we do every other line of business. We're a carrier for the state employee under 65. and many municipalities. So we really do appreciate the opportunity to speak to you here today. Very important conversation. Last time that you had this forum, our plan president, Lou Gianquinto, spoke, and he spoke about a lot of the provider collaborations that we're doing, because we strongly believe that that is how we get where we need to be on this to try and have a solution. I'm going to take it in a little bit of a different direction that I think might be helpful for people to understand. This is one of the things that Anthem is doing for its members, and we're actually seeing quite a bit of benefits from it. Next slide, please. So we have our, our mission. Everybody has a mission, right? Our mission is to improve the health of the people we serve. We focus on the basics. We deliver local with the strength of a national carrier. We drive whole health integration, and our job is to reduce medical trend. Next slide, please. So we have a program at Anthem called Total Health, Total You. And it really is important, I think, to understand from our perspective, and I think everybody agreed, we talked about it a little bit earlier, that a lot of the spend comes at the most expensive. You've heard the number, right? 80% of the healthcare dollar gets spent 20% on 20% of the people. But our idea and what we're doing with our members is to get them before they get to that 20% where it's a very high cost situation. And so that's what's behind Total Health, Total You. Next slide, please. So it's really an evolution of the clinical story and clinical integration. And we all know that health plans have the standard utilization and case management. And obviously, Dr. Carden talked about it from the Hartford Healthcare experience, and we do that as well. Then we sort of move to this specific, condition care, which a lot of you have probably heard about, where we really tried to hone in on helping people with specific conditions. Then we went to an integrated health model, trying to get physicians and members together so that we can try and make it get the healthcare dollar, most out of that healthcare dollar. And then we get to Total Health, Total You. And that's really where we're trying to meet the customer and the member where they need it. We currently have about 3.4 million members that are enrolled in the Total Health, Total You. Next slide, please. And it really is utilizing this great trove of information that we have. And that is, we identify the risk, and that's really the trick. And we don't identify the risk just as we get to the highest cost part of it. We're identifying the risk in various levels to try and help people to lower the cost as they go through their experience, whatever that happens to be. Next slide, please. So what we're seeing here is we analyze multiple data points: opioid addiction, diabetic risk, COPD, depression and anxiety, all those things that even collectively can come together and impact a person's healthcare and impact a person's health in general. Next slide, please. Because truly, oops, we got an extra slide there, I think. Go next one. Next one. Oh, I sent you the wrong deck. Woo, that's what you get for doing stuff late at night. So the member really is at the center and the heart of our model. And that's why we're trying to get the complicated medical, behavioral, and the social systems. And we've had about 92% member satisfaction. I'm just going to go along quickly here. Next slide, please. And this really just begins to show you what we're talking about. It's well-being and prevention. It's the total engagement, it's the guided support, and then it's the care management, all put together. Next slide, please. And I'm just going to go through these really quickly because what I want to do is next slide. And then next slide, I want to show you an actual example. We're using digital, everybody has these, right? You walk around with it. I'm never without it. And so we have an app called the CID app, and we're really building off of that because everybody has their phone with them at all times. And that's really where we're also meeting people where they need. Next slide. Okay, so here's a great example. And this is Sally. And she she's got worsening knee pain, and she had a doctor who said to her, you're going to need a knee replacement. And she was a bit hesitant about a knee replacement. Obviously, it comes with, and Jeff's got a perfect example, right? It's not just the knee operation. It's if you, God forbid, have an infection afterwards. And, it's not without some complication. And so she was concerned about it. This is where we identify it. Our Total Health, Total You advocates. They're a special group of people that work at Anthem. They're designed to do this, and reached out. It's a registered nurse, and learned about Sally's pain. And then we went through and had a conversation with her and found out, that she actually had some real anxiety about her knee pain. And so we worked with her on her CID app, signed her up with a care plan. She received some great information on how to relieve her stress and relieve her pain. Got a second opinion for her because she felt she really wanted to have a second opinion about it. They talked about on her weight was going up. She really decided that the weight was having an issue on her knees. Got her hooked up with a dietitian. And so she was able to get a dietitian plan. She worked with a telehealth provider to get her to talk about her anxiety and help to reduce the anxiety. She lost some weight and is on a path not to have a knee replacement. So the knee replacement, yes, it's volume. Hips and knees and shoulders cost a lot, just by volume. But as to what Jeff Hogan talked about, there's all those things that come along with having that knee replacement. So let's try and get it where maybe we can get people on a healthier path. And she would be considered a high risk. Next slide. Here's somebody who's what we would call an emerging risk. And this is somebody who she's taking care of her elderly mother. God knows, we've all been there. A lot of anxiety, a lot of stress, beginning to really impact her health, giving her hypertension, high blood pressure. And of course, we know the impact of high blood pressure, strokes, all the rest of it. Now we connected with her with a Total Health, Total You advisor. And we talked about ways with her about how to overcome that barrier. Got her some assistance with the anxiety and the depression, actually even helped her mother be able to work with a PCP that could do the visits, telehealth, so that there was not that stress on Lucy to have to take her elderly mom to the doctor and deal with all of that. And as a result, she's feeling better. The anxiety is less. And it's not, and her hypertension is down, and it's not impacting her body. And that's really what the whole idea, that's really what your goal is. Last one is a low risk. That's Mike. He's kind of been identified as having somebody with high cholesterol since his last checkup, really wants to understand it. Gets into the Total Health, Total You. We make an awareness of him. We put a plan together to change his lifestyle, do some exercises, be aware of that cholesterol, because the reality is, once you go down, as everybody knows, you go down this road of having high cholesterol. Yes, your doctor is going to tell you to try and deal with it with good diet, but sometimes you're just predisposed to it. And so you're going to end up on pills, then you're going to end up having to have your liver checked. It goes down that path, right? So if you can try and stop those where they're healthcare induced cholesterol, that's a great way to do it, just before we get into all those things that happen after the healthcare. I'm sorry, after the healthcare starts to impact it. And so next slide, last slide. Is that me? Okay. You okay now? A lot of little technical challenges with my presentation. And so this really just shows the end to end, and this is the reporting. This is what shows it. And then just keep going through. And I really want to go to the last slide, which is no, I'm sorry, one more up. Sorry. This really shows the results, right? Because that's really that's what matters, is how is the results going? 7.4% have a reduction in medical and RX costs, 6% reduction in ER visits, 90% customer satisfaction, 74% on a net promoter score, 17% increase in pharmacy refills. That's really important, right? Making sure that people get those if they're on medication that they need to be on, that they stay on it consistently, and a 69% gap closure for medical and pharmacy. All those things are really important. So we're really pleased about it. It's working really well. And that's one of the solutions that Anthem is doing, in addition to a whole host of other things. But as Jeff Hogan said, I could talk for hours, so I don't want to do that. I want to turn it to Dr. Rowland from Cigna.
Thank you, Christine. Thank you to the members of the Insurance Committee, the Insurance Department, the Office of Healthcare Strategy, the Healthcare Advocate, for all allowing Cigna to be important, a part of this important conversation. My name is Phil Rowland. I serve as the Medical Director for Cigna in Connecticut. I'm a resident of Bloomfield, and it's really a privilege for me to represent our National Health Services company, really based in my hometown. At Cigna, we are committed to driving high quality, high value-based care and lowering cost across the spectrum of all healthcare. And we're working to deliver innovative solutions to our customers and clients. On the next slide, please. If I could take a moment to reflect back over the past 3.5 years, where Cigna at that time recognized that our existing accountable care model, while effective pre-pandemic, was not applicable at a time when society was in isolation and sheltering. I certainly personally experienced this at that time. At the height of the pandemic, I was a chief medical officer for one of our hospitals and one of our large medical groups within the state. We needed help to keep operations moving forward. Cigna stepped up at that time and developed a COVID care model supporting physicians throughout Connecticut, their practices maintaining existing pre-COVID care coordination funding with a focus on quality and also those individuals most vulnerable to COVID-related morbidity. Now forward into 2023, we're moving forward with a total medical cost-based program. I'm pleased to say the physician leaders that I'm meeting with throughout our state are eager to proceed as well to a value-based care approach. I'd like to take a moment this afternoon to highlight 3 of our innovative programs promoting high quality and affordable healthcare. First is indeed our value-based care program. At Cigna, we refer to this as our collaborative, accountable care program with an emphasis on collaboration. We meet monthly with medical and business leaders of 7 of the largest medical groups in our state, helping ensure their patients and our customers have access to high quality care. We share in these meetings meaningful, actionable data on preventive care, chronic disease management, site of care, such as the primary care office versus the emergency department, and total medical cost. I'll share a brief example of how this program has been very effective. We noted coming out of the peak of one of the pandemic phases that we had a drop in well child visits and a drop in screening mammography. Now in this post-pandemic normal, we're able to reach out to those physician collaborating partners, share the list of their patients who have gaps in care. They and therefore can reach out, bring those patients back in and closing the loop. We then monitor this quarterly, working again in collaboration, looking at well visit rates and healthcare screening rates to ensure that we're trending forward in a positive manner. Again, an important component of this value-based partnership is regular quality metric reporting and total medical cost trending. I certainly want to recognize and thank the Office of Healthcare Strategy for allowing Cigna to be at the table as we work to develop core metric sets for all payers using value-based contracting. Now we look at these shared savings and we actually share the dollared savings with provider groups who achieve high quality at a lower total medical cost compared to the market. On the next slide, I just wanted to illustrate, I feel that our performance of these partnerships is very impressive. We have over 650 collaborative partners across the United States. Again, 7 of those now are in Connecticut. They perform 70% better than their market for inpatient admissions, 70% better than the market for avoidable emergency department visits, and we have a 60% improvement in the use of guideline-directed ordering of high-tech imaging. Next, I'd like to touch briefly. We use social determinants of health with our collaborative care partners. We appreciate that much of the health in our communities is not really related to the acute care we provide, but where one lives, their access to food, transportation, and housing. We feel that high quality care must address health disparities that a number of our citizens experience. On the next slide, we use zip code data and census data to develop a social determinants index. And we share this with our value-based physician partners, a profile of the social determinants for each of the patients they serve. We're looking at domains including education, language, infrastructure, and food access. We commonly find 1 in 3 members of that practice may be at high or very high risk of having unmet social needs. We flag this information in shared web-based manner with those practices. So when someone comes into the office, they know that that individual may be at risk. We encourage our value-based partners to use our Cigna communityfindhelp.com site to identify assistance for their patients. Again, if I go in my community in Bloomfield, we can find hundreds of programs that can provide assistance such as food, housing, and transportation. And further, we work with our accountable care partners to develop key focus action plans on an annual basis to address health disparities in the communities that they serve. Finally, I want to emphasize our work in the area of behavioral health care. We appreciate the stress of the events of the last 3 years have exerted on our communities. 1 in 3 citizens experience a behavioral health condition such as anxiety, depression, or stress. This not only affects their well-being, but their productivity in the workplace. On the next slide, we've also learned that these patients can drive 1/2 or more of their employer healthcare spend. We understand that investing in behavioral health care not only improves the quality of life of our customers, but reduces total medical cost. Our experience has shown that when an individual experiencing a behavioral health condition seeks treatment, only one treatment, we not only address their well-being, but we save money, approximately $2,500 of medical cost savings per person in the first 15 months after diagnosis. This compared to an individual with a condition who does not receive intervention. We strive to be a leader in behavioral health network solutions. First, all of the patients and our collaborative care partnerships receive behavioral health screening, and we provide access to over 200,000 clinicians nationally using both in-person and virtual-based platforms. On the next slide, I'd like to say in summary, we've hopefully left the worst of the pandemic behind. We appreciate the economic uncertainties that our customers face and the workforce challenges that our Connecticut businesses must address. At Cigna, we're committed to promoting high quality, affordable healthcare through our value-based partnerships with our Connecticut physicians, ensuring our customers have access to high quality and affordable care. We believe that healthy individuals are more productive, loyal to their employer, and healthier for our economy. Thank you again for the opportunity to be a part of this important discussion.
Thank you very much. We can open it up to questions. I would like to kick it off with a question for Jeff. You had talked about the Consolidated Appropriations Act and the self-funded plans. Can you explain that a little bit more? I was really interested to hear about that. And then the second part is the lawsuit in Connecticut. I don't know how much you can share, but just wanted to get some background.
Not a lot about that, but I'll mention it. So the Consolidated Appropriations Act has gone into full effect for this past year. And basically it imposes upon employers who manage a health plan, fully insured, self-funded, regardless of the size of their group, a new fiduciary standard, which means that the employer, the named fiduciary, who typically is the CFO at a firm, may also be the chief legal officer. In some larger instances, for example, if it's a municipal ERISA plan, could be a committee, a fiduciary committee named as the fiduciary as well. They must act in the best interests of their beneficiaries, and they cannot convey the decision around purchasing health services to a third party. What does that mean? That means in the past, most employers have relied upon agents and brokers to go out to the marketplace to procure health services. What was that? Let's go out and put our group out to Aetna and Cigna and Anthem and all the carriers that are out there, and they bid on it. And that system is going to change because the new fiduciary standard says you must utilize an unbiased, repeatable process for procuring your health services. So think about that. What does that mean for the average employer? If we were to walk out of the room right now and ask an employer, what are the biggest problems in your plan? Is it cancer or cardiometabolic or musculoskeletal or specialty drugs? You would get a look like my 2 Labrador retrievers give me most mornings when I wake up. They don't know. And herein lies the problem, and this was recognized when the legislation got passed, that the purchasers of healthcare have been completely insulated from cost and quality, and in most cases, even from their own problems. And what this is doing is imposing upon employers the same standard that was imposed about 13 years ago for employers that had 401k plans, that had ridiculous costs associated with them, lack of accountability, and what have you. So that is the Consolidated Appropriations Act. It imposes this standard. In the Connecticut case in particular are 2 union groups who are suing a carrier for breach of fiduciary duty for not giving them sufficient information about their data, and also a question about actually paying the claims correctly. So this is turning things upside down. Why? Because employers that at the end of the year, every year, have an audited financial statement, they have to sign off that they're meeting their fiduciary duty on their 401k and on their health plan. And most employers have no idea what the problems are in their plan or what services they should procure to meet their beneficiaries' needs.
I find this fascinating. I don't know. I feel like I'm on the edge of my seat for this. And I wanted to turn it to Christine and Dr. Rowland to respond from the carrier's perspective, because this seems pretty game changing. And what are your thoughts on the CAA?
I'll give you. So I can speak from my medical director role. So Jeff, you're teaching me about this as we speak, but you're also reaffirming a lot of what we're doing. So from the clinical part of our organization, we actually meet with our clients. Those are the businesses and the municipalities that we serve on a regular basis. We carefully review their total medical costs, their trends. We review de-identified information related to their high-cost claimants. And we use that information to assess on a regular basis the products that they're using, what there may be gaps in their coverage. And so this is very informative to me, and I feel that we're going in the right direction in this, because you're right, we have to help the people we serve make proper decisions to serve their employees.
You know, just say from Anthem's perspective, same thing. We do this very detailed conversation with our groups. The brokers are always in the conversation. And as far as the CAA is concerned, there's other pieces of it related to transparency that we've worked very hard to comply with. And it all goes to being able for people to being able to, and members and employees and employers to understand exactly what their healthcare cost for that particular group is costing them. And that is really important. Well, it'll remain to be seen whether people will take advantage of it. You know, sometimes you give people information and they don't know what to do with it, or they don't know how to digest it. So I think that, you know, we're just on the very beginning of this. So it'll be interesting to see, because it is, if people can understand it and take the time to understand it, I think that that's going to be very helpful to their own group and to know what's going on. I mean, one of the groups that one of our employer groups that's in Connecticut, and it's a family-owned business. It's a fairly good-sized manufacturing firm, manufacturing company, understands his employees and the what's driving the care for his employees, and is able to and has done some innovative things for his particular, this was long before CAA, for his particular employees. Some things worked, some things didn't, but he was a very engaged person on related to his employees. So it'll be interesting to see whether people take that same path and are able to do what works best for their employees.
Let me just make a comment from the provider perspective. When Jeff and I met a number of years ago, he said, you know, Steve, employers think that you guys are tone deaf. And I've been trying to reach employers for years. We had bundled payment and quality products. And I said to the employers, are they brain dead? Why don't they answer their phone, respond to emails? From my perspective, in the last year, this market is energized. I've never seen this type of activity before. It may be the most impactful piece of federal legislation in the last 40 years. Would you agree?
I mean, it would almost seem that employers, especially the large employers, and I'm thinking of the ones in the state that are, 2,000 over, employees, are now players in driving the cost down. I know the carriers have been in some cases, but I think with the passage of this act, there's now more pressure from large employers to say, this is what my employees are dealing with. We have, for example, a large population with breast cancer. So we are going to be making sure that coverage is there for, to deal with this, with these issues, and then taking that data and being able to go to the market and saying, we need this quality care at the best price possible. Is that something that could be going on because of this?
It's already happening. So all you have to do is read the paper. So lots of people anticipated this legislation was going to get passed 2 or 3 years ago. Walgreens 6 weeks ago spent $10 billion on Village MD, a tech-enabled advanced primary care organization. And what was their press release? This is Walgreens, this is a pharmacy. And they said, we will be the leader of curated health services. That's not just primary care, that's hospital at home, and it's virtual behavioral. It's the curation of health services, meaning you can come to us to buy your health services that should be apportioned to your employees, their specific needs, not go wherever you want, whenever you want. No, if you know what you need, we will go at risk with you in this marketplace. And we have purchased an advanced primary care organization who actually will go into legacy fee-for-service primary care areas and go at risk with those organizations. So they're open 24/7. So the patient can be seen 24/7, can be seen by an integrated practice unit with PharmDs and behaviorists, and gets graded on a net promoter score of 93. That means we really like you a lot. And the health system has never really had this. It's never been an open marketplace. This week, Anthem's parent company, Elevance, actually announced a separate health services company so that employers could go and procure health services from that separate company. Cigna has a separate innovation unit as well that you can procure health services from. It's changing. Things are changing, and this has been a big impetus.
Thank you, Representative Wood. Thank you all for being on the panel. It's been a long day. I was here earlier, and if there are things I might have missed and repeat, bear with me. The title of this section, let me repeat, is, moving to value in Connecticut, creating a transformed healthcare ecosystem through industry collaboration. We've had earlier today our pharmaceutical, our PBMs, our hospitals, and then we've had academic experts. Could you kind of put it together from a standpoint of where all these moving pieces are collaborating to create a more communicative and interactive ecosystem driving toward cost savings? Because I think one of the biggest challenges is there's so many silos that control pricing, and people protect their their niche area in their margins. How do we drive that collaboration? We heard from the experts, and I'm grateful to the panel for convening this elite group, but we've heard from one end, we've heard from that conditions. You're executing this. Share with us what your experience to bring all those entities together. Again, let me repeat, it's the pharma, it's our PBMs, it's our hospitals. How do we work together to drive down costs while maintaining the highest standard of care, as Commissioner Gifford had mentioned earlier? Because that is the utmost priority, but the cost is absolutely unsustainable. Anybody want that one?
So it's a great question. I've said it before, actually, in testimony before the legislature, that having been in healthcare for 37 years, that I refer to healthcare as pre-French Revolution France, the landed gentry and baronries. So it's been that way. It's been moded for very, very long, and folks are. It's changing because of the incentives in the system. The fact that healthcare is at 20% of GDP, that people can't hire and keep their employees, that they need better, that they're sick of things. So now the constituent parts actually have to work together. I mean, look at what the state of Connecticut did 3 years ago. The largest employer in the state of Connecticut went out, and Anthem is their open source TPA, and they created incentives for episodes of care, targeted price and warranties for the highest volume of services. So they showed an example. That example has been followed by the private sector, and it's happening now. You're also in public policy, you've been incentivizing attributed advanced primary care. It's a big deal. This is the state, if you look at the primary care collaborative data, that spends on average 3.7% of its total cost of care spend on primary care commercially. We're dead last, the worst in the country. Why? Because people just go to the orthopod if their ankle hurts, or they go to a specialist for care. With everyone working together, and Anthem and Cigna are doing this, and other carriers as well, creating an infrastructure of at-risk, value-based providers, at-risk, integrated providers, we get predictability in the system. Employers need the data. They haven't had it in the past. Like I said, the Connecticut All Payers Claims Database, getting that into RAND was a great first step to start that discussion about cost and quality. And the players are starting to work together. We need good public policy that incentivizes this innovation, this care transformation, this payment reform.
Any other questions from the panel? Paul?
Thanks. I have a real quick one. And you just got to the point, Jeff. Many of us were, okay, Paul Lombardo, I'm the Assistant Deputy Commissioner for the Life and Health Division at the Insurance Department in Connecticut. Many of us here have been born and raised in Connecticut. We don't like to be told who we can go to, right? We don't like to be told when we can go. We're a small geographic state. How do we work with the constituents, the consumers in this state, to make them understand that what we're suggesting here is better outcomes at a lower, more affordable cost point, and to the other point, less out-of-pocket money for them?
So it's a great question. I'm a reformed public official. I was the mayor of Farmington. So I've dealt with this. George Ryder was a former insurance commissioner and also served in the same position. So we've had this conversation often. My son is a Bristol cop, has been for 11 years. My daughter is a teacher. And it's interesting when they came to me with their contracts, which were up for negotiation. And I had 5 or 6 cops sitting in front of me and say, do you realize that our health plan costs $32,000 a year and we're only making X. And my daughter, who's a teacher, had a similar conversation with me as well. This is how. And I will tell you, having worked on state plans all over the country, having had conversations with cops and firemen and teachers and social workers, this can't continue. And believe it or not, the unions are the ones that are most sick of this and are actually doing things about it because they are the beneficiaries of these plans. If I were to show you the best examples of data being used, it's in Taft-Hartley plans around the country. We're sick of this. And the OPEB liability for healthcare retirees, they're not going to have that coverage in the future. So your question is perfect. The most important question they ask is how. Because unfortunately, the people that have been giving advice in the past have been incentivized for these plans to cost more, and they're paid based upon them costing more as well. So that is really the question that vexes CAA right now. Who exactly will inform the CFO and the fiduciaries about what they need to do? And I'll tell you, a lot of these organizations are bringing on chief medical officers. 2 Fortune 500 companies in Connecticut have hired them just to deal with this specific issue. So your question was perfect, and thank you.
Could I just follow
And-
up, follow up on Paul's question? So you told us a happy story about Stu Leonard's, to say 37%. My follow on to you is I'm asking, were the employees given a choice or not to go into that plan?
Thanks, Ted. You guys are going to think that these questions were planted, so they're perfect. So, so the answer was yes. In the first years, they were given a choice. A major portion of the population, they were incentivized to take the plan that used advanced primary care steering to specific facilities and what have you. It was a huge incentive. The second plan was a network plan with a big deductible. Employees are sick and tired of having $2,000 or $3,000 or $5,000 deductibles. It's not coverage. They can't afford it anymore, particularly when they're contributing cost share for these plans as well. So the answer is, despite that, that was the savings.
Sure, I've had my chance, so if you haven't, okay. Thank you, Senator. I want to ask our health plan panelists, and thank you for this information. Deidre Gifford, Office of Healthcare Strategy. I gotcha. You've all in some way talked about the importance of transparency, and I think we are all big believers in that transparency. That opacity in our healthcare system has been the enemy, and transparency is going to be a necessary but not sufficient tool to getting a grip on prices in healthcare. So one of the things we have is our APCD, thanks to my predecessor and the hard work at OHS and the collaboration with the legislature. And now we have our cost growth benchmark. So I wanted to ask you at the carrier side of things, how are you using the cost growth benchmark in your conversations with your customers and with the providers with whom you're negotiating? Because I think we've heard today how significant a tool that can be, and how are you experiencing it so far? Thank you.
So for Anthem, it's definitely been part of the conversation with the providers. And it has up to this point, it has been welcomed. You know, I think the devil will be in the details if we get into any terminations. Right now, we don't have any. But it has been a welcomed conversation with the health systems that we have been talking with, that we've got up for negotiation. I think it's a little bit, the employers are interested in it. They don't quite know what to do with it necessarily, especially on the APCD side. You'll see that, I'm sure you know that most of the people that have pulled the data from the APCD are more of the brokers. They're more of the policy people, the plans themselves. I think regular average people and even regular average groups employer groups don't necessarily know what to do with it when they get it. And so I do think that's where the CAA is probably going to be helpful. But up to this point, it's been a welcomed conversation within the providers, at least with Anthem. I can't speak for anybody else, but at least for us, it has been.
I'm not able to speak specific with the cost growth benchmark, as that would lie with really in the network and contracting part of our organization and kind of outside of my scope as a medical director. I would like, though, to bring in a point for the senator's question, the commissioner's question about collaboration, bringing it all together, and transparency. And I would say, as an experienced clinician in Connecticut, but relatively new in my role in Cigna, I have been incredibly impressed, touched, if you will, by the role that the employer plays in this whole process. I'm incredibly, every day, impressed at how so many of our employers truly have the best interest of their employees in mind. And so I think one of the ways that we disseminate this information in as a transparent manner, because let's be honest, when the insurance company comes up on the phone, a lot of folks don't answer the phone. We even have, bet you do too, we have campaigns that when Cigna calls, please answer. But the way we get that information down at the public level is through the employer. And although I don't know how we bring, for the senator's question, all this together, great question, very complex, I do believe the employer will play a major role in that moving forward.
Great. Well, this was really fascinating. Thank you so much for spending time with us today. And we hope to work with you on as we move these policies forward in this legislative session. So we may be calling you back again. So thank you all. Thanks for all the great questions today.
Thanks. We're going to take a quick 5-minute break before we go on to our section 4. So we'll see you all back here at about 2:07. Thanks. Welcome back, everybody. We're going to reconvene the Healthcare Cost Drivers Forum. We're up to section 4, further perspectives, and Connecticut State retirees and employees plan case study, 1 hour. We're going to kick off with hearing from Josh Wojcik from the Office of State Comptroller. Then we're going to hear from Katie Goodixson, who's a senior health policy researcher for the Source on Healthcare Price and Competition at UC Hastings Law School. And without further ado, I will ask Josh Wojcik of the Office of the State Comptroller to kick us off.
Thank you, Ted. Really appreciate it. And just appreciate the invite to be here and just the fact that this is happening, gathering everyone together and reviewing these options. So I'm Josh Wojcik. I'm the director of the Health Policy and Benefits Services Division at the Comptroller's Office. That is the division that administers the state employee health plan. We can move to the next slide. So just for some quick background we wanted to share before we sort of dive into looking at a few initiatives that the state plan is endeavoring upon. First off, state health plan it administers or covers about 215,000 non-Medicare eligible plan participants. That includes state employees, their dependents, as well as a variety of municipal and Board of Education employees who have the ability to join the plan as well, and their dependents, as well as retirees and dependents. Looking at utilization, I just wanted to sort of highlight this so folks could kind of see, where are the cost drivers and, how has the plan been performing in the most recent periods. So this is the most recent 12 months through the end of September. So sort of running through the first quarter of this year. You can kind of see some of the challenges that we're seeing, and they're not unique to the state plan. I think you see this very broadly in the marketplace. Outpatient facilities, so that's your outpatient services, things like surgeries, et cetera. Really high utilization. Some of that is pent up demand. A lot of those voluntary surgeries were delayed over the COVID period and then came into play during this time period. But just broadly, I think we're seeing more utilization there as more individuals are getting hip and knee replacements and other things like that. Pharmacy continues to be a large challenge for the state plan and for I think plans in general. And if you look at sort of the total cost, you can see about a 6% trend over this time period. That's coming down a little bit, starting to return a little more to normal after last year, where there was a really big jump up in utilization coming out of COVID and with some of the Omicron utilization that happened as well. But nonetheless, I think, is the whole reason why we're having this conversation is because that 6.1%, while it's coming back down to more normal levels, is not sustainable long term. So if we can move to the next slide. So I want to talk about a few initiatives that the state plan is engaged in, and particularly sort of value-based initiatives, areas where we are looking to kind of adjust the market incentives, have a better alignment between the interests of the health plan, which really represents the payer and which is funded by state taxpayers in this case, providers and the members of the health plan. So when we think about that, it's I guess sort of a complex goal, right? Their price is a component, certainly in the fee-for-service world that we are in, right? It encourages higher utilization, it encourages higher prices. It doesn't encourage a lot of value, and I think we've heard a lot about that throughout the day today. So looking at different models and different avenues to maybe encourage more value into the system. But not only value, not only value from a price perspective, but value from a service perspective and quality perspective as well. So a few things we'll talk about. We have a primary care initiative pilot. Also want to talk about our provider of distinction and center of excellence program. And then finally talk through a few things we're doing on the pharmacy side of the book of businesses. That is again a real cost driver. So if we can go to the next slide. All right, so we'll dive into the primary care initiative pilot. Next slide. So this is a pilot program where what we're trying to do with the state plan is drive towards meeting broader statewide goals. So I have listed up there the targets for the healthcare cross growth benchmark and targets for primary care spend. Those the legislator passed last year as statewide initiatives, and prior to that, the governor had promoted them through an executive order. And so what this initiative is really trying to do is leverage those statewide policies and put them into a reimbursement program that hopefully will help us manage healthcare cost growth, help us to manage the increase in expenditures over time, and improve quality. So really getting at, you know, I got the quadruple aim over there on the right, trying to address all of those areas. And I'll talk a little bit about all the different features of this program as we go along. So if we can go to the next slide. All right, so key features of this. So the first one is significantly increasing funding for primary care through increased care coordination fees. So this is an effort to give primary care groups more money upfront so that they can invest in more resources for care coordination, for behavioral health management, for engaging in social determinant, or engaging their patients in social determinants of health, et cetera. You know, so the fee-for-service market or fee-for-service reimbursement structure doesn't really allow for that. There's generally not reimbursement for many of those things, and certainly not upfront reimbursement. And so what we're trying to do is provide them those funds upfront through a standard monthly payment based upon the number of attributed patients to their practice. And to just give you some concept of how much these fees are, well, I guess we'll talk about it in the next one, but it is increasing what they're getting from the typical commercial carriers by about 400 to 500%. So it's a lot. In relation to that, we are looking to require those resources, right, to be invested in the areas I just mentioned, but they align with the 11 core competencies of the primary care roadmap that was produced by the Office of Health Strategy. We also have a quality bonus component of this, and for that quality bonus, we are leveraging the Office of Health Strategy's Quality Council core measure set. So performance on those core measures allows these groups to earn additional funds, which again can be significant. And then in exchange for these additional funds, we are looking for accountability. So on the accountability side, we're asking these groups who participate to share risk and total cost of care. So to actually take some downside risk, not just upside risk, relative to hitting total cost of care targets. And so if they miss those targets, they could actually owe the state plan money back. I'll be looking for annual reporting. I want to understand how they spent the dollars and make sure that they spent it to improve those 11 core competencies, as highlighted earlier. And then finally, if and when we have a recognition process in the state to identify high-performing primary care groups, we would require groups to go through that recognition process to make sure that they have the capacities that they claim to have. On the other side of the ledger, you know, we are looking to provide from a plan perspective as many resources as we can to help support primary care groups in this endeavor to make sure that they're successful. This is some learning that we've had in the past through our work with episodes of care, another sort of value-based model. And what we found there was, you know, having a lot of analytic support from outside to help identify opportunities, to help make plans to target those identified opportunities can really be beneficial for the groups that are engaged in this and allow them to really succeed. If we go to the next slide. All right, so the next few slides, we'll just talk through sort of the details and the components of this initiative. So in the care coordination fee front, as I mentioned, a significant increase in care coordination fees, monthly payments. So those would be $12 a month, risk adjusted. It turns out that the state employee plan is a little bit riskier than the market in general. So actually, when you risk adjust them, they're even a little higher than that. They average close to $15. The enhanced care coordination fees, right, are in addition to what our carrier Anthem already pays these groups. So it's 100% additional funds. And the additional funds are not at risk, right? They're not put into that calculation of total cost of care. And the purpose of doing that is to make sure that these groups are comfortable in spending these dollars up front, making the investments because they know they don't need to pay it back at the end of the day. And in fact, by making the investments, they're going to be much more likely to achieve those cost growth targets. Next slide, please. All right, so what are those cost growth targets? They're listed here. In this model, it's a prospective trend target. So we'd look at historic performance, would add a trend onto that, would say that's your budget for next year. If you beat that, we'll share the savings. If you don't beat that, we're going to share in the loss. And so that's really sort of the design of the program. Measurement year one, we're sort of targeting 5%. We bring that down to 4% in year two. And then finally, by measurement year three, which would be calendar year, say 25, we would have the target actually meet the healthcare cost growth benchmark. So trying to leverage that healthcare cost growth benchmark as our long-term target for these groups to meet. And when they beat it, that's when we'd share savings with them. And if they don't beat it, right, they would share in the responsibility for that loss. We can go to the next slide, please. This slide just gives a little understanding of what the levels of risk are associated with this. So it starts off lower and then increases. Groups can sort of choose from anywhere on this menu as to the risk level that they are comfortable with. There are, caps on overall risk that is purposeful, right? We're not asking provider groups to be insurance companies. If the pandemic hits and utilization increases, another pandemic hits, utilization increases by 20%, we're not looking to have hospitals go out of business. So there is a cap on overall liability, which is fairly reasonable. We can go to the next slide, please. All right, and then there's a quality bonus. Key component of this, we want to encourage quality improvement over time from the participating primary care groups. And so what we did, we took $3 PMPM, which is about what they get today in their overall care coordination from carriers. And we established that as a quality bonus. So to the extent that they achieve quality benchmarks, they'll receive that bonus. If they don't achieve them, that bonus would be reduced. At the end of the day, we are trying to increase total revenue going to primary care so that they have more capacities. So for the quality bonus that is not achieved by a particular group, let's say they only earned $2 of the $3 because they missed a couple of quality metrics, that extra dollar would go into an excess quality bonus pool, and those groups who performed the best of all groups involved, essentially looking at the top 20%. So if you top quartile, I guess it's saying there, but let's say we have 10 groups involved, then the top 2 performing groups would split the excess quality bonus pool, and that's important because we don't want groups to sort of stop once they hit the sort of minimum benchmarks for quality. We want them to go as far as they can and improve quality metrics as much as possible in any given year. And so this excess quality bonus pool, which will be significant when you model it out, really provides that incentive to improve quality as much as they possibly can in any given year. We can go to the next slide, please. This is the recognition requirement. So again, if and when we have a recognition process in the state, certainly there's been some proposed, but I don't think we've had funding associated with it. We would require participating groups to go through this and eventually get all of their groups, recognized under that recognition process. Next slide, please. All right, so this is sort of getting back to what I highlighted on that sort of initial summary screen of, what can we do as a state plan, as a payer, to be a real partner with these provider groups who are engaged with us in partnership relative to this initiative. So it's not just here, give them the dollars, give them a little bit of data, and good luck. It's, what can the plan, how can the plan actually structure itself and provide resources? So I mentioned the dedicated analytics and clinical staff that are going to be associated with this. So that is a group that will be dedicated specifically to this program. They'll reside at Anthem. They'll be Anthem staff, but we've worked with them to have a dedicated group specifically for this program. We want to make sure that our plan design sort of aligns with the program goals. I think the state plan sort of starts in a good position on this because of the health enhancement program, because of requirements that folks need to go see their primary care provider on a regular basis, that they need to get preventive care relative to HEP. So I think that that's really helpful. And then we have other aspects of the plan, right, that sort of drive utilization towards more efficient, higher quality providers, which will only help these primary care groups achieve relative to those total cost of care targets. And then the last thing is something that really, we're working through and working on. You've just sort of finalized a procurement, and this is to create a central resource, right, for all of the health plans resources, all plan management, all care navigation, the HEP administration, have all of that sort of in one place, and have a significant resource built around it. And not only have that be a resource for our plan members, but have it be a resource for these provider groups as well, so that they can leverage that, identify, what is available at the plan level. And I can give you a couple of examples, like for no cost, our plan members can enter into a pre-diabetes program, right? So a provider who has someone at risk of becoming diabetic, right, they might be interested in that. Right now, I think it would be difficult for them to recognize that the state plan even has that available. But in this case, I think what we'd be able to do is kind of work with those provider groups to allow them to know, all of our plan resources are going to be here. Here's what they are. Here's a team that you can work with to make sure that folks get enrolled in the right resources that are appropriate for them. And that'll just benefit both the plan, the provider, and the member as well. So if we can go to the next slide. So just quickly on participation, when we first launched the concept of this program, we asked groups to sign a letter of intent. We did have 9 provider groups sign that letter of intent, covering about 100,000 members. The program, just for background, actually the first measurement period started this year, so on January 1. A few of those 9 providers are still working through the contractual terms, but all of them are committed and are planning on joining. We even have one more that we're continuing to talk with, so that number might go up a little bit, but we will at least have about 100,000 of our members participating under this program. Next slide, please. All right, so the next item I wanted to talk about in terms of our sort of value-based initiatives is our Provider of Distinction and Center of Excellence program. We can go to the next slide. So this is a program that encourages members, health plan members, right, to utilize high quality, low cost providers and facilities for select services and provides them a cash incentive when they do that. So we're talking things like knee replacements, bariatric surgery, and smaller items like colonoscopies as well. So there's a network. Folks can look up providers that are participating or that are designated as providers of distinction or centers of excellence. If they go to those locations, they will receive a cash incentive. What this is really doing, this program, it's leveraging existing variation in the marketplace. I think we've heard a lot about that over the course of today. That there's a lot of inconsistency in both quality and cost across hospitals and facilities and provider groups. And so what this is sort of doing is trying to identify those that are high quality, those that are lower cost. And when we think about lower cost, we're really thinking about efficiency. So the total cost of the episode. I think somebody mentioned earlier, something that can really drive additional costs are medical errors or hospital contracted infections, that result in rehospitalizations and other things like that. All of that gets incorporated into the overall costs that we're looking at when we identify who should be designated for a provider of distinction or a center of excellence. Oh, sorry, if you go back one more. And the last thing, relative to this program, I think it not only encourages our members to go to those locations, right, the ones that are performing well, but it can also, encourage, hopefully in the long term, it can encourage providers to perform well as well, because their designations, either maintaining that designation or receiving that designation is dependent on their performance. So we can go to the next slide. So quickly, just on the impact of the Provider of Distinction program, what we've seen is overall a 6% increase in the market share associated with those groups that are designated as provider of distinction. We estimate that change in market share saved the plan about $4 million in fiscal year 22, so this past fiscal year. And next slide. We are working on updating this program. Hope to have these updates in place for July 1, but looking at a variety of items here, the list of incentives, the eligible providers, et cetera. But some key components that I think are important to increasing the change in the market share associated with providers of distinction, right? We've seen some change in market share, that 6% increase, that's good. I think we could do a lot better. So a couple of pieces to do that. We are trying to integrate the lookup tool for the provider of distinction with the broader plans lookup tool. Most of our members use a provider lookup tool, but many fewer will actually identify and find the provider of distinction lookup tool. So integrating those two together is going to be important. We had new vendor in place, that will do outbound outreach, which will help. And then finally, we'll be looking to coordinate this with the primary care initiative so that those primary care groups can benefit by making referrals to these locations as well. Next slide, please. All right, pharmacy initiatives. So a few things just wanted to touch on pharmacy. So the first one that we've been focused on, and this goes back a few years now, but is really looking at transparency with our pharmacy benefit manager. So our current contract, we have CVS Caremark under Aetna. And Aetna as our PBM today, but we have full pass-through pricing, right? So the state pays what the pharmacy is paid. So this was discussed earlier. We do have this in place for the state plan. We also have full pass-through of all manufacturer revenue. That means any rebates or any other revenue at all, regardless of what it's called, that goes to manufacturers that is associated with the utilization on the state plan. It's passed back to the state plan. We also have acquisition cost pricing of specialty and mail order drugs. This is actually really important that I don't think folks fully appreciate, but there's a lot of opportunity for profit margins in the wholly owned pharmacies of the PBM, right? So most of our specialty utilization actually goes through CVS specialty pharmacy, the vast majority of it, in fact. So we have acquisition cost pricing, which means that whatever they pay to acquire that drug from the manufacturer, the wholesale, or whatever they're getting it, we pay that exact same price, and then we give them a explicit administrative fee for dispensing the drug. And so it's very clear what we pay. It results, to be frank, in very low specialty costs for how do I say that? Very aggressive specialty pricing. Specialty drugs are expensive, so it's not low cost. And then finally, we have an explicit administrative fee. That's essentially how we pay them. Is a per member per month administrative fee. So anything beyond specialty, that's how they're getting paid. Next slide, please. So another thing that I think is important on the pharmacy side that we are working towards is that in any value-based arrangements, right, providers are going at risk, trying to include pharmacy, retail pharmacy as part of that. I will tell you that in most value-based arrangements in the state with carriers, pharmacy is not included, retail pharmacy is not included. We do include it in the primary care initiative, and I think it's vitally important, right, because the prescriber it has the best opportunity to identify the highest value prescription and actually prescribe it and sort of change the marketplace a little bit. Unfortunately, today, right, we have a prescription drug market where the prescriber is going to look at the out-of-pocket cost of the member, but oftentimes they'll actually have copays that were provided, or copay assistance, right, through coupons that were provided by the drug manufacturer. Those are in the office, and it turns out that sometimes prescribing the higher cost drug can be cheaper for the member because that copay assistance will bring that cost down to $0 for the member. And so suddenly we're getting a prescription of a higher cost drug, even though the value may not be much, may not be any more for the actual patient. So, I think changing that dynamic by making sure that providers have the information they need to understand the actual costs of the drugs that they're prescribing. And then when they don't have a preference from a clinical standpoint, they can make decisions based upon the actual underlying cost of the drug. And I think that could go a long way over the long term to help retain cost growth relative to pharmacy. All right, next slide, please. And this is my last one that I was gonna just highlight on. So on pharmacy initiatives, one more thing that we are doing in the state plan, this was included in the labor agreement this spring, but we've actually moved to a scenario in which we leverage, just talked about manufacturer assistance and how it can sort of turn formulary strategies upside down, but in the specialty marketplace, the state plan is actually leveraging manufacturing assistance to lower costs for both our plan members and for the plan itself. And so what we're actually doing is we're applying manufacturer assistance for a high cost drug. Let's take something like Humira. Humira might have $1,000 coupon available for it. Our members would normally pay $40 for a specialty drug. We're going to apply $40 of that coupon to the member. They're going to pay $0 now. The other $1,000 is going to be applied to the plan's cost. So instead of Humira now costing the plan $5,000 and the member $40, it's going to cost the member $0 and the plan about $4,000, right? So really significant savings. The program is it's voluntary. You can opt out of it. Almost nobody did, which was nice. And it's saved about $14.3 million through the first 6 months of the year for the plan, and $700,000 for members. And it's actually resulting in a negative overall trend for specialty pharmacy, which is really significant because specialty pharmacy is the highest growth area for retail pharmacy today. All right, next slide. I think I'm just about done. So just in conclusion, I think some of the key pieces here that we're looking at is, aligning those incentives between the payer, the patient, and the provider, creating partnerships, right? Making sure that all parties are working towards the same goal. Transparency, everyone needs the information in order to make this successful. And none of this is going to happen overnight, right? Because it requires a lot of resources, it requires a lot of change in practice. So really need a long-term focus. And the last thing I'll say too is, I think relative to these programs, the state plan is sort of, trying some of these things, but it can't be the state plan alone. So, we're trying to leverage statewide policy goals, and we hope that we can help to drive those more broadly into the marketplace. And that's all I have.
Thank you. That was Josh Wojcik from the Office of the State Comptroller. Quick clarifying question, Josh. How many people are covered under the state employee plan at the moment?
Yeah, so in total with the Medicare covered lives, it's about 275,000, but it's 215,000 with just the commercial covered lives.
Gotcha. Okay, thanks so much. So now we're going to go to Katie Goodixson. Katie is a senior health policy researcher for the Source on Healthcare Price and Competition at UC Hastings Law School. Katie, if you're there, please go ahead and welcome.
Yes, thank you very much. It's a privilege to talk to you today. I'm from the Source on Healthcare Price and Competition. We're a grant-funded group at what's now known as UC College of the Law, San Francisco. And just before I start, we run a website with all kinds of additional resources and details on all the topics that I'll talk about today. So I encourage anyone who's interested to go there and look for more information. I also have the advantage of speaking at the end of the day and sort of batting cleanup, so I can reiterate a lot of what was said in earlier presentations, and I get to focus on a few things that perhaps weren't emphasized as much. And in a way that was unplanned, I get to end the day with one of the first slides and show that the US spends a lot more on healthcare and doesn't get good value for those dollars. And in addition, price is the primary reason for that. The Healthcare Cost Institute estimated that of the increased spending since 2014, about 75% of that is just due to increased prices. About 20% is due to an increase in quantity or intensity of services, and 4% is due to an aging population. And so we've seen lots of this in the last session and other things today. So I just wanted to talk a little bit about solutions. Last September, the Congressional Budget Office came out with an analysis of all kinds of policy approaches to reducing commercial health insurance spending. And they grouped all the policies that they found into 3 buckets: promoting price transparency, promoting competition among providers, and capping the level of or growth of prices. I'm not going to talk about transparency today, partly because Connecticut is really a leader here, and also because the CBO found that it would have a very small price reduction. I do want to spend just a minute on promoting competition among providers, because I don't think it got touched on too much this morning. And in addition, this is taken from a newspaper article from the Connecticut Mirror. So it shows that consolidation is a big problem in Connecticut. The preponderance of research evidence shows that consolidation leads to higher prices, but higher costs is not the only problem. So access and in particular equity can be really exacerbated when a large health system buys a rural facility and then moves a lot of services like labor and delivery to the large urban centers. And that leaves rural and sort of economically disadvantaged communities even worse off. So protecting healthcare markets and regulating them when competition has failed is critical. And here, Connecticut, again, is one of the leaders in the way it reviews transactions. Now, Connecticut does it through its CON program. The other 3 states here have sort of set up independent agencies or commissions to review mergers when they happen. But the interesting thing about Connecticut and Oregon actually is that their offices have the ability to actually place conditions or have the authority to block mergers, unlike Massachusetts and California. California is just setting up their office, but both Massachusetts and California will just have the ability to write reports, and then they rely on the AG to block the mergers in court and rely on things like antitrust law or other law to do that. And the reason that I want to point this out is that if you have an agency like the Office of Health Strategy, the CON program, it's one of the few places that can place conditions around access and equity on proposed transactions, and that can be very hard to do if you're doing it through antitrust law. And so we have a project now looking across the country at all conditional approvals and what states can do here. And I just want to point out that there are some gaps in the authority of Connecticut's Office of Health Strategy, particularly around acquisitions of small physician groups or sort of joint ventures, affiliations, et cetera. And I would encourage people looking for policy solutions here to look at better merger review as one of those tools in the toolbox there. And the other place that I would talk about in terms of promoting competition is in banning the use of specific contract terms. So I actually worked with Aaron Fusay-Brown and then we worked with NASHP to draft the NASHP model legislation here to prevent these anti-competitive contract terms. And I certainly wouldn't say that these are the solution to healthcare prices, but I do think they're an important tool in sort of untying the hands of insurers and employers who are looking to implement some of the cost-saving sort of centers of excellence that we heard about before, some of these policy tools. And I think it's really important to think about this law. I know, or this bill, I know it was introduced in Connecticut last session. And so I would encourage you to consider whether this would be a possibility for for this session. But unfortunately, simply promoting competition or trying to protect remaining competition is somewhat of a losing battle, because in many cases the train has simply left the station, and we're just dealing with markets that are extremely highly concentrated, which is why I'll talk about this last bucket for most of my time. And this is capping the level or growth of prices. And I'm going to use that pretty broadly, interpret that pretty broadly. And so we've actually put out a range of policy options, or sort of evaluated them and offered recommendations to states who are looking to implement some of these. I put a paper up here that I co-authored with Bob Murray, who actually ran the HSCRC in Maryland for many, many years. And so he's a real expert on a lot of these payment models. And so on all of these, we've heard a lot about these this morning. I'm going to touch on a couple of them very briefly. But as I said, there's lots more information on our website or on this paper as well. And so the first are cost growth targets, cost growth benchmarks. I'm really not going to say much more here because I think Michael Balick covered it exceptionally well this morning, and just say that we completely agree with him that it's a great foundation to build a lot of these other models on. And, you know, Connecticut has one, and that provides you with a lot of experience and expertise for implementing a lot of these other options. And again, we heard a lot about public options this morning, and I know that's been a consideration in Connecticut in the past. I just want to emphasize that we think a lot of these policy options work best together. There's kind of forms of patchwork or a quilt of options that sort of bolster each other and really allow the market to work within some constraints. And a public option plan is one way that can really help pass the savings on and any savings from lower provider rates back to employers and to patients, because there is actually competition among insurance plans. And so this could be particularly useful in conjunction with some of the other things that I'll talk about today. We heard a lot about affordability standards or enhanced rate review this morning. And rate review, all states have either file and use or prior approval authority for the Department of Insurance. And the ACA requires justification of excessive increases in the individual and small group market, but very few states have prior approval for large group rates. And the ACA doesn't have any requirement for large group markets. And so when using affordability standards, the state insurance commissioner can reject these unaffordable rate increases. And these could be tied to a cost growth benchmark in the states that have them, like Connecticut. We heard about Rhode Island's success, so I'm not going to necessarily go through it in detail, except to say that there were a few limitations. We talked about, it was mentioned this morning, that the percent rate increase kind of exacerbates payment disparities. As was also said, there was a one-time correction to this, but tiered updates could fix this. But perhaps even more importantly, the Rhode Island model only applies to hospitals. And so while Rhode Island has some of the lowest hospital prices in the country, they have some of the most expensive physician prices. And there's some evidence that this sort of affordability standard, the way it's been implemented in Rhode Island, has actually driven consolidation among providers. And so I would encourage anyone looking to duplicate sort of or build upon Rhode Island's experience to consider those limitations and really try to address them. And so when we're talking about whether the affordability standards can control costs, they're one of the few models that actually has demonstrated success. So Rhode Island has really shown that these can control costs. There are some things that may be specific to Rhode Island, but we believe that those could be modified for other states. It can be implemented and enforced by the Department of Insurance, so it relies on existing state agency. It doesn't require a whole new agency. And the cap on insurance premiums, similar to the public option, actually requires any savings to be passed to patients and employers. And the affordability standards actually has likely a lower risk of regulatory failure or capture than some of the other models, because first of all, it's still market-based. There's sort of an overall cap on, and commercial insurers can gain negotiating leverage, but it still requires the market to operate. But maybe more importantly, the interests of the Department of Insurance and the industry being regulated, which is the insurers, are aligned, rather than rate-setting agencies where they're directly regulating the providers, and there's kind of almost an adversarial relationship there in terms of price setting. Affordability standards likely have a lower risk of regulatory capture and failure. So moving on to out-of-network caps, again, I'm going to spend just a little bit of time on this because we heard all about it this morning. They're a maximum payment that applies when a patient gets out-of-network care, and it's very similar to surprise billing laws, but they apply in non-emergent situations. Because currently providers threaten sort of exorbitant out-of-network prices to negotiate in-network rates. This has been seen in some lawsuits across the country. It was alleged in the Sutter lawsuit, the lawsuit against Sutter Health in California, that was one of the reasons that Sutter had excessive prices. And so the out-of-network caps, they do save money by truncating these very high out-of-network prices, but even more important, there's this spillover effect to increase the bargaining power to lower in-network rates of insurers. In Medicare Advantage, there is a de facto out-of-network cap that basically caps rates paid by Medicare Advantage to that of Medicare fee-for-service. And it appears to have caused the in-network Medicare Advantage rates to be at or near the cap for in-network prices. In California, their surprise billing has a payment standard for out-of-network rates, and it caused the anesthesiologist rates in that state to decrease for both out-of-network and in-network rates. And there was a publication by RAND that estimated that a nationwide out-of-network cap that was set at 200% of Medicare rates would save $81 billion in lower in-network hospital rates, which is actually 7% of total commercial spending. So a few considerations or caveats for states that are interested in out-of-network caps. They probably should be coupled with strong network adequacy protections, although I would say that perhaps this could be a little bit addressed by also setting the out-of-network rate, making sure the out-of-network rate was set above the marginal rate to provide care. Because as long as that rate is enough that a hospital is still making some money, unless they can replace that patient with another higher paying patient, it's still in their best interest to see that patient. So it's particularly important when setting these out-of-network rates to think about the marginal cost of providing care of the hospitals and making sure that the out-of-network caps are not too low. Because these out-of-network caps, if they are too low, they can lead to these diminished provider networks and really have an effect on access to care. And the out-of-network price caps also probably work best in competitive insurance markets, so that the savings from the reduced in-network rates are then passed on to the consumers. And then something else that was discussed this morning, but I want to talk a little bit more in detail about hospital global budgets. As mentioned, these have been used in Maryland, but I want to point out that there are two different possibilities for hospital global budgets. One of them are 100% fixed, and that's where the global budget for the hospital is set for the year, and that's the way Maryland does it. You could also set a flexible global budget, and that's where there is a particular amount given to the hospital to cover their fixed costs, and then there's a percentage above that that's adjusted based on the amount of care that the hospital provides. And the flexible budget neutralizes sort of the fee-for-service incentives to increase volume, so that's why you'd have a global budget to begin with. But the flexible global budget also allows for payer shifts. So in Maryland, there's an incentive to shift care out of the hospital into a physician's office or some other site of care. And so the state winds up paying for, or the payers wind up paying for that care, both in the global budget and at the additional site. The flexible global budget actually then would reduce the amount paid to the hospital if the care was shifted outwards, and it also then increases the payment if they have an increase in the number of patients. And so it also provides no incentive to stint on care because they're actually being paid to cover their marginal costs. A quick comparison of global budget models. There was one in Rochester, New York that is no longer in operation, but this is one that is considered a big success because it was very formula driven and aggregate and did not require as many resources or sort of the regulatory oversight that some of the other global budget models are, in Maryland in particular, takes. The model was successful. It reduced unnecessary hospital care and constrained total cost growth. It was ended when Medicare changed the way they did reimbursement rates, and the hospitals sort of opted out of this global budget model. We heard about Maryland this morning, so I don't think I really need to go into too much more detail here, but I can answer questions. But I did want to point out that Pennsylvania obtained a waiver to do a global budget model in 2017. And so it was mentioned that perhaps Medicare wouldn't be approving these waivers. Now, it's important to point out that the payment rates for Medicare and commercial payers, there was no equalization of that. The waiver was approved to limit the amount of growth in in Medicare payments. And this, due to COVID, the Pennsylvania model is experiencing some implementation delays. And it's also a voluntary model, so hospitals can opt out if they want to, which may really limit the ability of this model to really realize cost savings. But it is a model for other states that want to follow. In the interest of time, I'm not going to speak much at all about price caps, except to say that some economists have proposed very high price caps and said that was a very low regulatory model. Our opinion is that that's actually having to update these rates and each year, et cetera, and set the rates. It's actually relatively regulatory, pretty regulatory intensive option. And then there's also another model, a population-based payment model that actually could incentivize population level costs and quality targets. And Vermont's all-payer ACO model is an option here. Since it is such a high intensity model, I'm not going to talk about it in detail today, but again, I'm happy to answer questions, and there are resources on the source. So in conclusion, there are an array of options for policymakers to address prices. So in protecting competition and improving merger review are very important, but they're unlikely to address prices in isolation. So multiple interventions that target prices more directly are likely most effective. I'd make the case that lower intensity rate methods can be effective. They can be more feasible to pass and implement, but perhaps more important, they're less likely to be limited by regulatory capture and failure. Specifically in Connecticut, the cost growth benchmark really provides the basis for all these other interventions. And we might consider recommending a combination of the 3 middle intensity options. As was said earlier, I think the biggest risk is perhaps doing nothing. And I hope I've presented a lot of options today, sort of echoing a lot of the things that were said earlier this morning. And I think the most important thing is to choose which one that seems to fit priorities best, or perhaps target some of the inefficiencies in the market in Connecticut, and start there. Thank you very much.
Thank you to Katie Goodixson from the UC Hastings College of Law. Much appreciated. Before we go to questions, I just want to get one historical question for Josh Wojcik. Josh, before the comptroller's office started focusing on the value-based initiatives, can you give us some history as to whether or not you took on prices directly in terms of negotiation? And if you did, were you able to get discounts with the large healthcare systems successfully or not?
So a couple of pieces associated with that. I think, we certainly targeted prices through, and it was partially through a value-based initiative, but a component of the Provider of Distinction and Center of Excellence program initially was also an underlying episode of care contracting initiative. And what that means is that in order for a group to have been designated a provider of distinction or center of excellence, they had to meet 3 criteria. 1, they had to be, high quality. 2, they had to be efficient, so lower total cost. But 3, they actually had to sign a episode of care contract with a third-party administrator that the state had leveraged. So the incentive in place was that if a group wanted to participate and actually be designated and benefit from the higher utilization that might come from the incentives that were being given to state employees, and they would have to engage in that episode of care contract. A group who maybe was high quality but higher cost could lower their price, right? They could essentially agree to an episode of care price that was lower than their historical average, and thereby be designated a provider of distinction. We had some groups do that when they were very close, right? So if they were within 5% or so, a lot of groups were willing to do that and agree to a price that was a little bit lower and go at some level of risk for that. When it wasn't close, it wasn't really a conversation, right? Our market size and the and the fact that it was a voluntary benefit wasn't enough to push them to to adjust their revenue relative to those services to an extent, a significant extent.
I think it's important to note that an employer with 215,000 lives had that type of difficulty moving that particular needle. Thanks, Josh, for that. I'm going to open it up to questions from the other moderators. Let's start with Commissioner Mays. If you're online and have questions, please go ahead.
Yes, I am here. Thanks, Ted. And I guess the only question I have is necessarily, and I'm just throwing this open here because I'm trying to figure out who to ask. It's not necessarily reflective of what was said, but reflective of overall spending. And if you look at the CMS charts for health spending per capita over the past 20 years, with all the changes, and we've looked at Rhode Island, we've mentioned Maryland, we've mentioned Massachusetts, but it's the relationship to Connecticut spending is still pretty much the same. Does that mean that there are things that should have been done that we should be looking to do that haven't been done in any of those 3 states? What are that just strikes me as a warning. So we can implement these changes, but we have to make sure they work. What lessons can we learn from this?
So you're looking for lessons from
The fact that the
Maryland.
health spending per capita, according to CMS, and just looking at the 4 states that I mentioned, Connecticut, Maryland, Massachusetts, and Rhode Island, the states that we were looking at, that there really has not been a significant change in the relationship among the 4 states in the past, 1990 to 2020, which is what that's the data that I'm looking at right now. That was the KFF did it from the CMS data. So, and it just seems to me like, Massachusetts did stuff, Maryland did stuff, Rhode Island did stuff. But are there areas that we're not capturing? Are we focusing too narrowly on one item if the total spending is still increasing at the same rate in each state?
I think there's bigger factors than I think that what speaks to is sort of the health industry writ large, right? There's a lot of factors that go into the healthcare costs that aren't addressable. But I do think that people in those the experts in Massachusetts, Rhode Island, and Maryland would point to their policies and say that they really have had an impact over what the spending could have been. And I think the other point is that in some sense, this is kind of a game of whack-a-mole. And so as I pointed out, sort of in Rhode Island, they kind of really tamped down on hospital spending, and spending on physician services went up. So I think if there's a lesson here, it's that you really need to look at things globally and try a patchwork of options.
Yeah, thanks. That's kind of what I was thinking. We don't want to focus too narrowly on one thing, as you make. Because I was thinking of what you said about the Rhode Island example, and let something else slide. This is clearly an area where we do need a holistic solution. We have to try to get everything at once. So I just wondered if you were in agreement with that. Thank you. And that's it for me, Ted.
Okay. Director Gifford?
Thanks. And thank you, Josh and Katie, very much. And Katie, in particular to you from the West Coast, thank you so much for sitting through our whole day of presenters, and for your kind of expert wrapping up at the end of the day here. I did want to ask you about your Connecticut specific recommendation around flexible global budgets. Could you say, and this sort of as a follow-on to Commissioner May's question about, how should we be thinking about targeting our initiatives here? Can you say a little bit more about flexible global budgets for whom in particular? So, we know Maryland focuses on hospitals, and are you thinking about more comprehensive global budgets in that recommendation, or what would be the scope of that kind of a program? Thank you.
Yeah, I think global budgets are easiest to do with hospital-based care. And so you can also easily, or I shouldn't say easily, it's very feasible to include sort of physicians that are affiliated with hospitals, et cetera, into that. I think it's harder to attribute primary care patients to hospitals in urban areas where patients have a choice. I think global budgets are most easily implemented in rural areas. I think that's why actually Maryland started there, and now Pennsylvania is starting there as well. And so that would be a recommendation, is that you could start with rural facilities, or facilities that are less that serve a given population, and then build over time, which is exactly how Maryland did it. In terms of the flexible global budgets, it's less about who is included in the budget and more about how the rates are set. So typically, global budgets are based on historical spending, and that's important because you don't want a major disruption in hospital profitability and so forth. But the flexible global budget piece of it is that you have some portion of the budget that is fixed, and then some portion of the budget that goes up or down based on the amount of care provided to patients in that community by that facility. Does that answer your question?
Thank you. Yes.
Okay, I just have a follow-up question, Josh. I think you were here when Jeff Hogan was here. He was talking about the experience with Stu Leonard's. They created a value-based or oriented plan, and they got good savings from that. I know the state has something similar with the Quality First Select Access. Can you take us through that and what the challenges have been, what the uptake is on that plan, and what the challenges have been, again, from the perspective of a very large employer?
So the uptake has been limited, right? So in terms of the number of lives that we have in that plan, it's a little over 3,000. As we mentioned before, we've got about 215,000 that would be eligible to be in that plan. And I think the limitations, initially, we actually designed it almost identically to Stu Leonard's, looking at high-performing primary care groups. We worked with Anthem. We had those high-performing primary care groups commit to changing their referral patterns to refer to high-performing specialists. And that's sort of how you kind of roll the savings into that. There was a number of challenges. The number one challenge was our membership does not like gated primary care plans. And in our case, the alternative was not a expensive high deductible plan or a gated primary care plan, which is what it was in for Stu Leonard's. It was a very low cost, point of service plan that has out of network coverage and hardly any copays and no deductible. So it's hard, I think, relative to our population that has a low cost, very expansive option to encourage them to move to a also slightly lower cost limited option, right? And so I think that was a real limitation. In terms of the actual performance of the plan, the second year we actually had to adjust the plan. We actually made it so it wasn't gated for two reasons. One, because we went out and we surveyed our membership and got overwhelming feedback that they weren't going to sign up for it as long as it remained gated. And so what we did was we just made those higher performing PCPs and specialists tier 1, $0 cost share. Everybody else a higher cost share, $50 or $75. We did get a little bit more uptake in year 2, and we do a lot better with sort of new employees and that type of thing. It's not quite as effective from a savings standpoint, right? Because you don't have the primary care management component. Folks can go straight to specialists and other things. It also doesn't tier, hospitals or facilities, so that's completely open and without the primary care referral requirement. There's nobody to stop folks from going to the most expensive hospital over the efficient, high quality hospital.
Interesting. Even such a large employer is still, we got to change the environment for the whole community. It sounds like. Anything further, Commissioner Mays or Director Gifford?
No, Ted.
Okay. With that, I think we're coming to the end of our program. I do want to say thank you to Josh Wojcik from the Office of the State Comptroller and Katie Goodixson, Senior Health Policy Researcher at the UC Hastings College of Law. Thanks so much, Katie. We appreciate you coming in from the West Coast to help us with this. And you've been a resource for us in the past, and I appreciate your availability on that. We'll certainly be reaching out to continue the relationship. So thank you, Katie. So with that, I think it brings us up to the wrap-up portion, and I would invite Commissioner Mays to kick that off. Please go ahead, sir.
Thank you, Ted. Today's discussion was so very informative. It's provided, certainly for me, critically important information on the next steps we need to contain the increases in the healthcare costs and the resulting insurance premiums for consumers. Now, Katie and Josh, who I'm hoping are still here, I want to thank you. And I want to thank all of the experts and the representatives here today, and the co-chairs and members of the Insurance and Real Estate Committee for their work on behalf of their constituents and all consumers in Connecticut. As you have seen, we may not all agree on the solution, but we all do know there is a problem that all of us must work to address. We have a healthcare system that, at its best, it provides outcomes like no other. But what we need to do is to ensure that it does operate at its best for all of us, that access to quality, affordable health care is available to everyone in Connecticut. I want to thank you to my honorable colleagues who have been working collectively to make a better future and who shared the moderating duties today. Thank you, Ted Doolittle, and thank you, Deirdre Gifford. I look forward to continuing this work with you on making real changes to address the rising costs. It has been a privilege. Commissioner Gifford, would you like to say a few words?
Thank you, Commissioner. And I will echo your thanks to the team at CID who worked very hard in putting today's program together, our colleagues at OHA, and our legislative colleagues. Thank you so much for your participation today, for moderating this afternoon's really informative panel. And we look forward to working together this session on solutions. I learned a lot today, Commissioner Mays, as you stated, and what I was struck by in listening to our guests today was really the consensus on what the solutions need to be. And I would point first to the idea that we need to do lots of different things at the same time. And I forget who it was who said in the very first session that there's no silver bullet. And we have an enormously complicated healthcare payment system and healthcare delivery system, and we're going to need multiple different strategies in order to tackle cost and affordability. I was also struck by the consensus among all the different parties that we need to do better on the part of patients and consumers, that this unaffordability crisis that we find ourselves in is not an acceptable situation for Connecticut, and that we all need to work together. Also struck by the fact that I think what was clear today is that everybody has a part to play in the solutions. As I mentioned in my introductory remarks this morning, this is not just an insurer's problem. This is not just a hospital problem. It's not just a doctor problem. It's not just a pharma problem. It's everybody needs to get in the boat and start rowing in the same direction. And I really look forward to, in my new role at the Office of Healthcare Strategies, Office of Health Strategy, not healthcare, Office of Health Strategy, working together with all of the parties and listening to you as you bring solutions and working with you as we come up with collaborative strategies to address this problem. But one thing, the last thing I'll note in terms of the consensus from today is that every single party almost said doing nothing is not an option. And so we've all got to acknowledge that the status quo is really no longer sustainable. And now is the time to tackle these really challenging problems. The good news is that we heard a lot of viable solutions. Connecticut has an opportunity to be a leader, but there are other states that have moved forward on a lot of these solutions that we can learn from. So thanks to my colleagues, and look forward to this session and the rest of the year.
Thank you so much. I appreciate your remarks, Director Gifford and Commissioner Mays as well. It's been a privilege to work with CID and everybody on this program, and I appreciate it very much. And in particular, I commend Commissioner Mays for reaching out to me and suggesting this in the summer. It's a real leadership position that you place the insurance department in, and you're to be commended for that. And I want to thank you for it. I was, as was Director Gifford, I was a deputy director of one of the centers at CMS. I was a deputy director of the Center for Program Integrity, which is the anti-fraud division. And I became focused on healthcare spending. And of course, when you're an anti-fraud guy, you think it's due to fraud. I realized that it's not. I mean, the fraud is a huge problem, but I came to, through the scholarship that I started reviewing, understand that the United States doesn't use more, there's not more procedures here than in Germany. It's just that it costs half as much in Germany. So why is that? Was struck by the remark by Jeff Hogan, who was a teacher of mine on healthcare matters, and Steve Schutzer as well, Steve once told me that it takes about 17 years from the time that a new evidence-based treatment comes to pass to when it's finally accepted and widely used. And the seminal article in this field is called "It's the Price is Stupid" by a since deceased professor Uwe Reinhardt of Princeton, who pointed out in 2003 that the driver here was the actual prices. And now we are 17 years past that, if you want to take out 3 years of the COVID, and now we're starting to see it take place on the ground. So it's good to be part of that. I will echo Director Gifford's comments about being really struck by the convergence, some of the ideas. I don't think that convergence would have existed had we held this a couple or 3 years ago. I noticed a lot of folks, and we gave people, with the exception of Kurt Barwis, who we asked to address a specific issue, we gave people the control to, come to us with what you feel is important. And so some of the speakers were apologizing for the overlap. I welcome the overlap, right? It shows convergence, and it's instructive to policymakers to understand that things like the out-of-network pricing caps is now really accepted by a variety of experts. Public option, which, the politics on that are different, but it was also refreshing to me to hear the talk around the enhanced rate review as a strategy that should be considered. So it was just really good to see that convergence. And again, to echo Commissioner Gifford, as well as Commissioner Mays, this is a community problem. This is a problem for all of us, and we're not going to solve it without a community solution. Everybody's got to come to the table, and we've all got to work together. Not everybody's going to be happy. There's going to be some pretty tough push and pull here, because money's at stake, jobs are at stake, people's family lives and livelihoods are at stake. But it is the prices, right? And we are in that moment that Jeff Hogan mentioned. He mentioned this was a pre-revolutionary France moment, and now we're in the ability to make that change. I'm looking forward to working with the carriers, the providers, my colleagues in state government, on the executive side, as well as the legislative branch, and I again commend the leaders who brought this into being, and look forward to continuing to work with all of you. I do once again want to thank Justin. I want to thank Jim. I want to thank Adam on my staff, and all the folks who did the logistics to make this happen. If there's nothing further from my co-moderators, we'll wrap things up, and thank everybody for your time.